Charu ma'am, we are live now.
Can we start or wait?
Alpesh sir, MC Patel sir. Take me, sir.
Hi, good morning. Can anybody get in touch with MC Patel and all? Because I need to go.
Yes, ma'am.
It's
Mr. Vasu is
10,
calling.
7 minutes past 10.
Yes, ma'am. Mr. Vasu is calling. Dr. MC Patel.
Ashwat sir, we can start the program. No worry.
Okay.
I mean, they should be there, na, if they've organized.
Exactly.
No, they were here, madam. Just 10 minutes back. Here. Somewhere.
Rahul, you can start.
Okay, sir, I'm sharing the screen.
Okay. So, good morning, everyone. I am Dr. Shashwat Jani, one of the convener of this high-risk pregnancy webinar. This is a unique webinar, a whole day webinar. Actually, it's a so-called web conference for the whole day that is being organized by Dr. MC Patel sir and Dr. Alpesh Gandhi. We all know that the high-risk pregnancy is nowadays a very unique subject, and we need lots and lots of improvement in the treatment part and everything, diagnosis and treatment. So it's a very modern subject with all the latest innovations. And for this, I'm thankful to Dr. MC Patel and Dr. Alpesh Gandhi sir for organizing us webinar on high-risk pregnancy topic. So let us start with the Saraswati Vanna. I request Mr. Rahul to start Saraswati Vanna.
ज्ञानदायिनी अम्ब विमलमती
Thank you, Mr. Rahul, for Saraswati vandana. Now I invite my two co-conveners, Dr. Charu Mittal and Dr. Sangeeta. Welcome, Dr. Charu and Dr. Sangeeta. Okay, so now we are starting with the inauguration part, and for that I would like to invite our organizing chairperson, Dr. MC Patel, sir.
Thank you, Dr. Saraswati. Am I audible?
Yes, sir. Yes, sir.
Yes. So it gives me immense pleasure to welcome you all to this great webcon. We are going to discuss on high-risk pregnancy cases, which we are facing in our day-to-day life. And for that, Dr. Jaideep Malhotra has kindly consented to be chief guest to bless the webinar. I welcome Dr. Jaideep Malhotra. She is always with me in any of my academic activity. Welcome, Dr. Jaideep. I also welcome Dr. Jyoti Bindal, madam. She has also kindly consented to be guest of honor to bless the webinar. As far as these high-risk pregnancy cases are concerned, we know in our day-to-day practice, we come across this type of cases at any time. Hypertensive disorders in pregnancy, GDM, renal disease, liver disorders, and so many problems with high-risk pregnancy cases are there. And if we fail to manage them properly, these are the potential cases as far as litigation part is concerned. So we have to face so many consequences if at all something goes with this type of cases. And when we are dealing with this type of cases, it is expected from patient party, and in a wider perspective, I say by law also, that we have to manage that very patient in that very given situation, way in which any prudent gynecologist would have managed. So not to end up into this type of problem in future, litigation or any social events related to managing this high-risk pregnancy cases and something goes wrong, we have come up with so many good topics which are prevailing in our day-to-day practice, and we have invited learned faculty who are much more legend in their respective field. So without wasting much of your time, inviting you, welcoming you, all the delegates who have joined this webinar. Thank you very much.
Thank you so much, MC Patel, sir. We all know MC Patel, sir, has, but three things I would like to say to all about MC Patel, sir. That he has collected more than 21,000 eyes whenever he gets called for eye donation. That is very unique thing. He is organizing and going for health checkup camp every year since last 21 years to unreached people of Northeast, the farthest part of the India. And he stayed there for 1 month. And he has helped more than 300 Foxians medico-legally in crisis, free of charge till now. So, thank you, MC Patel, sir. And now thank you so much, sir. And now I would like to invite our scientific chairperson, Dr. Alpesh Gandhi, sir.
Hello.
Yes, sir. You are audible, sir.
Yeah. Good morning. Thank you very much, Saraswati and MC Patel for giving me this opportunity. My high regards to our guest of honors, Dr. Jaideep Malhotra and Dr. Jyoti Bindal, madam. My high regards to all the esteemed learned faculties, chairpersons, and all the delegates. For our country, we all know that SDG goal is 70-67 by 2030, and nearly 10 states have already achieved the SDG goal. And we can say now it is on auto mode. We are definitely going to achieve our SDG goal. But at the women's care stakeholders, we should look further. Now our goal is to achieve MMR equal to Western world, that is below 20. And for that, we need to identify each and every high-risk pregnancy. We need to provide them the infrastructure, and we need to update our knowledge, and we need to follow them till the safe delivery. And this web conference, the unique conference, focus conference on high-risk pregnancy. I hope this will benefit a lot to all of us. With this, my best wishes for the success of this webinar. Thank you very much, Saraswati.
Thank you so much, Dr. Alpesh sir. You have worked so hard for this high-risk pregnancy topic since many years. You are working on it, and your motto is always there to manage high-risk pregnancy, and you have written books, many books on this topic. Thank you so much, Alpesh sir. Now I request our guest of honor, Dr. Jaideep Malhotra, madam, to say a few words.
Thank you, Shashwat. Thank you so much, and a very good morning to all of you. At the outset, my heartiest congratulations to MC and Alpesh for dishing out a wonderful, wonderful conference with a lot of very, very important topics. I would definitely like to draw your attention to a very recent study which was published in the Journal of Global Health by researchers from ICMR, which was published in February only this year, and which actually published, from the National Institute of Research and Reproductive and Child Health on high-risk pregnancies in India. Now, if I go by it, the numbers are alarming, which this report in this year says that 49% of our pregnancies in India are actually high-risk pregnancies. And approximately about 33% of the women have actually had one single high-risk factor, and about 16% of them had multiple high-risk factors. Now, this is a huge, huge number. And if we go by the states, again, the states also, in fact, I am working with the Meghalaya government right now on, making some guidelines on how to go about managing these pregnancies, because the terrain is very, very difficult there. But there's so much regional disparity in our country, like Meghalaya, Manipur, Mizoram, Telangana, they all have very, very high, prevalence of high-risk pregnancies, and also, lot of maternal mortality is there. Now, there may be a lot of factors which are contributory, and believe me, the government of India also has dished out many programs. There are so many of these yojanas which have come up, but none of them will be successful if we who are going to carry out all those are not committed to them. Now, that is something which is very important. And then uniform practices are very important. So that is where the importance of this wonderful webinar conference comes into place. Because today, I believe we are going to really discuss some of the very, very important and enlightening topics. And the speakers are also fantastic. Because if we provide all these uniform services in a proper way, I'm sure the path of a decline in maternal mortality and morbidity, and even in neonatal mortality and morbidity, even infant mortality and morbidity, we are on the decline, but we'll definitely achieve it much, much faster. So congratulations to each one of you. Alpesh, you've done a great job. Keep on inspiring people, the way you have already done, and all the best to you, MC, for all your endeavors. I know that you have gone to the Northeast, stayed there, served the people there. And this is something which is a very, very heartwarming work which you have done. So keep on doing the good work, and all the best in your future endeavors. Thank you for calling me.
Thank you. Thank you, Dr. Jaideep. Of course, you are always with me in any of my academic activity. Thank you for sparing time to bless the webinar. Thank you. Thank you very much.
Thank you.
Dr. Jaideep, you are nice. Dr. Jaideep, you have rightly brought this, that in India, it's now government's official data that 50% pregnancies are having high risk factors. So 50% pregnancy is high risk. At the same time, our motto now should be not only to improve the maternal mortality, but also morbidity. So many near miss cases are there, and we need to prevent all of them, and to see that they all are having
something for you.
They all have safe obstetric outcome. Thank you very much, Dr. Jaideep.
Thank you.
Thank you so much. Hello. Dr. Jyoti Pindar madam is.
No.
Okay. So now I request Dr. MC Patel sir to say what of things. Then we will start with the scientific sessions. Dr. MC Patel sir.
Dr. Saraswati, you can go ahead.
Okay, sir. Okay.
Already
so,
MC is conveyed. Huh?
Yeah. Okay. So now we are our inauguration part is over, and we are heading over towards our scientific session. So we are starting with our session 1, that is on the miscellaneous topic. And for that, I would like to invite a session coordinator, my friend Dr. Kirtan Vyas and Dr. Suyogya Panath.
Yes. Thank you very much, Saraswati. Yes, thank you. Yes, Dr. Suyogya, ma'am, please go ahead.
Yeah. A very warm welcome to all the faculties and delegates for this Maitri National Webinar. And it's a web conference on high-risk pregnancy and best practices. After the inauguration and the welcome address, we proceed with the session 1, which includes 3 topics: combating severe anemia in pregnancy by Dr. Tirupati, managing molar pregnancy, a pathway of safe outcome by Dr. Binu Pushpa, and the third talk will be addressing postpartum psychosis, breaching the silence by Dr. B.S. Jodha. Dr. Gadappa sir is unable to join due to some unavoidable problem, and he has sent his apologies. So we would like to start with the first session. The first talk will be by Dr. Tirupati sir on combating severe anemia in pregnancy. And for this session, we have 3 chairpersons. May I invite the chairpersons for this talk? Dr. Leela Joshi madam, she here. Dr. Chandan Haparia madam. Yes. May I have the slides? And Dr. Jani sir. Jani sir. Can I have the slides? Yes. Dr. Leela Joshi madam. It's my proud privilege to introduce Padma Shri Dr. Leela Joshi madam, who has retired as the Chief Medical Director from the Indian Railways, Assam, and settled in Ratlam with a mission to reduce maternal mortality by eradicating anemia in tribal, rural, and underprivileged section of the society. Ratlam is a tribal majority district of MP, and she is continuing it for the last 24 to 25 years and still continuing at the age of 85 plus. Taking advantage of her transferable job all over India, she started 3 Foxy branches at different places. They are Kota, Dehradun, and Ratlam, and she has innumerable honors and awards to her credit. Some of them are 100 Women Achiever, Women Pride Award, Pride of Foxy, Devi Award, and Vishwa Seva Ratna Award. And one of the highest honor, that is the Padma Shri, and she is very well known as the Mother Teresa of this region. So it's my proud privilege, and I would like to ask her to chair the first session, and the first talk will be by Dr. Tirupati sir. Our next chairperson, Dr. Chandan Haparia madam. May I have her slide?
Rahul, Dr. Chandan ma'am ka CV.
Yes, sir.
Next slide.
Yeah, I can introduce. Yeah, okay. So Dr. Chandan madam, she was the ex-president of State Obstetrics and Gynecology Association in 2017 to 2020. ex-president of Isopark Indore from 2017 to 22, vice chairman AICOG 22 Indore. She was the founder president of IMS Indore. She has received Dr. S.K. Mukherjee Award in 2017, organizing chairman of Yuva Foxy Zonal Conference and ISOPARK Zonal Conference. She has organized several state conferences and she has special expertise in high-risk pregnancy and vaginal surgery. I welcome Madam to this webinar.
Thank you.
Our third chairperson is Dr. Dani sir. May I have his CV? Yeah. Dr. Saurabh Dani sir, he was this one. He has done his MBBS from Krishna Institute of Medical Sciences, Karad, and DJU from the Nauroji Wadia Hospital, Parel, Mumbai. And he has done FCPS and he has done his from to see his. He has a vast experience. Slide is moving actually. I'm going to see it properly. He has a Center of Preventive Medicine and he is a coordinator of strategic leads and development of Everheal practicing surgeon and consultant of obstetrics and gynecology since 2003. He is having special interest in high-risk pregnancy and emergency obstetrics. He has been invited to speak on various health-related topics by funds, IMM, Capgemini, and he has a membership from the from various associations like FOXY, MOGA of the Gynecologists Mumbai, Indian Society of Prenatal Diagnosis and Therapy, Kandivali Medical Association. I welcome sir for this unique webinar and web conference. Welcome sir. And now I hand over to Dr. Leela Joshi madam to introduce Dr. Tirupati sir and to begin with the first talk.
Thank you so much, Suyoga, for very kind introduction. Now we are starting with the scientific session, and the first topic of the session is about anemia in pregnancy, and the speaker is Dr. Sesha Sai from Tirupati, and he is ex-army person and was a secretary for a long time. Local society. He was president of Chittoor Society, and he's a recognized laparoscopic surgeon and laparoscopic teacher for many institutions, many government institutions, including medical college. The most important part of her CV, what I find is that his motto is to serve and love. It is wonderful. I think without wasting much time, we start what the topic on anemia in pregnancy, combating anemia in pregnancy. So Dr. Sesha Sai, please, over to you.
Thank you, ma'am. Good afternoon. Good morning to everyone. I really thanking Dr. Patel sir who gave the opportunity for me this one. And anemia, why we selected is, as in the OPD, we will be seeing 200 and 300 patients at a time. We will be asking them to sit in front of the OPD chamber and we will ask them to show how they can identify anemia. So if opposite person is showing their tongue, they are able to identify that anemia is so easily can be identified by even patient. They say the tongue is color is pale because they are very good in matching dresses. So here also they are telling who is anemic, who is not anemic. And they are bringing their neighbors to bring there. And another thing, the ICDS project is giving such a food, nutritious diet, except green leafy vegetables. And because of the taboos, the patients are not swallowing the iron tablets. So we are seeing, in spite of good nutritious diet, anemia is prevalent. In OPD, nearly 40 to 50% patients we are seeing. Please show this one. So one of the
Shashi Sai sir, can you put it in presentation mode?
yeah, or whether you can put
No, sir. Just enable editing. Just you can click on
Yes.
in the top of the slide. Yes, perfect.
whether you can see.
Perfect, sir.
So there are so many definitions, so many methods in each country. They are telling everything as anemia. In India, they are telling ICMR as less than 10 grams, but normal is hemoglobin 12 grams in ladies and 13 grams deciliter in men. So what RBC indices which we are seeing is MCV, MCH, MCHC, and the red cell distribution width index. These are the most important what we are seeing. Despite having a set of peculiar symptoms and signs, anemia is not a disease per se. We can call it as a syndrome, as it may arise from an extensive list of causative which are causing. It is a chronic syndrome of highest prevalence in clinical medicine, and in obstetrics also, iron deficiency is the most dangerously we are seeing. And if you take the etiology as the red cell morphology, if you count and see the indices, maybe inadequate response or adequate response, we can say. Then hypochromic microcytic, that is more prevalent what we are seeing, and normochromic, normocytic, and macrocytic. So adequate response we are seeing when there is blood loss or hemolytic disorders. So as per the etiology, we can say the anemia like this, inadequate and adequate response. And what are the symptoms of anemia? What we are seeing is most common is malaise, weakness, fatigue, breathlessness, and unable to walk, palpitation, and angina. They will have pica, that is desire to eat sand and clay, and menorrhagia in peri-reproductive age group. Even in the adolescents also we are seeing because of abnormal HPO system. So symptoms when you are seeing an anemia, the central nervous system, the heart and muscle mass of the most affected organs, they are the one that most need oxygen for their function. So in pregnancy, the volume is increased, hemodialysis is there, iron deficiency which causes more prevalent, and the oxygen requirement is reduced. As the symptoms increases with physical activity, they will require frequent rest to stabilize themselves and require more oxygen to do day-to-day work. And when, if you see that as per the HP levels 9 to 11 or 6 to 11 or less than 6 or 3.5. Actually, heart failure is impending and activity is unfeasible when there is 3.5 grams HP. Some of the times we are seeing multi-gravida with very low HP, and they will have 5 to 6, and each pregnancy they are seeing within 1.5 year or 1 year, 1.5 year or 1 year, 2 months differences between each child. So the anemia, which is causes in the beginning, it will be irritability, headache, psychic asthenia. Whereas hemoglobin 6 to 9, there will be tachycardia, dyspnea, fatigue. With hemoglobin less than 6, the sedentary activity also causes breathlessness. So these are the different types of concentrations and the denominators what we are mentioning in the HB concentration, hematocrit, MCV, MCH, and red cell size variability, RBC count, WBC count, platelet count, and reticulocyte count. So each will have its own definitions, MCV, MCH, MCHC, and the measurements with method of calculation we are showing here. And different types of cells of RBC we are seeing. Anocytosis, dimorphic blood film, holy jelly bodies, and these are present, but significance is comparatively less than this one. And hyposplenism, macrocytosis, or erythroblast, which we have nucleated red cell precursors, which are then there are hypersegmented neutrophils, neutrophils with 6 or more lobes, means vitamin B12 or folate deficiency. So iron, vitamin B12, folate deficiency, which is causing as a high risk pregnancy in 90% of the patients, what we are seeing. And hypochromia, the pale red cells, because when the depot is exhausted, the iron is deficient, then existing iron is adjusted with every cell. So it causes pale red and small cells, so microcytosis. We are seeing that one. When gradually improving, once the depot is saturated, iron depots, then after that only the hypochromia is controlled and uniformly the cell size, color, shape, everything is seen. So some of the microangiopathy that also causes reticulocytosis, and there may be different types of films and reticulocyte count usually we are seeing. And when we start the iron therapy, within 10 days, 15 days, the cheeks will be the pink color flashes, we are seeing that one. And on examination on 10th and 14th day, the reticulocyte count increase, that shows the improvement of the condition. And sometimes the relax formation, the RBC will be seen in the peripheral smear, and some cystocytes, spherocytes, sickle cells, crescent shape, or target cells also seen in peripheral smear. So Rolex formation is common. Some connective tissue disorders and ESR also increased. Infections, inflammations that are seen in cancers. In this diagnosis, probably multiple myeloma as a plasma cell can be seen in a film. So our aim is to have a complete idea of anemia and identification type of anemia. Though the microcytic hyperchromic is more common, we should not miss other types of anemia. So erythroblast with a nucleated cells, we are seeing in stress conditions. And small pale red cells are microcytic. Normal cells also seen. That shows recently the blood transfusion was done. The normal RBC and the microcytic anemia, that is also coexisting, that can be seen. And anemia, how to diagnose this? That is one of the most important. Blood test to detect various components of blood carried out proper diagnosis. RBC normal or decreased. Peripheral blood smear shows pale small cells. WBC count may be normal or decreased. So anemia can be either chronic or acute. Acute sudden blood loss 10 to 20% in accidents, in APH, in PPH, in placenta previa, in obstetrical hemorrhages. So hypertension, dizziness, and faint. This is one. And 20% causes tachycardia, cold extremities, extreme paleness, hypotension, and shock. And 30% is very dangerous and require immediate intravenous fluids, and rapidly we have to give multiple transfusions also we have to plan. In case of chronic anemia, no decrease in blood volume, but it's compensated by increase in plasma volume. So RBC concentration is reduced, and we can supplement with iron and routine therapy, and chronic heart failure management will help us in this chronic anemia. So based on MCV, microcytic anemia, normocytic anemia, macrocytic anemia, we can classify these into 3 anemias. And based on underlying process, blood loss because of deficiency nutrients, the ICDS project, which they are giving everything except green leafy vegetables, which is causing deficiency of iron, hemolysis, and failure of production in case of cancer or malignancies in cancer cervix and other conditions with pregnancy, with high risk pregnancies. And we have to determine the MCV, the mean capsule volume. It increases anormocytic when it is MCV is normal. So anemia classification, there may be thalassemia, sideroblastic anemia, iron deficiency anemia, most common, and there may be folate and vitamin B12 deficiency. And we have to see the MCV is 125 deciliter. In some cases, macrocytic is related to myelodysplastic syndrome prior to or after chemotherapy. So nowadays, pure red cell aplasia, anemia, chronic disease, hemolytic anemia, and recent blood loss, these are the things what we have to take the history properly and previous records. So when there is MCV, if you see that one, whether it is microcytic or normocytic or macrocytic. And iron deficiency anemia using serum iron and transferrin. Ferritin is unclear. Marrow as last resort, we are seeing that one. Iron deficiency, iron normal. So clinically inquiry for blood loss in case of sudden deficiency. And hemoglobinopathies, we have to exclude. Anemia, chronic diseases that is usually seen. In normocytic also, we are seeing that one. Reticulocyte, marrow failure, if it is low, high, look for blood loss or hemolysis. And if it is macrocytosis, B12 RBC deficiency, and we have to see the obvious cause which is causing, and we have to concentrate on bone marrow for the further management. So microcytic anemia, that is iron deficiency. And some cases, thalassemia also seen, sideroblastic anemia, anemia of chronic diseases, severe microcytic anemia, less than 70 deciliter is caused mainly by iron deficiency or thalassemia. So chronic inflammatory diseases which causes by infection, collagen vascular diseases, inflammatory bowel diseases, and some recent blood loss, melena, hematemesis, and malignancy, marrow infiltration, chronic renal failure, and transient erythroblastopenia of childhood, or marrow aplasia or hypoplasia. And most commonly with HIV, we are seeing anemia infections, HIV infections causing anemia, hemophagocytic syndrome. That is also some of the conditions we are rarely seeing, but HIV we are seeing nowadays. Once in a week also we are seeing a case. So megaloblastic anemia, vitamin B12 deficiency, that is pernicious anemia or malabsorption. And folate deficiency that causes malnutrition, malabsorption, chronic hemolysis. And she might be taking for epilepsy, phenytoin or sulfa drugs. Or there may be chronic hemolysis. Myelodysplastic syndrome, marrow failure, aplastic anemia, chronic liver disease also can cause megaloblastic anemia. And nowadays, we are seeing more cases of hypothyroidism with megaloblastic anemia. So microcytic anemia may be the result of megaloblastic or non-megaloblastic causes, and folate deficiency can in turn be due to either reduced intake or diminished absorption. Though we are advising prenatally to take folate, but most of the patients they are taking on 3rd or 4th month, and many times they are coming with deficiency. And another thing is diminished absorption. So severe macrocytic anemia is almost always megaloblastic. So another is erythrocytes, which are less produced, under production. Some kind of chronic diseases, what we are seeing, such as marrow failure and renal failure also causes erythropoietin less. So underproduction of erythrocytes that is causing, and loss or destruction of erythrocytes due to hemolysis, acute blood loss. And the cause of normocytic anemia includes aplastic anemia, bone marrow replacement, pure red cell aplasia, anemia of chronic disease, hemolytic anemia, recent blood loss. Maybe patient comes with other bookworm infestations are melena, anemia, or occult blood. A number of anemias have a generic etiology. Examples such as inherited disorders, that is hereditary spherocytosis, sickle cell trait, anemia, and thalassemia. So, hemolytic disorders, when we discussed the hemoglobinopathies, different types are there. Angioimopathies, because of deficiencies which are creating membranopathies, hereditary spherocytosis, elliptocytosis, and extrinsic factors, that is DAC, TTP, HES, which are commonly we are seeing and struggling when we are treating a DAC case. And immune hemolytic anemia.
Sir, may I interrupt a minute?
Please, please.
Sir, we need to hurry up actually. So.
Okay, madam. And iron deficiency with or without blood loss, 6 months in term. And nutritional, that is also they are not giving, and drugs which are causes anemia. Malabsorption syndromes, infections, hookworm, and other infestations that are seen. And patient physical examination may be fever, jaundice, petechial purpura, hypertension, hepatosplenomegaly, growth failure, examination of stools, blood, occult, that gives an idea. And skin changes, and head, frontal bossing, mouth, glassitis, pigmentations. These are anemia findings we are seeing. Physical findings, absent of Fanconi syndrome, each one will have its own importance. And there may be MCV, which we discussed just now. Laboratory findings, we have to see the hematology, biochemistry, serology, urine analysis, stool exam, endoscopy, and images of ultrasound, skeletal radiography, and tissue biopsy, lymph node biopsy, skin, liver biopsy, sometimes will help us in laboratory evolution of anemia. And microcytic, which is more common with serum iron low, ferritin low, marrow iron low, HbA2 will be normal, and RDW will be high, MCP will be 13 or less than 13. So you can differentiate iron deficiency, thalassemia minor, and other diseases, chronic diseases. So anemia treatment, specific treatment for disorders causing anemia, replacement of missing factors, iron, vitamin B12, folate, and transfusions are needed in case requirements. Blood transfusion usually needed as acute blood loss, and problems of blood transfusion also some of the problems we are seeing. Iron deficiency with iron supplementation orally 10 to 20 milligrams is helping us. And in case of women on menstruation, pregnancy, parturition, and lactation, we have to supplement the iron. And iron deficiency, when it is less than 10, when it is very low, it is causing more. And as per the low income in India, 60% of the patients, they are coming with iron deficiency anemia. The replacement of iron is complicated by the fact that only 5 to 10% of the iron, 10 to 20 milligrams iron is absorbed per day in the diet. So we have to supplement the iron regularly and to prevent the iron deficiency anemia. Iron deficiency anemia, still there may be so many things we have to think. Iron binding capacity and other things, if it is possible, we have to check and we have to treat. Iron deficiency anemia treatment, correction of iron deficiency, replenish iron stores, oral iron administration, parenteral iron may be needed, and treat the underlying cause. And chronic diseases we have to identify and we have to treat. Hemolysis, if it is there, we have to calculate the raised reticulocyte count and diminish serum heptoglobin concentration. That gives an idea. And hemolysis, we can do direct Coombs-Stills and other methods we can identify. And the causes we have to identify, we have to treat the cause. Lead poisoning and thalassemia major, thalassemia minor, and other conditions also we can treat by proper investigation and management. And the complications also we have to treat. And cirrhosis and liver failure, these are the things which may cause them. And these are the laboratory findings which we are suggesting diagnosis of thalassemia. And therapy, red cell transfusion, chelation, splenectomy, folic acid, and penicillin prophylaxis, pneumococcal HIB vaccine, cholecystectomy, bone marrow transplantation, and genetic counseling. Sickle cell also we have to identify and we have to treat. So as per the clinical features, we have to treat the condition, and therapy of anemia is usually chronic or compared blood transfusion to improve the oxygenation, splenic circulation, other things also to see. Main is give blood transfusion and more marrow transplantation. And there is G6 deficiency, G6PD deficiency, that is also one of the cause which we are seeing. And if the patient comes with severe anemia, with heart failure, direct only iron supplement of PC fat cell volume is not adequate. We have to supplement with diuretics, usually Lasix, and support with metoprolol, beta blocker, the heart function, and valsartan to improve the strengthening. And sodium loss we have to encourage, and by depeclofrogen, which we are doing in severe 2 grams, 3 grams HP before giving the fat cell volume. We'll treat this condition. Once patient is stabilized, then we are giving PCV. Then also we are seeing edema feet and overload on the heart. So again, we have to go this therapy to improve their condition. And these are the references. I thank everyone who gave the opportunity, because anemia is one. We should not exclude only iron deficiency anemia. We have to think of everything. Then we can treat the condition. We should not miss any condition of anemia. Thank you very much.
Thank you, sir.
Thank you. Thank you, Dr. Sesha Sai, for
Thank you, madam.
For anemia, for giving the information about anemia in general. But our concern is, what I feel, our concern is that in spite of so much advances in the knowledge, in the management of severe anemia with iron sucrose and with single dose iron, the cases of anemia, the prevalence of anemia is increasing. That is the report of National Family Health Survey also, that in about 6, 7, 8 states the anemia has increased. And for this, I think I will give few words my field experiences for anemia. There was a camp. We go to the tribals. The reason is that most of our huge population cannot reach to the available facilities, and there was a camp, and we get this sort of a cases very frequent, that a woman was standing in the queue for registration, and I saw, and with a red district chunni, I felt something, and I called for her. I saw she was a full-term pregnancy, and hemoglobin, I got it done. It was only 4 point something. I called for the field workers, the Asha Karyakarta. Why it is so? Were you not visiting her? She said, I was visiting her every time. So many times I had gone, but she was not taking pills and all that. So what I feel, that our field workers should be well trained. They should know what is the consequences of anemia when they'll not take this thing, because they are reluctant, they are not well motivated, they are not well trained. Many times I see that even in the government health units, nurses are giving IV iron very slow with the fear of reaction. So this is the implementation of government policies, and we must see, because the huge number, because it is not reducing in spite of our so many efforts, advances in the technique, advances in the, it is this thing that the huge population is not able to reach to the available facilities. So I think we must think of something to tackle with this unreachable population. And I think that only can reduce, because those who reach to us, they will be taken care of the way it is needed. So thank you so much. But I feel that this point should be very, very seriously taken care of. How our patients, really needy patient, can avail the available facilities. I think that is very important point. Thank you so much. Thank you. Thank you very much.
Thank you, ma'am. Point well taken. And now, to proceed for the further session, I hand over to Dr. Kirtan Vyas sir to begin with the second
Thank
part
you.
of the
Thank you,
session.
madam. May I invite now Dr. Saurabh Dani sir, our next chairperson, second chairperson, to go ahead with the second talk by Dr. Binu Kushwaha, madam. The talk is upon molar pregnancy.
Yeah, good morning, Kirtan, and welcome, Dr. Binu Singh. So, Dr. Binu Singh has been an leader par excellence from our very initial.
Sir, your voice is not heard properly.
You can't hear me, or it's not heard properly. Is this better now?
Yes, better, sir. Better, sir.
Okay, fine. So, Dr. Binu Singh has been an excellent performer from a very early days. So, as you see the PPT on the screen, she has, from MBBS days right up till current, she has always been awarded and given a lot of accolades during her lifetime of work. And she has been very active in the academic circles and the gynecological societies as well. And with that, I would request Dr. Binu to take us further in the topic of molar pregnancy and let us know what she has to share with us and what we can learn and take it forward into our clinical practices. Dr. Binu Singh, over to you.
Thank you for those kind words of introduction. So should I, yeah.
Kindly go ahead with your slide sharing.
Sharing. Yeah. Is it visible?
Not yet, madam. Yes, now visible. Now visible, madam.
Yeah, right. So I'm very, I feel privileged actually to be a part of this mega event.
Your slides are missing, ma'am. Your screen is there, but your slides are not there.
Please open the presentation, Dr. Binu. I think it is showing. It's showing Zoom.
Yes, I've already opened the presentation and shared it also. It's not visible to you?
Now,
I think it's taking time.
Now it will be probably, madam.
It
seems like the network coverage is little slower. It seems like that, madam.
Just a second.
The PowerPoint is opening now.
Again. Is it visible now?
No. So yes, now visible, madam.
Yes.
Now you can please go ahead, madam. Please. Thank you.
Right. So my topic for today is managing molar pregnancy, a pathway to safe outcome. I think this internet connection is not good here.
Ma'am, I suggest you can switch off your video so that your network will be manageable.
Yes, I'll do that. I'll do that. Yeah. So now it's moving. So we all know that molar pregnancy is a subtype of gestational trophoblastic disease, which are the group of tumors specified by the abnormal trophoblastic proliferation. And WHO has classified these GTDs into two broad diseases, and the malignant disease is called as GTN. And molar pregnancy is a part of pre-malignant diseases, which can be of two types, complete and partial. It is commonly known as hydatidiform mole, also as vesicular mole or molar pregnancy. Basically, it is an abnormal condition of the placenta where there is a partly degenerative and partly proliferative changes in the young chorionic villi. It is best regarded as a benign neoplasia of the chorion, but with a malignant potential. If we talk about the epidemiology, it is more common in Oriental countries like Philippines, China, Indonesia, Japan, but it is also found in India, Central and Latin America, and African countries. In Philippines, its incidence is as high as 1 in 18, while in India, its incidence is around 1 in 400. Complete hydatidiform mole is the most common antecedent to the choriocarcinoma. That is why we need to know about this, because it may proceed to choriocarcinoma. But choriocarcinoma can GTDs also like invasive mole. If we talk about the risk factor, it is the extreme of ages, that is less than 21 years and more than 35 years. If the more than 40 years, the risk increases 7.5 to 10 times. Asian women, and if molar pregnancy, the risk increases. There are certain gene mutations also which have been identified as a causative factor, especially for recurrent molar pregnancies. Then some type of blood group like AB and faulty nutrition like lack of folate, beta carotene or protein have also been identified as a risk factor for development of molar pregnancy. Pathology is basically of chorion. It is basically a disease of the chorion. There is a death of the ovum or failure of the embryo to grow, and there are secretions.
Ma'am, Dr. Binu, ma'am.
I think ma'am lost connectivity.
Her internet seems to be little slower one, what I presume.
Yes, sir.
Because the time taken by the computer to get slides open was indicative of that, I believe. So, Mr. Vasu, can you please contact Binu madam right now?
Okay. Give me.
So, Rahul, can we have Dr. Binu madam's slides with you and you can share on behalf of her? Is it possible? So that we can save the time and go ahead with the sessions.
Actually, sir, all slides have with Vasu, sir. So I requested to Vasu, sir, if you have slides, so please can you please share, sir?
Yeah, that would be better because her internet connection is little slower, I believe.
Ma'am, sir, Binu ma'am's not shared slide.
Acha. So can you please request her to share them right now?
I'm just coordinating, sir. Just give me a minute.
Yes. Please do that.
Good morning, Dr. Shweta. I'm just telling I'm joined here, Dr. Girija.
We welcome you, madam.
Yeah.
Welcome, ma'am.
Good morning, ma'am.
I think Dr. Kirtan, since not much has been covered, we can go to the next speaker by the time all this changeover is done.
That would be
Charu,
better.
I'm time.
also. Charu, this is Dr. Jyoti Vindal. I also
Welcome,
join
ma'am.
whenever.
Welcome, ma'am.
We welcome you,
Yeah,
Jyoti,
so
madam.
please.
I'm Dr. Tabassum Dalla.
Yeah, let's go ahead with the third speaker and then we'll
Yes,
again ask
yes.
Dr. Binu to show
May
her
I-
presentation.
Yes. For that, may I request Dr. Chandan Fafriya madam to kindly invite and introduce our third speaker, Dr. B.S. Jodha sir. He is going to speak upon postpartum psychosis.
Okay. Good
Yes,
morning,
Dr.
everyone.
Yes.
Good morning, everyone. Thanks to Dr. M.C. Patel, sir, Dr. Alpesh Gandhi, sir, for giving me this opportunity to start with the first session of this very prestigious conference. Dr. B.S. Jodha is professor, senior professor in the SN Medical College, Jodhpur. His special award in, he has several award and achievements. He's a diploma in the gynecologic surgery. He's a trained in the ultrasonography, ART, fetal medicine, and secretary of the Jodhpur Obstetric Society. Some disturbance. Okay. He is achieved the Marwar. I think I lost the connection.
Madam, fine. You are audible. You are audible, madam. Fine.
But I'm not able to see the screen. Okay. Okay. Now it's available. Now it's available. He's the Marwar Achiever Award in 2015. He's the postgraduate and undergraduate examiner in the various universities in India. He's the paper setter in the University of the Examination, a review editor of the journals. He's a national master trainer of the various government sponsored program. He's the various publication, national and international journal. He has so many innumerable stars on his crown. So I invite Dr. Jodha sir for your talk on the postpartum psychosis. Now screen is yours, sir. Thank you, sir. Thank you again.
Good morning, and I am thanking Dr. Patel and Dr. Gandhi for the same. They're inviting me, but I request Vasu to share my presentation already.
Yes, sir.
Shared to you.
Yes. Just give me a minute.
Okay. Because net problem is here also, so certain issues are there. So I will already sent.
So, Mr. Vasu, that would be better. You only share the slides.
Just give me a minute, sir. I'm just sharing this, sir.
And meanwhile, you also coordinate with Dr. Binu madam also.
Done, sir.
Yes.
Jodha, sir?
Yeah. Yes, sir. This is visible.
Okay. Okay, thank you. Next. May I able to move from my side or okay? So as we know that this problem in our clinical setting is a very tedious problems. When we see such type of patients in our OPDs coming or staying in the hospital and seeing that these patients have some mental issues which are not able to cope up with this, especially in postpartum, immediate postpartum period. And we have faced many situations, challenges in 2-3 cases where the patient is going to jump from the second floor, try to jump. So these are the real issues which we clinically in our practice hospitals. We are working in a medical college hospital where number of deliveries is just 30,000 deliveries in a year. So these cases may come once in a 2 months or so. So in postpartum psychosis, a severe mental illness were characterized by extreme difficulty in responding emotionally to a newborn baby. It can even include thoughts of harming the child. So they may be having some certain issues regarding this that may harm their own babies. It usually represents a bipolar disorder, not just a depressive type of illness. And postpartum psychosis as a psychiatric emergency because of the potential for harm to baby or the new mother. So it is a severe form of mental illness characterized by extreme confusion, loss of touch with reality, paranoia, delusions, hallucination, disorganized thought process, and hallucinations which may cause. Next. So Childbirth is a major physical, emotional, and social stressor in a woman's life. Mood swings and mild depression, post-traumatic stress disorders, major depression, or even full-blown psychosis may be seen in number of cases. Psychological factors, which include physical and hormonal changes, lack of sleep, exhaustion, and the beginning of a new role and commitment in caring for newborn, both physically and emotionally challenging for new mothers. So the risk, which is around 1 to 2 per 1,000 females of childbearing age, within days till first 6 weeks after birth, then we call it as a postpartum, and it is a psychiatric emergency with immediate medical and psychiatric attention and hospitalization if the risk of suicide or filicide exists. Among the etiology, we are not able to feel complex multifactorial origin may be there, and where sometimes these cases we commonly encounter in where there history of bipolar disorders, history of postpartum psychosis in the previous pregnancies, family history of psychosis and bipolar disorder in any siblings or parents, and history of affective disorders or schizophrenia and discontinuation of psychiatric medications during pregnancy, which was controlling all the, so because of certain gastrointestinal problems or the help is not there for such type of patient, then they miss the doses and they may come with this type of situations. So the prevalence is higher in patients suffering from affective disorders like bipolar 1, 2, and first-time pregnancy with a previous family or personal history of bipolar. And adding to this is the lack of sleep, which adds this problem, and hormonal fluctuations, which is rapidly falling levels of estrogen, sleep loss triggering the episodes of mania. So we have to be very supportive attendants and the persons who are there to help such patients that she is able to sleep at least properly to the factors which are risk factors which in the postpartum psychosis which adds to this is which commonly seen in the primipara, discontinuation of mood stabilizers, obstetrical complications which has occurred in form of PPHs or tears or and loss of baby itself may be a compounding factor for that. In perinatal infant mortality, previous bipolar episode, psychosis, family history of postpartum, family history of bipolar, sleep deprivation, increased environmental stress, and lack of partner support. In the history and physical examination, which will tell us in form that this patient is at a high risk of developing such, we should be able to keep an eye on such patient and ask the attendants to have good support for these patients. And history of neuropsychiatric evaluation should be done to consult with the psychiatrist right at the time in the pregnancy itself, and regular follow-up, where the past history of personal family history of psychiatric illness evaluate to rule out the medical comorbidity. Some cases of medical comorbidities which may be mimicking in this type of psychosis like organic causes and complicated obstetric history like preeclampsia, eclampsia, or negative birth outcomes. History of psychiatric medications or medicines withdrawn in the pregnancy, substance abuse, medication history, and history of any other recent major stressors or traumatic events. So we have to evaluate the patient's social support network, including the role and responsibilities of a partner and other available caregivers. Among the symptoms, which may be acute onset within 2 weeks postpartum, but as early as in the day first, there can be cognitive poor concentration, delirium like impaired sensorium, orientation, and we have to rule out other organic causes which may be there in form of encephalitis, meningitis, or other problems. Then there can be behavioral problems like agitated, hyperactive. If we see these changes in the patient while you are in the rounds, we should be cautious of it. Emotional disturbance or coldness, perplexity. There can be mood which may be in the spectrum of elations, labile, dysphoria, less frequently depressed, Affect may be altered in form of flat or incongruent. Speech may be rambling. Sleep in form of insomnia. There can be changes in the thought processes like mood incongruent delusions, thought broadcasting, ideas of references, infant being harmed or killed, ideas of persecutions, ideas of jealousies, or ideas of being controlled by someone else. So these are the mood congruent delusions or grandiosities may be there. There can be change in thought process, disorganized flight of ideas, perceptions in form of hallucinations, which may be in form of visual, olfactory, or tactile. So if you observe such changes or any complaint from the attendants or the nearby patients, which say we should be cautious that this can be a serious matter for this patient and is an emergency which can go even up to the suicide and homicides. Next. So this is a video. If we are able to show it, it suggests that some of these patients are so, they are trying to beat the child and they are not knowing what they are doing. And this can be so traumatic to babies or even toddlers can be, and the patient may not be knowing what she has done. She's agitated, sometimes she may be depressed or cool and calm. So these problems are being seen in these psychotic patients. So we should be very cautious that this can be the problem in such patients, and we have to keep eye on this group of patients. And in the possible mood disorders, we should be cautious if there are ideas of suicidal thoughts or homicidal thoughts. We should immediately refer to psychiatrist or emergency department and take care of these situations as far as this condition is possible by parental therapies to control these group of patients. If there are no current mania or bipolar disorder, then we can go for the psychiatric evaluation, which may be in the major or minor form of depressive and which may require routine care, and severe form may psychotherapy or antidepressant therapy, which can be given in such group of patients. Or if a psychotic symptoms are there, then consider to be the typical antipsychotic management, mood stabilizers, which may be started as early as from the first trimester in form of antipsychotic drugs, lithium, valproate, carbamazepines, and so on and so forth. Next. But we have to evaluate what is the condition of these patients. We have to exclude certain conditions which may not be a psychotic problems, which can be an organic cause, which is hampering this, and we are labeling this patient that she may be a psychotic. And these situations has erosions sometimes, and patient has been given haloperidol and other olanzapine combination, and we are missing the organic cause for these patients, and sometimes we may lose these patients. So laboratory workup is to exclude all sorts of these causes, which is to be excluded prior to starting antipsychotic therapy for such patients who has been seen first times, which may be a complete blood count, electrolytes imbalances, which may be causing this, or certain types of renal conditions where rise of uremia, which may be urea nitrogen raised, and rise serum creatinine, which may be causing these types of problems. Blood glucose, creatinine, vitamin B12, folate deficiencies. There can be high glucose, like in a diabetic ketoacidosis, which may be missed in such group of patients who has reported late in the end. So this evaluation is very important, and we have to exclude and do these tests, and accordingly we have to manage these, and if needed, do the CT and MRI of brain to exclude the organic problems in like form of meningitis, or which may require CSF evaluations or any hemorrhagic episode which has occurred. Next. So we have to differentiate these patients with the bipolar, which has relapsed unipolar major depressions and schizophrenic patients, which may be there in such group of patients, fever due to these conditions like sepsis, meningitis, encephalitis, may be a substance abuse, hepatic encephalopathy, uremia, B12 deficiency, folic acid deficiency, hypercalcemia. So any type of metabolic and nutritional causes which may be there. So it is very important to have diagnostic facilities and tests to be done prior to starting these therapies. Some certain advanced cases of SLEs, immunological causes which may be there, and the consumption of corticosteroids and antiviral therapies, group of some antibiotics which may be there if they are for prolonged duration, like gentamicin, vancomycin, and isoniazid, certain anticholinergic drugs which may be there, which may be causing certain stimulants like amphetamine and epidurmephalin may be causing the problem. So it is very important to take care of this exclusion of organic and substance abuse in this group of patients. Next. So there are certain conditions which may be a psychosis, but initially postpartum blues may be there, postpartum depression. So most of these patients are in 50 to 85% in the first 2 weeks, there are which may be in form of irritability, anxiety, fluctuating mood, and increased emotional reactivity. It is usually mild and spontaneous, it's not considered psychiatric disorders. In postpartum depression, which may be seen in up to 13% of mothers, in first year postpartum, symptoms may be excessive guilt, anxiety, ecnodynia, depressed mood, insomnia, hypersomnia, suicidal ideation, fatigue, moderate to severe symptoms, prolonged course, may require antidepressant therapies. But in postpartum psychosis, which may be as low as 1 in 1,000 cases, but symptoms may be mixed or in form of these agitations, delusions, hallucinations, disorganized behavior, cognitive impairment, low insight, severe, and this may be in form of emergencies, and hospitalization is must in this group of patients to treat these patients as early as possible to prevent the harm. Next. So in treatment recommendations, hospitalizations versus home care, hospitalization in most cases because of emergency severe conditions, fluctuating course, based decision on risk evaluation, safety issues for patient and infant, and after discharge, visiting nurse are useful to help monitor the mother's condition at home. There should be education for patients himself, family, social support network, address risk to the mother and infant and risk in future pregnancies, and the medications which are required to stabilize the mood, antipsychotic, consider for the mothers the breastfeeding. Then we have to discuss that most of these drugs are circulated in the milk, so we have to keep the pediatricians' vision in these cases, avoiding the sedation to the fetus also. Next. So this is the algorithm where we have to keep it as a medical emergency, involve significant other partners and families, and the drugs which are commonly used in such patients in parenteral therapy for initial 0.5 to 1.5 lorazepam, then antipsychotic in form of haloperidol, olanzapine, and if these patients are not responding, then we may add lithium in consultation with the psychiatrist. And if these patients who are not responding, they may require the ECT in this group of patients to control their hyperactivity and continue lithium, gradually tapering the doses. And for further pregnancies, we have to be cautious in such patients which are having such in the previous episodes. Next. So in the treatment, timely identification of illness, the condition usually has a sudden onset. It is a brief and limited illness with response rapidly to the treatment. Hospitalization is must. Rule out the organic causes first. Antipsychotic medications, antidepressant, which may be as per an ECT, may be required in few group of patients, and we should be having a good consultation with the psychiatrist, psychologist, and other qualified mental health professionals, because these are the conditions where alone obstetrician may be of having problems especially in the private setup where single gynecologist obstetrician is taking care of such patients. Next. So these are the treatment. We have to continue these in form of lithium during pregnancy. For women with the past history of postpartum psychosis, recommendation high therapeutic target levels is to be maintained to avoid this in the current pregnancy. And other forms of therapy like carbamazepine, sodium valproate, short-acting benzodiazepines are relatively safe during breastfeeding, which may be considered in lactating mothers. Next. So we have to keep certain things in mind, that prolonged duration of oxytocin, certain drips are given to prevent PPH in some of these patients, or to initiate the breastfeeding, in that may cause insomnia, such in patients. So it is to be kept in mind that this may cause insomnia, which may precipitate this episode in that. So ECT itself is a therapy recognized as a means to treatment with a tremendous benefit in patients with psychosis related to schizophrenia and schizoaffective disorders, refractory to antipsychotic pharmacotherapy. And it is a safe and effective intervention in patients with acute relapse or exaggeration in the postpartum with the risk of minimal complication. So still there is a place for ECT. Nowadays, a good group of antipsychotic drugs. So, but in the postpartum psychosis, still a ECT may be required in few of the patients. Next. In the prognosis, a single episode of postpartum psychosis will report the patient to another episode with a future pregnancy. Patients with the history of bipolar disorders are at higher risk. Relapse is common, and after pregnancy should be carefully evaluated and counseled regarding the risk in future pregnancy. These are the few points which we have to keep in the mind to tell the patient or attendant or husband to prevent such episodes in future, and preventing the risk to the fetus and mother. Next. So complications are very few but are dangerous. Proper identification of risk remarks should be we have to keep and manage these conditions. Tremendous stress for the partner and to other family members, and suicide or filicide, which may be less, but it is to be kept in mind by the treating doctor and the psychiatrist. Thank you. Thank you very much. The marks that pregnancy leaves in your body are a reminder of the permanent shift in your identity. Thank you. Thank you very much.
Madam, you need to unmute yourself. Dr. Chandan, madam. Dr. Chandan, madam, you are muted, so kindly unmute yourself.
Thank you very much, sir, for your very elaborate presentation. And it was really multifactorial disease, and it is a psychiatric emergency, and it requires tender, loving care of the obstetrician, respectful mother care, maternal care. It requires support and tender, loving care of the patient and their family members and their partner. So thank you very much for the very good talk. Thank you, Dr. MC Patel sir. Once again, Dr. Alpesh Gandhi, and all the best wishes for Dr. MC Patel sir for his election for the POXI presidency. All the best, and thank you very much, organizer. Thank you.
Thank you, organizers. Thank you from my side. Thank you.
Yeah, I'll just take a few minutes. We have Dr. Jyoti Bindal ma'am and amongst us, and she's joined us. We would really like to take a few words of blessings from her for this conference. She was busy in the morning, so she's joined now.
Thank you so much.
She's been a guest of honor. Please welcome, ma'am.
Thank you so much.
CV, please show the CV of Dr. Jyoti Bindal ma'am.
Thank you so much, Charu, for having me here. I would like to begin by thanking Dr. M.C. Patel and Dr. Alpesh Gandhi. Friends, nobody else could have thought of such a massive webinar. They've used the word web conference. I wonder even if they realized that there are 65 faculty members involved today of 8 sessions lasting for almost 8 hours. I don't think in recent times we have had, and what a topic they chose, high risk pregnancy summit. And I mean, there's no way I can enumerate all the speakers, but look at the galaxy. Look at people like Binu and Dr. Joda, Dr. Gadappa, and wow, Dr. Seshasai Tirupati. You know, we've started calling him a Pandora box. Sir, can we have this book, digital book? And there he is. He doesn't literally take 5 minutes to give us. Coming from a person like me, who's been a teacher for almost 40 years, and whom I claim that I have one of the biggest library for obstetric books. Even I find him amazing with the kind of storage. And we are going to have Dr. Sanjay Gupta as well today, who's going to be giving us such wonderful oration. Of course, Chamila, Girja, Dr. Chellama, we are always looking forward to your talks. And we do have today Dr. Prakash Math. I don't think in लोगों ने किसी को भी छोड़ा है. Dr. Reena Wani, Dr. Shikhana Seth. We have Dr. Aparna Sharma and Sarita Agarwal, Dr. Poonam Verma and Sarina. Oh wow, we have even Dr. Ritu Joshi and Achanta. And this is a totally new concept which is now coming up, cardio obstetrics. And we have none other than Dr. Manju Puri and Dr. Krishna speaking on that. So I'm so happy to be a part of this. And as I was telling Dr. M.C. Patel, that usually guests of honors are just decoration pieces. They actually add nothing to the value of the webinar, but he was, you know, the magnanimous personality he is. He just wanted me to be a part of it. And sir, so here I am. I'm so thankful to you. And we all wish you all the best in your forthcoming elections. And we do hope that we have many more such successful webinars to come. Thank you so much.
Thank you. Thanks for blessings.
Thank you so much, madam. Thank you so much for your kind words. Is Dr. Binu, your talk, can you finish your talk? Dr. Kirtan?
I have WhatsApp.
Yeah,
I have
Mr. Vasu.
WhatsApp the slides. I have WhatsApp the slides.
Yes, Mr.
Okay.
Vasu, you can just go ahead from this slide sharing from where Dr. Binu madam left previously.
But, sir, give me a minute. Just I have to download the presentation because the last presentation which I am sharing.
Yeah, sure,
Okay.
please.
Just
Till
Mr. Vasu, you can directly jump onto the slide from where she left previously.
a second, sir.
Till then, I take this opportunity to thank everyone who has spared precious time on a Sunday morning to be here. All the respected faculty with their learned knowledge and all ready presentations to share with us on such an important topic. And I'm sure we'll all benefit from all these talks which are being covered throughout the day. Thank you so much to everyone.
Just a second. A couple of places there is a disturbance.
So I'll just start with the introduction that I had already conveyed, that we are now talking about the molar pregnancy and the safety regarding the management of molar pregnancy, basically. So molar one, there is a total chromosome. While in incomplete or partial one, both the maternal and paternal chromosomes are there. So please go ahead. 5-6 slides ahead. Yeah, we were talking about the risk factors, extremes of age we thought we talk of. That's it. So give me a second. So it is principally a disease of chorion. We talked that, and vesicular fluid is rich in SCG. Next, please. Microscopic appearance, we are not much worried about, but there is a marked proliferation of the syncytial and cytotrophoblastic epithelium, marked thinning of the stromal tissue, and there is an absence of blood vessels in the villi. That is a specific characteristics, but the villus pattern is distinctly maintained here, while it is not in choriocarcinoma cases. Next, please. Yeah, so this is what I was talking about. In cases of complete mole, there's a total inactivation of maternal chromosome, and in partial, the maternal chromosomes are always there, and it is the triploid chromosomes that is there in partial, while in the complete one, the chromosomal pattern is diploid only. Next. If we talk about the differences among this complete and partial mole, so partial mole in terms of clinical features, it present like missed abortions, while the complete mole will give a picture of molar pregnancy. Uterine size is small for dates in partial mole, while it is large for dates in complete mole. Fecal utensils are very rare in partial mole. SCG levels, initial SCG levels are less than 1 lakh in partial one. Medical complications are very rare in partial, while they may be found in complete mole. Rate of subsequent GTN development is 1 to 5% in cases of partial moles, while it is 15 to 20% in cases of complete mole. If we come to the pathology, we can always find a part of a fetus in partial mole, while it is absent in complete mole.
Ma'am, you are
Yeah, villus edema is focal in partial mole, while it is widespread in complete mole, along with the trophoblastic proliferation and trophoblast atypia. Next, please. Our main concern today is the management of molar pregnancy in a safe way. Next slide, please. So this is the picture of the complete mole. On ultrasound, you cannot find any part of the fetus here, and there is a snowstorm appearance in complete mole on USG. Next, please. Next is a case of partial mole, where you can see the placenta is so large and filled with the cystic spaces, while there is a fetus also present there. Next, please. So this is the picture of complete mole on one side and the partial mole on other side on USG. Next. So what would be the clinical presentation? In terms of clinical presentation, vaginal bleeding is the most common symptom. In 90% of the cases, the patient present with vaginal bleeding along with other symptoms like lower abdominal pain, some constitutional symptoms like patient looks sick without any apparent reason, vomiting of pregnancy becomes excessive, there is breathlessness, thyrotoxic features may be there, and there may be a history of expulsion of grape-like vesicles per vaginum, which is diagnostic of vesicular mole, and history of quickening is absent. Next, please. Other thing, a very important thing is the patient looks more ill, then it can be accounted for because the bleeding may be happening inside and because of the other systems involvement. Pallor is present and may be unusually out of proportion to the visible blood loss. This may be due to the concealed hemorrhage, and there may be features of preeclampsia like hypertension, edema, and or proteinuria that are present in up to 50% of cases, and in very rare occasions, convulsions may also occur. Next, please. So if we examine these cases, uterine size is always larger than the gestational age in cases of complete mole, and the field of uterus is doughy. Fetal parts are not felt, external allotment cannot be elicited, and fetal heart sounds cannot be heard. Next, please. On internal examination, you will not be able to find the internal allotment. You may be able to feel the bilateral enlargement of ovaries due to thecal utensils, which may be there in 25 to 50% of cases. And if patient is in the process of expulsion, you may find the vesicles per vaginum. Then if the cervical os is open instead of membranes, blood clots or the vesicles may be felt. Next. On investigations, the main mode of investigation to diagnose a case of molar pregnancy is ultrasonography. So characteristic feature here is snowstorm appearance. If it is a case of partial mole, you may find a part of the fetus also along with the enlarged cystic placenta. So apart from diagnosing the H mole, what all investigations you need to do to manage her? It is full blood count, ABO and RH grouping, hepatic, renal and thyroid function tests are also carried out as patient is to be taken for evacuation under anesthesia. And very importantly, quantitative estimation of chorionic gonadotropin. That is important because the fall pregnancy, the value reaches its peak at about 10 to 14 weeks and rarely more, it is more than 1 lakh. Next, please. So straight X-ray of the chest has also been recommended and it is to be carried out as a routine for evidence of pulmonary embolization even in benign moles. CT and MRI are not always recommended. It is only recommended when you firmly believe that she may be a case of invasive mole. So definitive diagnosis is made by histological examination of the products of conception. Next, please. Complications of molar pregnancy are hemorrhage and shock, sepsis, perforation of uterus, preeclampsia, acute pulmonary insufficiency, coagulation failure, and development of choriocarcinoma following hereditary from mole, which ranges from 2 to 15%. Next. Differential diagnosis is very obvious. These all things are to be ruled out, like threatened abortion, fibroid or ovarian tumor with pregnancy, multiple pregnancy, ectopic pregnancy, and a very important DD is twin pregnancy with one normal fetus and placenta and the other with complete mole is to be differentiated from partial mole. If it is not evident by ultrasound or by seeing the gross specimen, we need to do a cytogenetic study as well, because these two have a very different kind of progression. So we need to follow them up differently. A case of partial mole will be followed up differently, and a case of twin pregnancy with one fetus normal and another is a complete mole will be followed up differently. So this is very important in cases of twin pregnancy whenever there is a confusion with diagnosis of partial mole. Next, please. So it is the actually gene P57 which is absent in complete mole and it is present in partial mole. So that is how cytogenetics helps there. So what are the management guidelines? Management guidelines, if the patient has come very sick to you, you first need to provide the supportive therapy. That is IV infusion with Ringer solution, blood transfusion if you find that the patient is anemic, parenteral antibiotics are to be given, as many of the times these ladies come with a prolonged bleeding. So there are chances of infection. Blood is kept reserved also during the evacuation as there is a risk of hemorrhage. Next, please. As a part of treatment, evacuation, suction and evacuation is the main modality of treatment. And medical evacuation is not recommended even if the uterus is small, because there are 16-fold higher risk of developing GTN if we manage them medically. So suction and evacuation is the main method of treatment, and with the use of a larger cannula size, that is at least 12 to 14 number common cannula, and no oxytocics are to be given from beginning. They are to be started at the end of the procedure or only if patient starts bleeding heavily. Other things which can be given to control bleeding is injection, methergine, carboprost, and misoprost tablet also. So these are the patient where cervix is favorable. What about those where your cervix is tubular and closed? So earlier they used to say that ripening is not allowed. Then now, but they say that okay, ripening is allowed prior to your evacuation, especially with vaginal misoprostol at least 2 hours prior to the evacuation. And a slow dilatation may also be allowed in cases of a very long and tubular cervix. Next, please. What are the main safeguards? This is very important while doing the evacuation of a molar pregnancy. First of all, as I said, use wide bore cannula. It is to be done preferably under USG guidance, and other hand is to be kept on fundus if uterus is
more than 14 weeks to avoid perforation. And also your cannula should not go just beyond the internal os, because that cannula will suck in the products from there only. You need not to go to till the fundus, because there are chances of perforation. Then these uterus are very soft. And start oxytocin at the end if bleeding. And a gentle sharp curettage has been recommended now at the end of the procedure. Earlier it was like that there are chances of perforation, so you should not be doing a sharp curettage after the procedure, but now it has been recommended, but a gentle one at the end of the procedure. Next, please. So post-procedure management and follow-up is very important in molar pregnancy. You keep on checking for vaginal bleeding, especially for initial 24 to 48 hours, pulse, BP, and oxygen saturation, because there are very much chances of embolization during the procedure that may, be seen later on during post-procedure period. So you need to keep an eye on the oxygen saturation also. Then what do you send? The next investigation is beta SCG, that is to be sent after 48 hours or evacuation, and it is to be taken as a baseline beta SCG from which your follow-up will start, not the pre-evacuation SCG. It is the post-evacuation SCG which is your baseline beta SCG for further follow-up. After that, we do a weekly SCG till it is undetectable for 3 weeks. Earlier, there was a tradition to go for follow-up for 6 months in partial and 1 year in complete mole. But now there are clear-cut indications that in cases of partial mole, you need to follow up for 1 month instead of 6 months after the undetectable beta SCG. And in complete mole, if it is undetectable before 56 days, that is 8 weeks, then follow for 6 months from the date of evacuation. And if it has long more than 6 months, more than 56 days, it has taken to get normalized, then you follow up for 6 months from the date of normalization. So this is very important in cases of complete mole. If the beta CG levels are undetectable before 56 days, follow up only for 6 months from the date of evacuation. But if it is more than 56, for 6 months from the date of normalization. That is important. Next, please. So contraception in pregnancy, what would be your counseling? Ideally, a lady should not get pregnant during the follow-up of molar pregnancy, but accidental pregnancy is not to be terminated if patient is not receiving chemotherapy. OCs are very safe to be used during surveillance. We should not be advising them barrier or IUCDs, because barriers are very less effective, and IUCDs carry a risk of uterine perforation and abnormal bleeding PV, which may be confused with the symptoms of molar pregnancy. Next, please. NTD prophylaxis. Earlier, they used to say that no NTD is not to be given in cases of complete mole because there is no expression of Rh gene. But there are two things. Now they say that it is expressed in complete mole also, and also that you cannot know whether it is a complete mole completely just during the evacuation. That you would know only after the availability of histopath report. By then, the benefit of the NTD would be gone. So as a rule of thumb, it is to be given to all molar pregnancies, be it partial or be it complete. When it is in first trimester, the dose is 50. After first trimester, 300. But we have in India only 150 and 300. So we give 150 in first trimester, and ideally to be given in 72 hours. Next, please. Then second uterine evacuation. I remember when I was a PG, we used to do a second check curettage after 1 week. But at that time, we did not use to do the gentle sharp curettage at the end of the procedure. It was not recommended then. But now, as it has been recommended, the repeat evacuation or curettage is not recommended. It should only be done when patient has some symptoms, like she has heavy bleeding PV, or there is a condition of persistent mole. And most importantly, whatever you take should be sent for histopathology. Next, please. Role of hysterectomy. So there is a small role of hysterectomy in patients who have completed their family, their desire to get their uterus out, and the follow-up is unreliable. So a hysterectomy may be performed in these cases while mole is still in situ, but only in carefully selected high-risk cases. But mind it, hysterectomy does not prevent metastasis. Therefore, patient will have to come for the follow-up, right? But it definitely reduces risk of GTN by 5-folds. And ovaries are to be preserved at the time of surgery, even in cases of prominent theca lutein cyst. Next, please. Then a word about prophylactic chemotherapy. So prophylactic chemotherapy in the form of injection methotrexate also is only to be given in high-risk cases where the follow-up is unreliable and lady wants to preserve her uterus. So these are the high-risk factors mainly which we choose. If the patient's age is at extremes, more than 40 or less than 20, parity is more than 3, but age is more important than the parity. And if the serum SCG, initial serum SCG, pre-evacuation, not the post-evacuation, serum SCG levels are more than 1 lakh and uterine size is more than 20 weeks, and there is a previous history of molar pregnancy and theca lutein cyst of big size that is more than 6 centimeter. If these risk factors are present, you may think of hysterectomy if the follow-up is unreliable, otherwise not. And same holds true for the prophylactic chemotherapy also. Next, please. So this is the SUG categorically says that because toxicity including death may be significant, so prophylactic chemotherapy is not recommended routinely. And in 2021, FIGO also said that it may be useful in the high-risk cases when follow-up are unavailable or unreliable and reduces the risk of post-molar GTN to 3-8%. So it also does not recommend it in all cases. Next, please. So this is the regime that we follow for prophylactic chemotherapy. Methotrexate is given at alternate day over a week, 1, 3, 5, 1, 3, 5, and 7, alternatively with folinic acid. And the beta SCG level we measure after a week, and there should be a decrease of at least 15% between 4 to 7 days after methotrexate injection. If a lady is resistant to methotrexate or is not able to tolerate, alternatively intravenous actinomycin can also be used after consultation with medical oncologist. Next, please. How do you give this methotrexate regime? You repeat it at 7 days interval, and treatment is continued until the SCG level has returned to normal, and then for a further 6 consecutive weeks. And if any chemotherapy treatment is re-evaluated, if CBC, liver or kidney function tests are affected or at drug resistant, then you may need to increase the dose or you may need to change the drug altogether. Next, please. Postmolar gestational trophoblastic neoplasia, as I mentioned, it is a benign lesion with malignant potential. Malignant potential is more with the complete mole than with the partial mole. And what about the recurrence? Risk of recurrence with prior molar pregnancy in next pregnancy is about 1 to 4%. Next, please. Criteria for postmolar diagnosis of GTN or pregnancy is when during the follow-up period 4 values or more of plateau SCG over at least over 3 weeks, like 4 values over 3 weeks, 1, 7, 14 and 21 days, they plateau, they are not decreasing, or there is a rise of SCG of 10% or greater for 3 values or more over at least 2 weeks, that is day 1, 7 and 14. Or there is a histological diagnosis of choriocarcinoma. So if you suspect that she could be a case of choriocarcinoma, she is then to be classified as low or high risk and refer her to a oncologist for further management. Next, please. So these are the criteria, WHO prognostic scoring system given to each of the characteristic found in female, and depending on them, we divide them into low risk and high risk. A score of 6 or less is low risk and 7 or more is high risk. Next, please. So this is very important. What we have been talking about till now is the management of a molar pregnancy which has been diagnosed clear cut, either by the ultrasonography or by the histopathology. But what about the spontaneous abortions which go unnoticed? They may also have been a case of molar pregnancy. So these are recent recommendations which have been made to identify them also. So ideally, all surgically terminated abortions should be evaluated by histopathology if no fetal parts have been identified, either on ultrasonography or when you evacuate them and you feel that there is no fetal part in that, then you need to send it for the histopathology. Then urine SCG testing to be done after 3 weeks of spontaneous and those MTPs which have been done medically. There you do not have the product of conception to be sent for histopathology. So what do you do after the this abortion has happened? After 3 weeks, you ask the lady to repeat the urine pregnancy test. And only those patients, and what about the next pregnancy? After a molar pregnancy, do we do something else for that? No, specifically not. A routine antenatal workup, as we do. Early ultrasound will always tell you if she is a case of molar pregnancy now again. And what about the post-pregnancy period? In post-pregnancy period also, if patient has not received chemotherapy, she does not need to be followed up for molar pregnancy after the index pregnancy. So please, earlier they used to say that after the delivery has happened, you have to perform a repeat urine testing or a repeat SCG testing. But this is the recent guideline that if she has not received chemotherapy, she does not require any follow-up in subsequent pregnancy, just a routine antenatal care. And one very important thing is that all cases of post-delivery AUB, which have lasted for more than 8 weeks, should undergo urine SCG testing. This is very important. I keep on telling this to my postgraduate students also, that any lady coming post-delivery with AUB should be undergoing urine pregnancy test. Next, please. A few words about the recurrent molar pregnancy. Recurrent molar pregnancy definition is 2 or more consecutive or non-consecutive molar pregnancy is called as recurrent molar pregnancy, and its incidence is less. It is only 1 to 2%, and it may be of multifactorial in origin, which may be environmental and genetic factors, which may interplay. There are basically 2 types: familial, that is genetic, and non-familial. Familial one is very rare and it is biparental in always, and always results in complete mole. Till date, 2 genes have been identified in which the mutation may take place. The commoner one is NLRP7. It is responsible for like 95% of familial cases of recurrent molar pregnancy, and other gene is KHD-C3L, which may also be responsible. So NLRP7 mutation testing should be offered in cases of 2 or more recurrent molar pregnancy, and if it is absent, then only you go for KHD-C3L testing, because these are very expensive tests. And if they are found there, then IVF with implantation genetic testing is the option, that you select the embryo which is normal, and that embryo only you transfer, or you can do a ovum donation. These are the 2 modes of treatment in genetic cases. Till date, means after my PG 18 years of experience, I have seen 1 case of recurrent molar pregnancy. She has had 6 molar pregnancies, and I had referred her for IVF with PGT, and she had a successful pregnancy. So next, please. So these are my take-home messages. Molar pregnancy is an important pregnancy complication. Evacuation and follow-up are the 2 key components of treatment. Proper risk stratification is critical. Hysterectomy and prophylactic chemotherapy are to be reserved for selected patients. High suspicion can identify it timely, even in the cases where you generally do not think that she may be a case of molar pregnancy. And recurrent molar pregnancy is a rare entity, but with significant ill consequences. So the obstetrician should at least be aware of this entity. Thank you so much. Thanks for the opportunity. Thank you. Next, please.
Thank you very much, madam. It was
Thank
a
you.
crisp talk. And is Dr. Chandan madam with us right now?
I think you can wrap up,
So
Dr. Kirtan.
yes, so we can just conclude the first session over here. And it is rightly said that well, beginning is half done. So when the first session itself is so much crisp and to the point, so we expect that other sessions would also be so much enlightening for the speakers and also for the delegates. And with this, I hand over this second session to the coordinators for the second session, Dr. Madhav Hirani and Dr. Shweta Sirsirkar.
Good morning, all. Thank you so much, Dr. Kirtan. Am I audible to all?
Yes.
You are audible.
Okay. So
maybe
after
request,
that wonderful...
just a minute,
Yeah,
Dr.
yeah.
Shweta, just to interrupt
Yes,
you
yes.
for a minute.
No.
Maybe request all the speakers to share their PPT to Mr. Vasu as a backup in case of any difficulty with the internet connection or so.
I think we can share his email on the main group and then they can send their
Yes.
presentations there.
Yes. Thank you.
And
Thank
kindly,
you.
please, we request everyone to maintain the time since we are having a day-long conference. So please, I would humbly request all the esteemed speakers to maintain time. Thank you so much for understanding.
Okay, thank you so much, Dr. Charu. Yes, we have a wonderful brainstorming and basket full of session, which includes the complication and management of high-risk pregnancy. Now we are proceeding to our second session, which includes the hypertensive disorder of pregnancy and its complication. The HDP, as you all know, is the leading cause of mortality, the perinatal and the maternal mortality, and putting both not only the mother but the baby also at risk of the complications during pregnancy. So besides improving the early, what we need is, besides improving the early diagnosis and initiation of appropriate treatment for HDB, prevention of this disorder from occurring is really require an essential strategy to be made to reduce the mortality and the morbidity, particularly in the low resources setting. So with this background, we'll start with our second session. Definitely we are having a wonderful keynote speakers in this, and galaxy of stalwarts, you can say, are Dronacharya. Before that, I would like to invite all our esteemed speaker chairpersons for the session. Definitely they will put an insight to the topic. Can you please share the CVs of speaker, Mr. Vasu? Yeah, we are having our first chairpersons. We are having our first chairperson, a dynamic, multi-talented, yes, down to earth, Dr. Anupama Dave, ma'am. No introduction required to the madam. She is an organizing scientific committee chairperson, AICOG, for the year 2022. She holds many awards with her. She is a wonderful teacher and a professional par excellence. She has a recipient of the award of the Foxy Sun International Driving Fellowship in the year 2016, and also the winner of Dr. Amrendranath Award for the AICOG 2015 held at Chennai, winner of the Umaram Prize for the best paper presentation in the maternal medicine, and also receives many other awards. She is a master trainer and the nodal officer for the Foxy MOC training, master trainer for the IPAS CSC training, and she holds 64 publications in the national and international journals. Her area of special interest are the high-risk pregnancies. We welcome you, ma'am. Our next chairperson is a dynamic, multi-talented Dr. Tabassum Dala, madam. She is a president, Raipur OBGYN Society, a vice president of IMA Raipur. She holds a diploma in the minimal access surgery. She is organizing committee member of the zonal conference for the IMS and a member of adolescent health committee Foxy. She received various awards including the TOBIP award at the JCI Mama Excellence in the medical field, and also the Women Empowerment Award by the Go India Foundation and the Nari Shakti Samman presented by the Jayaprada. We welcome you, ma'am. Our next chairperson is another vibrant Dr. Arun Aruna sir. He's a course coordinator masterclass on the reproductive endocrinology and applied genetics IFS, and also.
Can I just interrupt, Dr. Shweta? Just a minute.
Yeah.
I think there is some technical issue with the microphone at your end. Can you just see
Okay.
that?
Okay,
It's
I'm not audible
disturbance.
properly.
No, you're audible, but there's a lot of scratchy sound in between.
Okay.
So if you can, just check it out, whatever it is.
Is it okay now? Is it okay now, Dr. Charu?
Still there. Yeah. Can your
Other electronic
coordinator take
devices
over?
is to-
Dr. Madhav can take over for a while, and you can change your earphone if possible.
Hello, now is it okay?
Better,
Hello?
a little better, a little
Better?
better.
A little better. Okay.
No,
okay,
no,
okay.
no. It's again started. Sorry.
Okay. Might be I'm doing till then.
Yeah, if you can hand over to
So,
Dr. Madhav and you can just change your earphone.
Yeah. Dr. Madhav, you are there?
Yeah, I'm here. Good morning,
Yeah, so
everyone.
please please
Morning.
introduce our chairpersons.
Dr.
Yeah, so our
Dr.
next
Shweta,
chairperson
please
is Dr.
change your earphone. Thank you.
Yeah. So our next chairperson is Dr. Arun Arora, who was the former HOD of Department of Obs and Gynae, GMC Udhampur, Jammu and Kashmir. And just to list down, he has lots of achievements and he has been at the highest positions. But the mainly we can just list down that he is the founder secretary of IFS Jammu chapter and even the regional faculty of Adolescent Health Committee FOXI, coordinator for the masterclass of reproductive endocrinology and applied genetics IFS, is the director at Pushpanjali Life Hospital, and uh, he has he has books. He's the author for 3 books, and he has contributed to many chapters in the 5 books, and he's also a joint secretary for Jammu and Obstetric Jammu Society or OBGYN Society. We welcome you, sir.
Thank you, Madhav.
Yeah. Can we have the next chairperson, please?
Hello. Hello.
Yeah, ma'am.
Rahul, next chairperson.
We have all
so
the
I
three.
think
We introduced all the 3 chairpersons.
Yep.
Hello. Hello.
Please request one of the chairpersons to introduce and we'll start.
Yes. Hello.
Yeah, Shweta ma'am, you're audible.
Yeah, okay. Thank you so much. Now I request chairpersons to please introduce our speakers and for the further proceeding of the session.
So can I start now?
Yeah, ma'am.
The first talk is on innovations for HTP, and I take pleasure in introducing the speaker, Dr. Charmila. She's an MD, DGO, DFP, FICOG, PG, DCR. She is the Vice President, FOXI 2024, Vice President, Trichy OBGY Society, Director, Aditi Hospital, Trichy, ICOG Governing Council Member 2021 to 25, National Coordinator, UNICEF FOXI PCA, Mega FOXI PG Program, ISAR Gurukul Program, Series Convener, ICOG Journal Club, ICOG Certificate Courses 2022-23, WHO Southeast Asia Region MDSR India member, and she has many more things to her credit. She's an eminent speaker and a stalwart in the field, and I invite you, ma'am, for your talk.
Thank you, Anu. Thank you so much for that very, very kind introduction. I would like to thank MC sir for the opportunity. My talk is going to be on prediction and prevention of PIH. We need to know why this disease is so important that it needs to be prevented. This is a disease which affects almost like 8% of the pregnancies worldwide and remains a major source of maternal and neonatal morbidity as well as mortality, affects almost 10 million pregnancies per year worldwide. That's it. There are some preventive modalities which has been advocated, and that is particularly by a FIGO working group on good clinical practice in maternal fetal medicine. They have said 3 conditions, that is a public health focus, universal screening, and prophylactic measures. the thing which we can do very commonly as a clinician is the universal screening. And the utility should be, it will help us to estimate a patient's risk of developing preeclampsia and whether they are a candidate for, second, I don't know why I'm It will help us to estimate a patient's risk of preeclampsia and whether they are candidate for a heightened pregnancy surveillance during her pregnancy, and whether we need to adopt certain prophylactic measures which help to prevent this disease, and that is low-dose aspirin, calcium, and exercise. Preeclampsia is a syndrome with several presentations, so there's nothing like an ideal predictive test for preeclampsia, and we need to utilize a combination of many predictors to predict this disease. And the pathology of this disease is due to an abnormal placentation and abnormal vascular supply. Hence, if there is any pre-existing maternal subclinical endothelial dysfunction, like a chronic hypertension, it will be exacerbated during pregnancy. And that's why, due to these assumptions, studies to predict this disease have all focused on the maternal vasculature in early pregnancy, which will combine the maternal history with measurement of blood pressure, urinary Doppler, and serum biomarkers. And universal screening is recommended, but there's no single effective screening test, as I said. And none of the tests which have been proposed till date to predict an at-risk population for preeclampsia qualify to be recommended for a general population universal screening. And that's why the thing which I've got available, readily available, cost-effective is the assessment of clinical risk factors, and that will help us to remain more vigilant. And that can be done very easily by any healthcare worker using the Gestosis score, which has been done by the Gestosis India Association. And when you want to compare the different guidelines of how they use the clinical parameters for predicting this disease, the American College, the NICE guidelines, the International Society for Study of Hypertension in Pregnancy, the United States Preventive Task Force, all say that when there's a prior history of eclampsia or preeclampsia, there's a very, very high risk of the mother developing preeclampsia again. And suppose she's got a previous adverse pregnancy outcome or a perinatal outcome, American College says there's a moderate risk of her developing again, but the United States Preventive Force takes it as a high risk criteria for developing preeclampsia. Chronic hypertension, we know, it gives a very, very high risk of the mother developing preeclampsia again and again in every pregnancy. Similar for diabetes mellitus, kidney disease, and autoimmune disease. Nulliparity actually scores only as a moderate risk factor in all the guidelines. But a pre-pregnancy BMI has got a very high risk factor of developing preeclampsia in her pregnancies. And that is when she's more than 30, it is moderate risk according to American College. NICE guideline says more than 35 gives a moderate risk. But the International Society says more than 30 should be considered as a high risk criteria. The United States Preventive Force takes it as a moderate risk category. Family history of preeclampsia gives a moderate risk for her developing preeclampsia. A multifetal gestation, according to American College, conveys a high risk for her to develop preeclampsia, but it is moderate with the other guidelines. Being an older mother gives her a moderate risk of developing preeclampsia. Having a history of being a low birth weight baby also gives her a moderate risk category, risk criteria. But if there are more than 10 years in between pregnancies, remember, it also gives a moderate risk of her developing preeclampsia. According to the Fetal Medicine Foundation, they take high risk category as BMI more than 40. And if there's a current assisted reproductive technology pregnancy, like an IVF pregnancy, it gives a very high risk of developing preeclampsia. A moderate risk is there when she's had a prior stillbirth, a prior abruption, or a prior fetal growth restriction. And according to the FMF, the strongest predictors of prior preeclampsia and chronic hypertension for developing preeclampsia in this pregnancy. And they also exclude chronic kidney disease, prior abruption, and fetal growth restriction, which has been included in many guidelines, but it has been excluded by the Fetal Medicine Foundation. But they've added something called a racial origin of the disease for developing preeclampsia. So when you go through the risk factors of a mother, we take it as screen positive by the American College. She's got even one high risk criteria, or she's got two moderate risk factors based on all these guidelines. So any risk factor which has got a high risk category will need the mother to be undergo a greater surveillance rather than more than when she's got a lower risk factor. And this is the Gestosis score which has been devised by Foxy ICOG in 2019 with the Gestosis India Association. And score of 1 is 35 years, younger women, anemia, obesity, primary, a short duration of sperm exposure, like cohabitation of shorter marriage, a lady who was born as a small for gestational age, all gives her a score of 1. Family history of cardiovascular disease, PCOS, interpregnancy interval more than 7 years, conceived with ART, a MAP of more than 85, a chronic vascular disease like dyslipidemia, or she's gained excess weight gain during this pregnancy, will have a score of 1. Score 2 is with hypothyroidism, a family history of preeclampsia, a history of GDM in this pregnancy, obesity of more than 35 kg per meter square, multifetal pregnancy, or a hypertensive disease during a past pregnancy. Score 3 is for a pre-gestational diabetic, a chronic hypertensive. Mental disorders has got a score of 3. Inherited acquired thrombophilia, chronic kidney disease, autoimmune disease, or pregnancies associated with home donation or surrogacy all gets a very, very high score. The other parameter which helps us to screen and predict for this disease is the measurement of blood pressure. And all pregnant individuals at risk of preeclampsia should be screened by measurement of blood pressure at all provider visits throughout the pregnancy. And it is actually universal. It's not even that there's a risk. You have to measure the blood pressure at every visit. And even though pregnancy is not diagnosed before 20 weeks of gestation, early measurements will establish the patient's baseline blood pressure so that he can be more vigilant in her later part of pregnancy. And mean arterial pressure is one which is around 70 to 110 millimeters of mercury when it's considered normal. As an isolated marker for the prediction of preeclampsia, the performance of MAP is quite low. So you have to combine it with clinical risk factors to say that the mother has got a higher risk. American College and NICE guidelines recommend for prediction a routine blood pressure measurement of all mothers, a detailed medical history to evaluate the risk factors, and the baseline screening for urine protein content to assess the kidney status at every visit to say that she's got a higher risk of developing preeclampsia. And historical risk factors with only the maternal history will predict only 30% of mothers who will develop preeclampsia. And that's why there are so many laboratory and imaging tests which have been advised to add on to the clinical risk factors to estimate the risk of developing preeclampsia. But it's still an active area of investigation. It's not come through, but still there are so many changes which have been brought into the picture. And remember that the pathology of preeclampsia is due to an abnormal presentation and its vascular supply. So any pre-existing maternal subclinical endothelial dysfunction, if it is there, will exacerbate during pregnancy and the mother is going to develop preeclampsia. So because of these assumptions, the studies have all focused on maternal vasculature in early pregnancy, combining the history of the mother, the clinical characteristics of her, with the measurement of blood pressure, the measurement of the uterine Doppler, and serum biomarkers for predicting preeclampsia. So the combined test is supposed to be much better than the single risk factors estimation. And that is you combine mean arterial pressure, the placental growth factor, the uterine artery pulsatility index, and all that you combine together and give her a risk factor for developing preeclampsia. But if it's not possible to measure because of the cost factor, at least the maternal risk factors with MAP, which does not need much of cost to evaluate for her risk factors. And suppose a double marker test is done in the first trimester, like a PAP has been done with a routine first trimester screening for a fetal aneuploidy, that result can be included for the preeclampsia risk assessment without adding to the cost. There are some methods which are being evaluated with the Bayes-based method, and the mother is considered as high risk when the risk is more than or equal to 1 in 100 based on the first trimester combined test with the maternal risk factors, mean arterial pressure, the placental growth factor, and the uterine artery pulsatility index. But remember, the first trimester combined test is most predictive of a preterm preeclampsia development rather than a term preeclampsia. And first trimester screening, the best biochemical marker which is available at this point of time is the placental growth factor. And several studies have shown that the ladies who develop preeclampsia later on will have a lower maternal placental growth factor in the first trimester compared to other normal pregnancies. And the uterine artery pulsatility index is the measurement of the resistance to blood flow in the uterine arteries, and it correlates with both histological studies and clinical severity of preeclampsia. And it is a persistent high impedance to flow in the uterine arteries. It is an evidence of poor placentation that manifests itself in the form of abnormal uteroplacental flow velocity waveforms later in her pregnancy. And that's why when you want to compare the prediction sensitivities of different modalities, when you use only clinical markers, it will predict 34% of preterm preeclampsia and 39% of term preeclampsia. When you're using a combined test with a maternal screening, a biochemical screening, and a sonographic screening at 11 to 13 weeks, 75% of preterm preeclampsia can be predicted, and term preeclampsia, 47% can be predicted. When you use only placental growth factor or uterine pulsatility index without combining both, you will actually have a 70% chance of predicting the development of preterm preeclampsia. There's one study called the SPREE study, which is called the Screening Program for Preeclampsia study of 2016, where they've said the NICE guidelines using clinical risk factors will actually assess the risk of being only in 10% of the patients. And preterm preeclampsia, it will predict 40%. We are using only clinical risk factors. But when you use the mini combined test, that is the maternal risk factors, the mean arterial pressure, and PAPA, it is 42.5% screen positive. Preterm preeclampsia estimation will be 53.5%. But when you add to the maternal factors and MAP, the serum placental growth factor, the prediction of preterm preeclampsia is almost 69%. And when you add uterine arterial pulsatility index to this, it will add on to the prediction of preterm preeclampsia to almost 82%. And doing a uterine artery Doppler velocimetry in the early pregnancy is not a recommendation because the false positive rate is quite high, leading to excessive patient anxiety and healthcare costs. And that's why it's more accurate when performed in the second trimester than in the first trimester. But when it's done as a part of the combined test to add on to the cost, it just give you a clue that you need to be more vigilant during her pregnancy. Other lab tests, like suppose a double marker test is done and you've got an unexplained abnormal PAPA, or you've done a circulating cell-free DNA and microRNA levels and it's shown an abnormal report. It also predicts an adverse pregnancy outcome, which can also include preeclampsia, but the associations are not sufficiently strong that you need to make a change to the routine prenatal care, that you need to do a double marker test to assess for the risk of preeclampsia. And there are risk prediction models because they say when you combine many screening tests, it will give you a higher chance of predicting the development of preeclampsia. But there are so many variables which have been used to create this tool to predict the risk of developing preeclampsia. By the example is the Fetal Medicine Foundation preeclampsia calculator. But in validation studies, you have to remember the combined screening algorithms of the first trimester will predict preterm eclampsia from 75 to 92% at a screen positive rate of only 10%. And this is the calculator which they use. And the disadvantage of these tools is they can be a low positive likelihood ratio estimation, and then the patients will be made more anxious and they will receive unnecessary treatment for a very small absolute risk reduction. And there are also additional costs and complicated logistics involved. You need special tools to actually estimate the risk. And in addition, the methodological deficiencies are very common, which limit the reliability and validity. And there was a systematic review of the risk prediction models where they said almost 95% had fewer than 10 events per predictor of early preeclampsia. So it's not so useful as it's made to be. And NICE guidelines suggest that PLGF-based tests should be done to rule in or rule out preeclampsia in women who are suspected of the disorder between 20 to 36 plus weeks of gestation. It will help us to predict the progression to preeclampsia with severe features within the 2 weeks. Suppose she's already developed hypertension, it will help us to predict whether she'll go for the severe variety. And where PLGF was implemented in the Royal College, there was a lower incidence of maternal adverse outcomes. And what about rescreening for risk once you're done in her early pregnancy? There's nothing like, there's no evidence to say that this tiered approach will help us to actually diagnose much better. It will actually help us to increase maternal fetal surveillance and also will help us to time delivery. But keeping on doing it again and again may not be much of use. And that's why an individualized approach should be undertaken. And there are tools which are not of any use. The biophysical tests which were done earlier, they're all quite expensive, time consuming, and most importantly, quite unreliable. Serum uric acid cannot be used as a screening tool for predicting preeclampsia. Screening for inherited thrombophilias, which are very costly, should not be done. And screening for antiprecipitate antibodies will not add on any value to the screening for preeclampsia. And that's why FIGO has come out with this guideline that all pregnant women, that is universal screening, should be done for preterm preeclampsia during the early pregnancy by a first trimester combined test. It should be a one-step procedure with both maternal risk factors and biomarkers, according to FIGO. And the Canadian guidelines and the International Society have said in early pregnancy, all women should be screened at least for the clinical risk markers of preeclampsia. And suppose there's a cost factor is not involved and the testing is available, you can offer a combination of clinical risk markers, the uterine artery pulsatility index, and the placental growth factor estimation to individualize the risk of developing preeclampsia. But the American College Task Force is still stuck on to say that only a risk factor estimation is more than enough for identifying women considered as at risk for preeclampsia. So after prediction, what are you going to do? According to FIGO, you should offer the women aspirin prophylaxis, and that should be from 11 to 14 plus weeks of gestation at a dose of 150 milligram and should be taken every night until either 36 weeks of pregnancy or when delivery occurs or when preeclampsia is diagnosed. And the ASPER trial is the one which came with a dose of 150 milligram, where they compared it with placebo and not 75 milligram. And they said when they use this dose, it would result in halving the incidence of preterm preeclampsia. And the results from the trial proved evidence that effective screening for preterm preeclampsia can be achieved with a combined test and aspirin treatment from the first trimester of pregnancy. And this will significantly reduce the risk of developing preterm preeclampsia. And aspirin reduced preterm preeclampsia in the study by almost 62%. And suppose the lady is allergic to aspirin, you have to put her on a close vigilance and expected management is appropriate. And she will include more of free clinical blood pressure estimation and or home blood pressure monitoring. And when the intake of calcium cannot be assessed or predicted in a patient, it is reasonable to give oral calcium for many of them. And the blood pressure reducing activity after this drug is due to the alterations in the plasma renin activity and the parathyroid hormone. And exercise should also be recommended to the lady at least 3 days per week for an average of 50 minutes using a combination of aerobic, strength, and flexibility training. And it has been associated with less weight gain and reduced incidence of hypertensive disorders. And there are no significant adverse effects of exercise in pregnancy. And the GCPR guidelines of oxytocin ICOG in 2019 was, they still said that aspirin can be given at 75 milligram. They've said there are many studies which are using 60, 75, 100, 150. And the number of patients exposed to doses over 100 milligram is still low. And the safety of prevention based on 150 milligram of aspirin per day has to be confirmed. And that's where they said aspirin of 75 is readily available, should be used, and very easy to prescribe. And they also said it has been started even earlier than 12 weeks of pregnancy because defective placentation is considered as the causative factor of preeclampsia. And when you give early aspirin, it will balance the levels of thromboxane A2 and prostacyclin, which will maintain adequate uteroplacental blood flow and improve the placentation without increasing the risk to the mother and the baby. Hence, it's safe to use low-dose aspirin as a prophylaxis to prevent preeclampsia throughout pregnancy. And please continue until 2 days prior to delivery or cesarean section. And the International Society of 2018, they've said it has to be given between 75 to 150, preferably before 16 weeks of pregnancy, possibly taken at night, and should be continued until delivery of the baby. Not of any use by the guidelines is primary interventions like bed rest, restriction of activity, nutritional measures like reduced salt intake, antioxidant usage like vitamin C, E, garlic, marine oil, all are not acceptable. And secondary interventions like diuretics, progesterone, nitric oxide, metformin, statins, esomeprazole, heparin are all in the research phase. They are not advised for the prevention of preeclampsia. And how to improve the outcomes according to the Society for Maternal Fetal Medicine guideline, general measures should be ensure access to quality care by every pregnant patient, address the systemic and community factors which impact the health outcomes, invest in innovative care delivery models, and adapt guidelines to be context appropriate. Specific interventions which have been advised to reduce the disease is magnesium sulfate, antihypertensive drugs, urine dipstick test, and functional blood pressure machines. So I'd like to conclude by saying the unknown etiology of the disease, the low predictive value of current screening tests, and the several presentations of the disease complicate the prevention of all cases of preeclampsia. Interventions may help in only a small reduction in risk, and it means that a large number of women will need to be treated to prevent a single case of preeclampsia. At this moment of time, the definitive treatments remains delivery and removal of the placenta, and there's no effective prophylaxis of preeclampsia, which is being advised currently. Thank you so much for a patient hearing. I'd like to thank Dr. MC sir for the opportunity.
Thank you, Charmila ma'am. It is always a pleasure listening to you and you in action. Greetings to you from Raipur.
Thank you. Thank you, Tapas.
Thank you,
And
for the
and then it was a wonderful talk. As we all know that all the parameters definitely they are adding on the uterine artery Dopplers as well as the PLGF and everything. but with low resource settings, clinical parameters also make a big difference. In a very low resource setting, like in peripheries, even if we give them a chart and tell them to chart that and find out the risk factors, will also make some difference in predicting. So I think that is also a very important take-home point here. And the treatment is definitely very simple to prescribe, low dose aspirin. So we can prevent preeclampsia very well. Thank you so much, ma'am, for a very good talk.
Thank you, Tawassi. Thank you so much.
Thank you, Dr. Charmila. It was an excellent talk, especially the concept that you highlighted the various guidelines and what they said about predicting preeclampsia. In our country, we can follow the Gestosis score and then, of course, go on with screening by ultrasound Dopplers. We do not have biochemicals. Thank you, ma'am. And I would like to thank the organizers as well, Dr. Alpesh Gandhi and Dr. MC Patel, for inviting me. And I do wish all the best to Dr. MC Patel for his election. Thank you.
Thank you so much, ma'am, for that wonderful insight for the prediction and prevention of HDP. Now I request Dr. Tabassum madam to please introduce our next speaker, Dr. Girja Wagh madam. Hello.
Hello, good afternoon, everyone. It's my proud privilege to introduce none other than Dr. Girja Wagh madam. She is a renowned gynecologist. She's associated with Cloud9 Pune. After graduation, she completed MD in obstetrics and gynecology, diploma in endoscopy, and attended fellowship of ICOG gynecologist.
I think it's okay, Dr. Tabassum. Thank you so much.
Girja
You can
madam
just
needs no introduction. So over to you, ma'am. Thank you so much for coming for this conference.
thank you, Dr. Tabassum. At the outset, I want to first let me try and share my slides so that I know that they are running. I don't know what has happened here. Yeah, 2 minutes. Just a moment. There's some. Yeah. So are we able to see the screen?
Yes, ma'am.
You can put it in slides.
Okay. So at the outset, I want to really thank Dr. MC Patel for creating such a magnanimous, a webicon. Dr. Shweta Siriskar and for Madhav, and my absolute respects to Dr. Anupama Dave madam, who I really respect a lot for her academic contributions. Dr. Tabassum, much dedicated especially to stillbirths, and Dr. Arun Arora for chairing this session, and my predecessor, Dr. Charmila, who gave an excellent exposition on prevention and how best we can do. And I'll also try to very quickly navigate this particular challenge that has been given to me. Crisis averted, navigating eclampsia with prevention and care. I've been observing that there have been some network issues as we have been going by. And in case if my talk also happens to go like that, I may just put off my video so that we have a better relay. So let's quickly understand what is eclampsia. We all know that it is a new onset generalized tonic-clonic seizures or patients with preeclampsia, HELLP associated with this particular condition. And if you look at the magnitude of the problem in our country, especially the incidence is found to be approximately 10% as per the National Eclampsia Registry, the incidence of preeclampsia and eclampsia are typically about 1 to 2% of all the pregnancies. That means, as in our country, we have 26 million deliveries per year. We are dealing with 26 lakh 78,000 cases of preeclampsia and nearly 5 lakh of cases of eclampsia yearly, which means that it is a truly gigantic task. So when we look at the hypertensive disorders of pregnancy, now we have completely agreed to the classification, which classifies it based on gestational age, especially the gestational hypertension, preeclampsia, and eclampsia. And we have a very common occurrence of 1, superimposed preeclampsia. So these women are typically probably chronic hypertensive, which we didn't diagnose beforehand, diagnosed it later. And we also have women with gestational hypertension. Nearly about 40 to 50% of them would get converted into preeclampsia, which is proteinuric hypertension. And all of them are at risk of developing eclampsia. Now, whenever we look at preeclampsia, usually we have to be very, very careful clinically at this women, because what we see when the blood pressure is first seen by us clinically, usually there is a lot of things which are hidden down there. So we are only looking at the tip of the iceberg. Down there are a lot of maternal and fetal issues that are there, and this can give rise to severe morbidity and mortality in both the mother and the baby. And therefore, we have to be very sensitive to this. Now, despite advances in detection and management, eclampsia remains a common cause of maternal morbidity and death, especially in resource-limited regions. Now, let's look at the pathogenesis of this particular condition as to why do seizures occur in preeclampsia or hypertensive disorder of pregnancy. Now, popular belief has been that there is vasospasm and cerebral. It probably is not the only reason. The placental ischemia causes the release of certain molecules such as neurons and tissue plasminogen activators, and these molecules simulate excitatory neuronal receptors and alter neuronal excitability, synaptic transmission, and neuronal survival independent of any vascular effects. So this seems to be an inflammatory surge into the brain, giving rise to this problem. Preeclampsia itself, where we have understood that there are women with risk factors, as Dr. Chamila told us in a wonderful lecture. And then these are the ones where something goes wrong in them immunologically, or maybe inflammatory issues are there. There is an ischemic placenta, and then there are release of certain anti-inflammatory things, which give rise to gradual changes over the period of time. And then there are end organ involvements. Typically, as a clinician, we would be able to pick it only when an end organ involvement would present to us. And of course, we may detect it early if we are really very vigilant during the antenatal care. And these can be in the form of hypertension, proteinuria showing renal dysfunction, HELLP syndrome, and cerebral edema, seizures, and PRES. So these are typically found to be that there are these inflammatory cytokines and immunological maladaptations which happen in the cerebral, the systemic resistance, vasospasm in the cerebral vasculature, cerebral edema, and then symptoms of eclampsia like seizures could happen. So eclampsia would be due to the change in the neurosteroids such as decreased GABA or subunits, pro-convulsive effects of estriol, imbalance of progesterone, estrogen, and others. There is inflammation and infection in the form of microglial activation, local cytokine production, and others. And there is disruption in the blood-brain barrier, which increases the permeability factors, failure of efflux transporters, endothelial dysfunction, autoregulatory breakthrough, and edema formation. So on one side, you would have certain complications associated with. The short terms would be white matter hyperintensities, ischemic and hemorrhagic shock, stroke, cerebral small vessel diseases, vascular dementia, vasospasm, reversible cerebral vasoconstriction syndrome, convexity, subarachnoid hemorrhage, intracerebral hemorrhage, arterial dysfunction, failure, etc., and autoregulation. And so many things would happen, and there can be even long-term consequences because of these structural changes that can occur, giving rise to carotid edema, media thickness increase, and cervical artery dissection. So typically, eclampsia happens to be a pre-presentation of the CNS complication of hypertensive disorders, and it can also have infarct, cerebral edema, PRES, and blindness associated. And there can be focal neurological signs, prolonged coma, atypical or recurrent convulsions and seizures even after delivery. Now, usually, nearly about 95% of the times, the eclampsia would be associated with what we call as the PRESS syndrome. Now, what is this PRESS? This has been found on the MRI of brain, which has been identified to be a gold standard of diagnosing of this condition, where the T2 weighted images typically reveal punctate or confluent symmetrical bilateral hyperintensity in the parieto-occipital lobes. You can see in this particular picture at the lower part of this is the place where it would be happening, and CT would demonstrate symmetric hypotensities that usually involve the occipito-parietal regions of the brain. Now, it is found to be postulated to be vasogenic cerebral edema, ischemia of the brain tissue. It has less sympathetic innervation of the vertebrobasal vasculature to protect the parenchyma from rapid increases in arterial blood pressure. And the management is by discontinuing offending medications, lowering of the elevated blood pressure, and treatment of any seizures. Now, let us understand which are the women who are at risk of eclampsia. Women who have preeclampsia or gestational hypertension, Black and Hispanic age women, advanced maternal age, nulliparity, and less than 20 years of age, also teenagers are more at risk, multifetal gestation, preterm delivery at less than 32 weeks, and lack of prenatal care. And the several signs and symptoms which may precede eclampsia, which we have to be a little sensitive to, would be visual disturbances such as blurry vision, diplopia, scotomatopa, photopsia, transient cortical blindness, epigastric pain, severe persistent occipital or frontal headaches. And the most common symptoms are headache, nearly 66% of the times, visual disturbances, 27% of the times, and epigastric pain, nearly 25% of the patients would present. So eclampsia is a patient which is most commonly easily identifiable complication. Patient comes with a seizure, but sometimes there can be a confusion if she's unconscious or there have been general, maybe very mild convulsions. It may not be understood. Antepartum occurrence is the most commonest, about 38 to 53% of the time, 18 to 36% intrapartum, and postpartum risks are also there, and therefore one has to be very vigilant. It will be an extension of the prenatal care itself, but it can also be a de novo occurrence of eclampsia who has been a normotensive woman before even after delivery. Now, atypical eclampsia, there are convulsions sometimes despite giving a full dose of magnesium sulfate, and there would be patients who would have problems when also called as late postpartum eclampsia after 48 hours of. So these seizures should be treated promptly with a bolus of intravenous magnesium followed by continuous infusion of magnesium sulfate. And if there are intractable seizures, it's called as resistant eclampsia. Example, recovery position. Now, one has to also understand that sometimes eclampsia can be a differential for an intracerebral hemorrhage, especially in women with chronic hypertension, where the systolic blood pressure is high, because they would be having Charcot-Bouchard aneurysms in their brain, which may get erupted. And these are usually found on the deep penetrating arteries of the lenticulostriate branch, that of the middle cerebral artery, which weaken and predispose these small vessels to rupture with sudden hypertension. The good news in many of the cases, and this particular wisdom came by the very, very landmark trial, which was published in the Lancet, the Magpie trial. And the controversy largely ended because of this particular RCT, which was published in 1995, which was comparing magnesium sulfate with diazepam and phenytoin, and it found to reduce the risk of recurrent seizures in eclamptic women by 52% compared to diazepam and 67% when compared to phenytoin. And this is the Magpie collaborative group study, which has now made the new guidelines, which we practice on day-to-day basis. So magnesium sulfate is not only for preventing treating seizures or treating eclampsia, but it's also known to prevent seizures in women with severe preeclampsia. It's also known to be a very good tocolytic. It is also known to be a good neuroprotector. But in the recent, there has been a publication which has also shown that it is a good tissue stabilizer and a drug to go to when you have a patient who has HELLP syndrome. Now, eclampsia can occur suddenly, as you can see in this situation here.
Okay. Doctor, she's 8 months pregnant. She hasn't eaten anything since today. Okay. I'm also. What problem you are having? Doctor, I have headache since morning. Okay. Doctor, she's 8 months pregnant. She hasn't eaten anything since today. Okay. I'm also feeling nauseous and also had one episode of vomiting. Okay, just take her BP meds. Let me take your. Doctor, is this normal? No, we'll just check her BP once and then I'll able.
So you can see that the patient has just come for a checkup, not feeling well, and her blood pressure has been recorded to 170/100. She is a 32-year-old primigravida, conceived with PCOS, and has now come at 33 weeks with these complaints. So you can have a patient, and this patient was just being taken over for the breath. And immediately, she has started convulsing. Now, sometimes in such a patient, you will not be able to put in giving her an IV magnesium sulfate. You are justified here in giving her an intramuscular 4 grams as well to prevent the further complications. So don't go and run for a diazepam. You can very well give the magnesium sulfate injection to abort such a convulsion. It's important immediately to rush for a rapid nursing kind of an approach and give a loading dose. The loading dose typically, as per the Pritchard's regimen, is a 4 gram IV followed by 10 grams, 5 grams, and then strap the patient onto the infusion pump, delivering the Zuspan regimen at the rate of 1 to 2 grams per hour for the next 24 hours. These are typically the contents of the magnesium sulfate, and which should be all magnesium sulfate box. And they should always be ready, easily accessible, because as you can see, eclampsia is a sudden bolt which may occur into your OPD, into your wards, in the patient who are laboring, or in the operation theaters. And therefore, one has to be always armed. And this particular box has to be replenished on a regular basis. Now, how does magnesium sulfate help? It causes vasodilatation by relaxation of smooth muscles. It has a generalized effect on all smooth muscles, including the peripheral vasculature and the uterus. And there is a blockage of the NMDA receptors in the brain, which reduce the calcium influx and protect the neurons from further damage. And it has been supported by strong evidence, because it's known to halve the risk of eclampsia more than 50% and the risk of maternal death as well, and substantially more effective than diazepam and phenytoin. So it causes blockade of the NMDA receptors, reduced presynaptic release of neurotransmitter glutamate, potentiation of adenosine action, improved mitochondrial calcium buffering, and blockage of calcium entry via voltage-gated channels. So the moment a patient comes to you with severe hypertension, your checklist of severe hypertension will primarily include the initiation of the magnesium sulfate for seizure prophylaxis, if not already initiated, the moment she has a blood pressure of 160 or 110 mils of mercury, and the antihypertensive medicines. And this is something that should be always there in all your birthing places. Now, patients who therefore get admitted with severe hypertension should be given magnesium sulfate, and giving magnesium sulfate does not mean that we are going to terminate this pregnancy. And
Just take her BP once. And her BP in the morning was also 160/100. Should we give her magnesium sulfate? Yes. Get the MgSO4 box. We will give her injection MgSO4 4 grams as a prophylactic tool.
And then she asks her whether we need to now discontinue the pregnancy. The answer to that is no. We don't need to discontinue the pregnancy. The patient may get temporized, and there are times where we have been able to extend this particular pregnancy to the tune of a fortnight or a month. Now, as associated other features also can be there, especially of HELLP, and usually the symptoms of vomiting in the second trimester, not feeling well, are also the signs which we have to be carefully looking for. Patient would present with abdominal pain, and it's sometimes wrongfully so, differentiated as gastritis or some other thing, but many a times it could be stretch of the liver capsule, the Gleason's capsule, and that's the reason why there would be pain and a sign of HELLP. So one has to understand that eclampsia is a hypertensive emergency because it is associated with end organ complications and with severe hypertension. And drugs for urgent control, therefore, what we have currently immediately at handy, and most of us are experienced in using, is the labetalol and the nifedipine. And labetalol has to be given in a titrated dose with proper understanding of the contraindications, and nifedipine should be given only if the patient is conscious, and if not, don't ever give it sublingually because it can cause complications. You can then consider giving the injectable labetalol. We all know that nifedipine is extremely effective, but it would be very difficult to give it for a patient of eclampsia. But in a patient who has severe preeclampsia, you can give it as a management of the hypertensive crisis component and be well versed with using labetalol, started with 20 milligram IV, titrated with blood pressure every 10 minutes to a maximum dose of 240 to 300 milligrams. And this is the typical protocol that we use. Hydrolyzing, however, is not available in our country. But if there is severe hypertension, one can consider giving in a conscious patient. She's not having eclampsia yet. You can also give her 200 milligrams of oral labetalol or injectable labetalol and nifedipine and correctly titrate the duration, the dose, and the BP monitoring. Now, there are challenges with use of hydrolyzine. I'm mentioning this here because some of the states in our country do have hydrolyzine. And there are certain disadvantages which include adverse effects which may mimic impending eclampsia or a syndrome characterized by HELLP. There can be maternal hypotension and fetal heart rate deceleration. And there can be possibly increased tendency to cause serious ventricular arrhythmias compared with labetalol in women, especially of eclampsia. Now you can see that this particular patient has been brought here in an emergency, and this can be a patient who is unconscious, has been wheeled into the hospital, and then various questions come to our mind. What is she really suffering from? So it can be epilepsy, it can be cerebral malaria, it can be meningitis or encephalitis, or it can even be a tetanus toxoid. But if the patient has a past history of normal blood pressure, and for that matter, any condition which is causing seizures during pregnancy, or any condition where the woman has been brought in unconscious, first diagnosis always has to be eclampsia, and then it has to be ruled out. So epilepsy, syncope, stroke, intracranial hemorrhage, hypoglycemia, and cerebral malaria can be diagnoses. Now, this is something, a typical question which I ask whenever I talk on eclampsia. You can just look at this picture and a video and write in the chat box as to, do you think that there is something amiss in this particular thing? Or would you want to answer something, which is the phase? It's a clonic-tonic convulsion. The problem is the position of the patient. You can see there is no respectful maternal care. And then you have to put her in a right nursing care. And you must also put in the gap properly. It has to be supported. Because you can see that if there has been a traumatic microglossia intubated with a lateral approach, you can see how much swelling this woman had to be undergoing, where she required to be intubated with a lateral insertion of the intubation tube. And it took such a long time for her edema to reside. So seizures will have typical phases, and it's a hallmark feature of eclampsia, a new onset tonic-clonic type of seizure, typically lasting for 60 to 75 seconds, followed by a variable lasting post-ictal phase. And this will cause an initiation of a cold blue in the hospitals wherever this facility is available. It's an absolute call for help. Eclampsia convulsions are life-threatening emergencies that should be cared in a proper manner in order to minimize morbidity and should undergo continuous intensive monitoring and not to be left alone in a darkened room. And there has to be respectful maternal care. And you can see how this particular woman has been kept in a little propped up left lateral position with the multipara monitors and the fetal monitor all in place. Infusion pump, which is delivering magnesium sulfate, so there is no unnecessary fluid overload, and another IV line also going in case she requires any help. And this is typically a setting of the Eclampsia room, where a patient is not in a dark room, but it is a properly well-equipped room, wherein now she'll be shifted and all the kind of drip would continue. Now, if the patient has thrombocytopenia especially, it's always prudent to give her an IV regimen. But the WHO recommends, and especially for transfer of the patient to a tertiary center, you are justified in giving the loading dose as per the Pritchard's regimen of 5 grams in each buttock. The problem with 5 grams in each buttocks is that it may not be very easily to retrieve if there are any magnesium toxicity, and plus it may cause a lot of pain, and sometimes abscesses have been noticed in this particular area. Quick lab investigations have to be done to find out what is the hemoglobin level, the platelet counts, the liver and the renal function tests, and serum electrolytes, especially in an unconscious patient, is a good idea. Look for hemolysis either by sending LDH or on a peripheral blood smear when you see the schistocytes, and perform a fundoscopy if possible, because that will help us in identifying what the problem is and what is the severity. Likewise, and this is just a demonstration of a delivery of an magnesium sulfate through an infusion pump, something which is very, very easily doable. Now, immediate action after this eclamptic seizure occurs is protect the patient, so restrict her with protection and support, and get a nice central line access, and can give her an loading dose of 4 grams of magnesium sulfate, and this you can give over 10 minutes of time, or even up to 5 to 6 minutes, and it can be delivered by an IV line through an 100 ml Ringer's lactate. And if the patient gets a new convulsion, a paddock tongue blade should be inserted between the patient's teeth to prevent tongue biting. Avoid stimulating the gag reflex with a blade as much as possible. Position on her left side, and foam and secretion from her mouth should be sucked to avoid a risk of aspiration. And auscultate the lungs after the convulsion was ended to ensure that there is no aspiration. So this is typically the eclampsia checklist which should be followed. And this looks busy, but I have put in highlights here. Call for assistance, designate a team leader, checklist, reader, and a primary care provider, left lateral gag and propped up, magnesium sulfate, ensure protection, protect the airway, plus improve oxygenation, continuous fetal monitoring, place IV, draw labs, administer antihypertensive therapy if appropriate, and develop delivery plan and debrief the patient and the family OB team. And maintenance dosage, if you are using the Pritchard's regimen, is 5 grams. So that's 5 ampoules of 1 gram magnesium sulfate, delivered intramuscularly with 2% of lignocaine at the tip to avoid pain, with a large bore needle of at least 18 or 16, 20 or 16, 18 or 16, so that the proper penetration in, because it's a very high specific gravity kind of a drug which is penetrating the muscle itself. Monitoring of magnesium sulfate is extremely important. Patellar reflex is always better. That is the endpoint usually from where the toxicity would start. So if the patellar reflex are present or not, you must see. Respiration is not depressed, so RR is more than 16. And urine output during previous 4 hours exceeded 100 ml, that is 25 ml hour, gives us an assurance that there is an adequate action and there is no toxicity. Serum monitoring of magnesium sulfate has been advocated, but is expensive and has not been shown to be superior to clinical monitoring. So this is a typical checklist: emergency treatment algorithm for eclamptic seizure, airway IV access, avoid maternal injury at 0 to 5 minutes. At 10 to 15 minutes, prevents a recurrence by maybe giving a little more top-up of magnesium sulfate. Continue the maintenance dose and obtain lab work, another bolus of 2 grams if necessary if there are recurrent convulsions. If there are refractory seizures, you may consider giving her lorazepam 4 milligrams or levetiracetam. Consider need for intubation, and after stabilized, prepare for delivery. Assess need to transfer to a medical center with medical ICU and or a neonatal ICU. Always remember the therapeutic and the levels of magnesium sulfate. So if the patient feels warm, flushing, double vision, slurred speech, it is 3.8 to 5 moles. Loss of tendon reflexes more than 5. Respiratory depression more than 6. Respiratory arrest 6.3 to 7.1. And cardiac arrest more than 12. So loss of, you can see, tendon reflexes would occur after 5. And the therapeutic level is between 2 to 4 millimoles per ml. So when the patellar reflexes get are obliterated, then we know that, okay, fine, we are going to a adequate dose of magnesium sulfate and try not to go and give any more dosages after that. So if respiration is normal, further dosages of magnesium sulfate should be withheld if the Patel reflex is absent. And if respiration is depressed, then management to be as said earlier. Magnesium sulfate can be restarted if considered necessary once reflexes have returned, but at a reduced dose unless there have been further convergence. Admist apply checklist, the Muse charts and the monitoring, and A, B, C, D, E has to be followed as has been shown here in this particular picture. You can actually show bleeding, CO2, circulation, drugs, magnesium sulfate, labetalol, and expose and explain. Discover the patient and then explain which should be the E. And then this is the typical PERT, that is preeclampsia early recognition tool. When the patient has been admitted for severe preeclampsia, these are the things which you should ask the nursing staff or your junior teams to see while they are monitoring the patient for blood pressure, alertness, respiration, pain in abdomen or chest, fetal signs, and urinary output, and the labs. And these are put in typical green, yellow, and red zones. So once the patient starts going through the yellow zone, it's always better to be on guard, and then accordingly the actions are taken. Now, if convulsions recur after 15 minutes, give 2 grams of magnesium sulfate IV over 5 minutes. Take 1 10 ml syringe, draw 2 ampules of magnesium sulfate into the syringe and give slowly over 5 minutes. Anticonvulsants alternative can be diazepam, phenytoin, and ketra, and minor side effects must be noted. If there is respiratory depression, stop magnesium therapy, give 1 gram calcium gluconate, give oxygen by mask, maintain airway, and recommend position. If there's respiratory arrest, stop the magnesium sulfate therapy, give 1 gram gluconate, intubate, ventilate, and it should be continued. If the urine output is less, then you may consider halving the dose of magnesium sulfate and keeping a watch of this patient. Be also looking at the fetal
Sorry for
monitors.
interruption, ma'am. We are enjoying listening to you, but the organizers want the things to be on time.
I can conclude it right now. Actually, just 2 slides are remaining, but if you want,
Yes,
I
ma'am.
can
Yeah,
stop
please
it right
continue.
now.
Please
Should I?
continue.
So you look at the maternal and the fetal evaluations, and there are definite indications where you must consider prompt evaluation and delivery. And once the patient is stabilized, now here stabilization means that the hypertension is controlled, there's proper seizure prophylaxis, and all preparedness for delivery, either a vaginal or a C-section, has been properly made. Special delivery decisions which are to be considered are especially in preterm babies, where you may take an advantage of postponing or delaying delivery, trying to buy an advantage of 24 to 48 hours, and especially identifying if she has and there are certain contraindications to delay delivery, as we are very well aware, and this should be undertaken. You may have to consider invasive hemodynamic monitoring if the patient is very, very sick, and be very careful with fluid management, because most of the times these patients die because of pulmonary edema, and this can, despite giving proper fluids, so therefore measured fluids have to be given, and you can consider giving concurrent furosemide. Hepatic complications are very commonly associated with eclampsia. Likewise, there can be chest complications, and an X-ray chest would help us in differentiating and diagnosing. If you're given a massive transfusion protocol, they can be TRALI. There can be cardiovascular complications also, which we have to be sensitive to, especially cardiomyopathies and acute myocardial infarction. And one has to remember certain drugs, if they are not properly given, like beta mimetics or extreme diuretics, which can cause pancreatitis. Some ligament nifedipine can cause problems. Be careful of all patients who have severe hypertension in their postpartum time, because they may show a convulsion, and while the patients are ready to go home, they can have problems. Now, this is, you can see a patient who has presented after remote from delivery with all the signs of eclampsia, and it showed later on that it was a vasoconstrictive syndrome, such as vasculitis. So can we prevent all these conditions? As my predecessor, Dr. Charmila, said, be very vigilant with your patients, apply the Gestosis score, try to be predictive and preventive as much as possible, and we can definitely save women. Be sensitive to the symptoms, always be ready with your checklists, and always replenish your magnesium sulfate box. Thank you for giving me the patient hearing and also the extension of time. Unfortunately, I think the network has been a problem, and thank you so much. And wish you all the best, Dr. MC Patel, for your election. I want you to be next up.
Thank you so much, madam. Thank you so much for the wonderful presentation. We'll just move ahead as we are short of time, so we'll just move to the next speaker. I would like to invite our next chairperson, Dr. Arun sir, to invite the next speaker, Dr. Chelam. Over to you, Dr. Arun sir.
So, Ami, is it expired?
Hello,
Hello.
Dr. Arun sir.
Yeah, I'm audible.
Yeah, yes, sir. Yes, sir. Please.
Okay, the next speaker is Dr. Chelema. In fact, there is some disturbance at the airport. Excuse me for that. We have she is professor and head OBG MCT Medical College, Kozhikode. She is former professor of OBG, Government Medical College, Alappuzha and Kozhikode, Honorary Secretary, Calicut OBG Society, 2004 to 8. She is President, Calicut OG Society, President, Kerala Federation of OBG. She is Secretary, IMS Calcutta Chapter, IMS Endocrinology Committee, Chairperson, IMS National Quiz Committee Chairperson, Chairperson of IMA Women's Wing Kozhikode. She is a fortune peer reviewer. She has about 25 national and international publications. She is undergraduate, postgraduate teacher, and is an examiner, faculty for national and international conferences. She has fellowship from ICOG in 2013. Madam, the floor is yours.
Hello. Hello.
Hello.
Hello. Am I audible?
Yes, madam, please proceed. You're audible.
Okay. Please share my slides. Mr. Vasu. Good afternoon to all of you. I am very much thankful to Dr. MC Patel for inviting me to this special webinar on high-risk pregnancy. Thank you so much, sir. So we had seen that previous speakers have mentioned they had given excellent talk on preeclampsia and also eclampsia. Now my talk is there is a variant of preeclampsia or as a special entity and also and very complicated condition and a very serious condition where we have to give emergency care and also that is associated with high morbidity and mortality as such the perinatal mortality is also increased. Next slide. Next. Now, this is a famous quote by Louis Winstein, and the light dawned on me that what those women needed was what this entity should be called. Therefore, the term HELLP syndrome was born. This in 1982. Next slide. So the term acronym HELLP was coined by Louis Winstein in 1982 to describe a syndrome consisting of hemolysis, elevated liver enzymes, and low platelet count. Next. It may represent a complication of or progression of severe preeclampsia. This relationship has been challenged by recent evidence that this may occur as a separate disorder of preeclampsia, even without sometimes hypertension or proteinuria. As preceding hypertension, proteinuria is absent in at least 50 to 20% of patients with HELLP syndrome. A previous history of preeclampsia or HELLP syndrome can lead to recurrence in subsequent pregnancies. Next slide. Now coming to the epidemiology, HELLP syndrome has a prevalence of 0.5% to 0.9%. About 70% of cases can occur in the third trimester of pregnancy, and the remainder occurs in the postpartum period within 48 hours of delivery. And the mortality rate women with the HELLP syndrome is up to 24%, with a perinatal death rate up to 37%. Next. So multiparity and adverse maternal age can contribute to increased risk of HELLP syndrome, and genetic association or increased predisposition to HELLP syndrome has been noted, and it has been recently reported that patients with SARS-CoV-2 infection during pregnancy has an increased risk of preeclampsia and HELLP syndrome. Next. Now, coming to the classification, there are two classifications. One is the Tennessee classification, and the other is the Mississippi classification. And this is the Tennessee classification is based on the laboratory criteria and platelet count less than 1 lakh per liter, and AST equal to or more than 70 international per liter, and LDH equal to or more than 600 international units per liter. And the third important component is the hemolysis, which is dictated in the peripheral smear. And if all three are present, that is full HELLP, and if only two of the three are present, that is called partial HELLP. Next slide, please. Next. So coming to the previous one. Coming to the Mississippi classification, that is class 1. That is all depending upon the lab criteria, and also that is a hemolysis. But the most important criteria here is the platelet count level. Class 1 is the severe type of HELLP syndrome, that is severe thrombocytopenia, that is less than 50,000 or equal to less than or equal to 50,000 lakhs, and AST is equal to or more than 70 international units, or LDH equal to or more than 600 international units per liter, and the hemolysis on peripheral smear. And class 2 is moderate type. Here again the platelet is 50,000 to 1 lakh, and AST and LDH are in the same level. Hemolysis is detected in the peripheral smear. Next slide. And this is a class 3, is the mild form of HELLP syndrome according to the platelet level. It is 1 lakh to 1.5 lakhs, and AST and LDH are AST is equal to or more than 40 international units per liter, and LDH equal to or more than 600 international units per liter, and hemolysis seen in the peripheral smear. Next. So coming to the history, usually the main gestational age where the patient comes to with the HELLP syndrome are between 28 to 37 weeks, or immediate postpartum period within 7 days of delivery. And the clinical presentation may be varied in patients with HELLP syndrome and present with epigastric pain or right upper abdominal cotton pain associated with nausea, vomiting, and fatigue. The associated features may include jaundice, which is very important, and headache, edema, and visual changes, and may present with severe bleeding, abrasive placenta, acute kidney injury, and also liver hematoma or retinal detachment. Next slide, please. And coming to the physical examination, most patients may have hypertension more than 140/90, and also may have ascites or pleural edema. But patients, I had seen patients with normal BP coming with HELLP syndrome. And right upper quadrant or epigastric tenderness is noted, icterus is present, and visual disturbances may be present. Next. So the most important is the lab examination, and the complete, it includes a complete blood cell count, that is GBC, coagulation studies, prothrombin diamond, APTT, peripheral smear for hemolysis, that is you can see histiocytes, Hermet cells, Burr cells, and secondary to microangiopathic hemolytic anemia. And LFT, the most important is according to the classification also, we have to see AST, ALT, and LDH. Renal function test, blood urea, serum creatinine, bilirubin level increase secondary to hemolysis, and hemoglobin level decrease secondary to hemolysis, and fibrinogen level low secondary to increased coagulation, and D-dimer increase due to fibrinolysis. Next, please. So coming to the imaging studies, ultrasound of the liver may reveal increased sarcogenicity or irregular, well-demarcated areas in the liver suggestive of necrosis. And CT scanning MRI should be obtained to rule out subcapsular hemorrhage of the liver, and also echocardiography should be done because we have seen a lot of vascular changes which may occur in preeclampsia. Next please. Coming to the fetal evaluation, this condition may be, especially with severe preeclampsia, may be associated with FGR, and biophysical profile and proper study should be done to evaluate the fetus. Next one. Next, please. Now, HELLP syndrome is a life-threatening condition with high maternal and infant mortality rates. So there are associated with many complications, maternal and fetal. Next slide. Next one. So the maternal complications are mainly the eclampsia, which we had a detailed lecture on eclampsia now, and the placental abruption, cesarean section, DIC, thrombosis, liver rupture or hematoma, fulminant liver failure, cerebral infarction, cerebral hemorrhage, pulmonary or cerebral edema, cardiovascular instability, acute kidney injury and infectious or sepsis, retinal detachment and severe peripartum bleeding, and may be associated with high mortality rate, that is maternal death is associated. Next. Now coming to the fetal complication, perinatal death, fetal growth restriction, preterm delivery, and neonatal thrombocytopenia and neutropenia, leukopenia, and also respiratory distress syndrome. Next one. And coming to the differential diagnosis, it may be related to pregnancy or may not be related to pregnancy. Diseases related to pregnancy are benign thrombocytopenia pregnancy, acute fatty liver of pregnancy, AFLP. So here the most important differentiating factor is the examination of the blood sugar value. The blood sugar value is very low in AFLP, which can be differentiated from HELLP syndrome. Infectious and inflammatory diseases not specially related to pregnancy, that is viral hepatitis, cholangitis, and polycystitis. Next one. Next. And thrombocytopenia, immunologic thrombocytopenia, that is ITP, folate deficiency, and SLE, and also antiphospholipid syndrome. And rare diseases that may mimic HELLP syndrome are thrombotic thrombocytopenic purpura, that is TTP, and hemolytic uremia syndrome. Next slide. Now coming to the management, it's a very important part of HELLP syndrome, very crucial because to reduce the maternal morbidity and mortality. So these patients are very, very high risk cases and should be managed in a tertiary care center only. If this type of patients are in the periphery, they should be transported to a tertiary care center with well support, ventilatory support, or the oxygen support, etc. And HELLP syndrome requires input from a multi-specialty team that include intensive care and the anesthesiology, pediatrics, the fetal medicine specialists, hepatology, surgery, nephrology, hematology, and ophthalmologist. All this team work will help to reduce the maternal morbidity and mortality. So the most important I consider is the transfusion medicine department, because many of these patients may require massive blood component transfusion. So we cannot forget about the nursing care support, nursing, and also the paramedical staff, which may help us to manage these patients. Next slide. Next. The first step in the managing this seriously ill patient is stabilization of the patient. And this should be done with the help of the emergency department care. Ventilatory support should be there, avoid fluid overload to prevent pulmonary edema, and control of hypertension by IV labetalol, anticonvulsive therapy with magnesium sulfate. And this also helps for the neuroprotection of the fetus in preterm babies, and blood components transfusion if needed, especially if there is DIC. Next slide. Now, management is mainly supportive in patients with DIC, pulmonary edema, acute respiratory failure, and acute kidney injury. And massive transfusion may be required, as I mentioned earlier. Consider patients for RBC packed cell transfusion if hemoglobin is less than 7 gram per deciliter, or the patient has ecchymosis, severe hematuria, suspected placental abrasion, etc. And blood components, apart from the packed cell transfusion, we require FFP, flash frozen plasma, and platelet transfusion. Next one. Next slide. Now, meanwhile, we have to evaluate the mother and the fetus with blood investigations, that is the all the initiations I have mentioned, and also the USG or CT if needed. Next slide, please. Now, coming to the, I think the heading is not seen, that is a corticosteroid therapy. It is controversial. Studies have demonstrated that improved laboratory findings include improved platelet counts, liver function tests, and blood pressure, urine output, etc., with high dose of dexamethasone. But the Cochrane review shows that it is a study with or with no treatment. There was no difference in the risk of maternal death, and also severe maternal morbidity and perinatal or infant death was not much reduced, no difference at all. The only effect of treatment of individual outcome was improved platelet count. Next slide, please. Next. No, before that, previous. So we know that the mortality and morbidity is very high as well as the perinatal mortality. So the definitive treatment of HELLP syndrome in the antenatal period is termination of pregnancy irrespective of the gestational age. Next one. Next slide. So vaginal delivery is preferable. CS is only indicated if, or in indicated cases or if the labor is prolonged. Arrange sufficient amount of blood because we expect PPH or DIC may be there. And if there is DIC, complications of hematoma of abdominal wall and also the side of the uterus may be there. So sufficient amount of blood should be arranged if you are planning for cesarean section. Next slide. So monitoring is very important even though the patient has delivered. Very close monitoring is required in HELLP syndrome until delivery and in the postpartum period. And the laboratory test should be repeated every 12 hours interval. And AST and also LDH is very high. It may suggest increased maternal mortality risk. Next one. Next one, please. So coming to the surgical interference, emergency laparotomy is by a general or vascular surgeon if there is hepatic hematoma or hepatic rupture, and hepatic lobectomy or embolization or of the hepatic artery, and liver transplantation in patients with the total hepatic necrosis with severe HELLP syndrome. Next one. So management summary, if HELLP syndrome is diagnosed, immediate delivery, corticosteroids is less than 34 weeks for lung maturity, and antihypertensive and magnesium sulfate if indicated. Labor must be induced with prostaglandins according to the Bishop's code. Proper monitoring of the mother and the fetus. Check the lab values, LFT, RFT, platelet count, and protein time, etc. Platelet transfusion if the platelet is less than 20,000 per cubic millimeter. Active management in the third stage of labor. Check for PPH. If no progress of labor, only arrange for a cesarean section with sufficient blood is arranged along with that. Next slide. Next. So delivery and supportive management and blood components therapy, FFP, PRP, and PRBC, multidisciplinary approach and management in a tertiary care center with critical care team. Next one. Next one. So the HELLP syndrome is a life-threatening condition. The mortality rate was very high, up to 24%, and the infant mortality rate, perinatal death is 37%. The causes of maternal death are usually DIC, placenta abrasion, postpartum hemorrhage, and acute renal failure. Poor perinatal prognosis is because of placental abrasion, intrauterine hypoxia, asphyxia, and prematurity or low birth weight. Next one. Next slide. Now coming to the recurrence. Patients with HELLP syndrome have 19 to 27% of risk of developing HELLP syndrome in the subsequent pregnancies. Recurrent cases occur in the latter part of the gestation period and are less severe after 2 episodes. Next one. Next slide. And the patient education and interference. The patients with HELLP syndrome should be educated about the cause of the disease, risk of maternal and perinatal complications, and also about the mortality and the risk of developing HELLP syndrome in the subsequent pregnancy. So they have to arrange, change their lifestyles and prevent the disease such as hypertension or diabetes. Routine prenatal care and laboratory testing must be initiated immediately in the subsequent pregnancies. Next one. And this was a study from India that is from Punjab. It was a prospective study was conducted in the Department of OBG in Amritsar, and they studied 352 patients with preeclampsia, and out of this, 71 complicated with HELLP syndrome. Their incidence was 20.17%. So I think it is a high incidence of HELLP syndrome in this study, and majority of the patients presented after 36 weeks of gestation. Only 5 patients in the postpartum period. Severe maternal complications like PPH, DIC, abrasive placenta, pulmonary edema, and renal failure, and seen high along with the HELLP patients. And they concluded early diagnosis and treatment can be initiated. Close surveillance of the mother should be done and continued even after delivery. Next slide. So this was a study conducted by myself in the Calicut Medical College, and this was here the study patients were included more than 28 weeks of gestation. Next one. Next slide. And this the chart shows the different outcome of the studies, and here the percentage was only 0.3%. Next one. Next slide. And here also the complication, maternal complication, main complication led to renal failure, and here are 2 maternal deaths due to HELLP syndrome. Next slide. And the results to summarize, that is the present study, the HELLP syndrome was only 3.32%, and the main maternal complications were eclampsia, renal failure, abruption, PPH, and coagulation failure, hepatic rupture. There were 2 cases of maternal death. So the take-home message from the study was, even with better management options in a tertiary care center, HELLP syndrome continues to be an obstetric emergency with high maternal and fetal morbidity and mortality. So high suspicion, early diagnosis, management of HELLP syndrome in consultation with the multi-specialty team, and it is a goal to prevent maternal and fetal complications. Next slide. To conclude, HELLP syndrome, that is hemolysis, elevated liver enzyme, low platelet, probably represents a subtype of preeclampsia with severe features of hemolysis and the abnormality in the liver enzymes and thrombocytopenia, and should be managed in multidisciplinary team in a tertiary care center associated with high maternal morbidity and mortality, and also perinatal mortality. Women with HELLP syndrome are also at increased risk of pulmonary edema, acute respiratory distress syndrome, and renal failure. Next slide, please. Next slide. Thank you. These are all my references, and thank you. Thank you for your patient care.
Thank you so much, ma'am. It was wonderful presentation. I would like to, at the end of the session, I would just like to thank all our chairperson, Dr. Anupama ma'am, Dr. Tabasu ma'am, and Dr. Arun sir, and also our great speakers, Dr. Charmila ma'am, Dr. Girija ma'am, and Dr. Chelama ma'am. Thank you so much for the wonderful presentations and spreading a great knowledge. As we all know, we are just lot of time, so we'll, without wasting time, we'll just move to the next session, to the next oration.
Hello.
Yes, ma'am.
Thank you so much, our respected chairpersons, definitely for sparing their valuable times and giving their feedbacks. And thank you so much for all the speakers for that wonderful, crisp talk. We are all really delighted with that. And definitely, when we talk about the HDB, it is really a alarming situation. So over to you, Dr. Madhav, for the further proceeding.
I would like to call our next coordinators for the next session, Dr. Neelaj sir, Neelaj Bagde sir, and Dr. Venus Bansal ma'am.
Am I audible?
Yes, sir. Over to you, sir.
Okay. So
Thank you,
Dr. Madhav, and for inviting us. So thank you, MG sir, for organizing such a wonderful seminar today. So we are eagerly waiting for the next oration by Dr. Sanjay Gupte sir. So I request my coordinator, Dr. Venus Bansal sir, Bansal madam, to kindly introduce the chairpersons for this session. Dr. Venus.
Good afternoon, everyone. And yeah, this is a very, very interesting session going on. And we are very thankful for MC Patel, sir, for bringing everyone together on such a huge platform. And I would like to just tell that Dr. Chandravati ma'am is right now busy in an emergency. So she won't be able to join up. And we will be inviting Dr. Kavita Singh ma'am for chairing the session for our great Bhishma Pitama of Obstetrics and Gynae, Dr. Sanjay Gupte sir, and the chairperson in this session is going to be no other than Dr. MC Patel, whom we look forward for every situation, day in and day out. So Dr. Kavita Singh is working at GMC Bhopal. She is a professor and head and has been a great experience, list of experience in her CV. I'm just going to read few of it. She is having IACA Fellow Gynec Oncology from New York and Tata
You can
Memorial.
skip, Venus. You can skip because we are already too late.
Perfectly, ma'am. I will just say that she is Foxy Duru Shah Community Service Award and many other awards she has received. The second chairperson of the day is Dr. MC Patel, sir. We wish you best of luck for your election and would like to invite Dr. MC Patel to please introduce the speaker of the day of this particular session.
Thank you, Venus. As you rightly mentioned, Dr. Chandravati madam is held up in one emergency. So I am taking that honor to introduce Dr. Sanjay Gupte. Sanjay Gupte, as all we know, he is very senior gynecologist and obstetrician from Pune and more than 44 years of experience in the field at Sanjay Gupte Hospital in Deccan Gymkhana, Pune. He is past president of Foxy and he is also a member ICOG and RCOG. And overall, there is a long list of achievement on part of Dr. Sanjay Gupte. But overall, and if I go in a very brief, he is a great person, gem of person, I would say, and friend of so many of us. And he is always ready to assist us, to guide us in any of our given situation. So, welcome, Dr. Sanjay Gupte. And over to you, Kavita Singh, madam, for opening remark as far as this oration is concerned. Kavita Singh, madam.
Yes, yes. Good afternoon to everyone. At the outset, I would like to congratulate you, Dr. Patel and Dr. Alpesh Gandhi, for this wonderful summit which is going on. And as I've been invited to chair a session, let me have the topic. Just a minute.
It's prevention in prevention of high risk pregnancy or tips and tricks.
Yeah, prevention of high risk pregnancy and tips and tricks. Which and there was I was seeing in the flyer that there was a question mark. Can we really prevent them? So it's a huge question, and we all know that how difficult it is to prevent 100%. So to speak on the topic, we have none other than past President Dr. Sanjay Gupte. I'm sure after listening to Dr. Gupte, there will be the doubts as far as the topic is concerned, and how far we can predict and prevent high-risk pregnancies. Dr. Gupte is, I don't think he needs any introduction. He's known for years and years in Foxy for his continued services. I recall in 2010 when there was a huge camp we organized at Mandla for cancer prevention and Rahat camp. That time he visited Jabalpur and Mandla. So I'm honored to invite you, sir. Over to you, Dr. Sanjay Gupta.
Thank you, Kavita ji, for those very kind words. And yes, I do remember that, the camp that we had, a huge camp, which was organized by all of you there, So, and MC Patel, sir, of course, a very close friend. So what can I say about him? Absolutely a wonderful, genuine person. As we are running, let go directly to the topic.
Yes.
Now, I'm sure people are surprised to, have this topic, that how can we prevent the high-risk, pregnancies? Because you are hearing today the whole day wonderful talks by eminent speakers, and the conditions are so intricate, and even leave aside preventing these conditions, but properly managing these conditions, like you just heard, HELLP syndrome and preeclampsia and all that, it is life-saving, definitely. And that is what we have been taught all along. What after being in practice for such a long time, one starts wondering, yes, we always go after, treating a condition when it occurs. We diagnose it, we are happy that we have diagnosed something, and then we want to go ahead and treat it. And once we have treated it, we feel great that, life saved and all that. But somewhere, I think the missing link is that why not to prevent a condition which we know can be life-threatening? It may not be possible every time, obviously, but at least are there any new tools in our hand? Anything else that we can do to prevent these conditions is something that at least those who have been in this field for a long time. You may be in any medical field for that matter. You may be an endocrinologist. You may be like Kavita ji, great oncologist. But still the question remains: yes, we do a great job in treating these conditions, and that's how we have reduced maternal mortality to a great extent in our country. But can we go ahead a little further and try to prevent some of these conditions? And that's just a a kind of a thought that I want you to pick up throughout this particular talk. So let's see, what is high-risk pregnancy? A high-risk pregnancy is one in which woman and her fetus faces higher than normal chance of experiencing problems. And these risks may be due to factors in the pregnancy itself, or they may stem from the pre-existing maternal conditions such as cancer, diabetes, and what have you. And events that occur during pregnancy may also lead to high-risk status. So many factors, including that which affect mother and also the fetus, can lead to high-risk situation for mother or the fetus. And that's where we have to think of something that then can we think about anticipating it, because if you have to prevent something, then you have to anticipate this condition, and then only you will be able to think about prevention. And why not to start with very basic risk factors, for that matter, that all of us have learned in second MBBS itself: ethnicity, socioeconomic status, parity, nutrition, age. But do we really give importance to these factors when we are looking at a particular case? Because it's just written down somewhere at the top of the case paper, and we all mostly forget these risk factors. So let's look at it in a different view. Look at it as ethnicity and race. Why should we know that? Because these are the surrogate measures which stand for even the lifestyle issues of a particular person, and even the living conditions, standard of living conditions of in many situations. And between that also, if we look at further, there are marked variations which occur in cultural beliefs and practices, language, household structure, sexual behavior, contraceptive patterns, general health, perception of illness and disease, childbirth. Everything differs according to the ethnicity, race, and the background of that person. Do we consider this as important, or shall we consider this as important? Should we give more time to look at this in the history taking? Because come to think of it, every single thing matters, even what is the occupation of that person. This has again been taught to us in second MBBS when we are taught to take the history of the patient. But as we go ahead, we are so clinically so-called oriented that we forget that these issues are very important and should not be missed on. Same about socioeconomic status. We are, both kinds because of, overindulgence. There are problems now like drugs and smoking and, other things, obesity, but there are also problems of poverty which lead to perinatal mortality, preterm labor, FGR, and so on. Parity, of course, we have been taught about, young, adolescent being different and grand multipara having her own problem. Age, again, teenage pregnancies, which are increasing even in Europe, we see lots of teenage pregnancies now, and in our country also, in spite of the legal ban, they're still there, the early marriages still happen. And of course, we have gone to the other end also, where now the IVF couples, come at age of 39, 40, get their IVF done, and the problems with that advanced maternal age is entirely different. But do we give importance to all these issues as we are seeing the patient for the first time? Is my question to all of you, that can we start anticipating these problems right from then on, leave aside after or during pregnancy? And then the biggest thing that we have missed out on in medical education and teaching of our students is nutrition. We have left the nutrition to the nutritionists, and that's really, really sad, because nutrition probably makes the most important part of our management, and about which we are never, at least at our time, we were never taught anything in details about why that is important, how metabolism occurs, and how it is to be correlated with the day-to-day eating habits of the patient, and how can we modify. So this itself, I think nutrition has to come to the fore now. The WHO has woken up just a few years back now, and now they have nutrition checklists for pregnant ladies, and FIGO also has worked on it, and we have these, but the recognition has come, I believe, rather too late. And as we go along, I'll tell you why this is so. Again, underweight and overweight issues in pregnancy. I won't go into the details of it, because we have a lot of points to discuss. And then the pre-existing factors, maternal factors like diabetes, chronic blood pressure, thrombophilia. These are inherently high-risk pregnancies, and that's why it is important to anticipate, and the high-risk part, whenever it's possible, to at least, if not prevent, we should be able to reduce. And these are some of the other conditions. Not only that, but there are fetal factors. And the fetal factors also can make either pregnancy high risk or the pregnancy high risk for that fetus itself. And these are conditions that we have to look at. The fetus may be having its own, genetic problems, which will lead to fetus being vulnerable and leading to that way a high-risk situation in pregnancy. So apart from that, now very common cases that you all must be coming across now, repeated pregnancy loss. Somehow I find in my practice that these situations have increased, definitely. And we have to look at it. Why have these conditions now increased? Of course, stillbirths are there, they've been there, but then just now we talked about preeclampsia and HELLP syndrome, placental abruption. You'd wonder why. Can placental abruption be prevented? Yes, of course it can be prevented. Folic acid and the nutrition plays a huge role in that. Abnormal placentation, premature rupture of the membranes, or preterm labor. All these issues we have to look at now in a different manner. What do we find more in our country? Anemia, hypertensive diseases or gestosis, bad obstetric history, or again, repeated pregnancy losses. Then gestational diabetes, grand multiparas, antepartum hemorrhage, heart disease, multifetal pregnancies, congenital malformations have somehow now found to have increased, and recurrent pregnancy loss, previous cesarean sections have increased, and obviously with that, second time problems or third time problems have also increased. Fibroid uterus, because the pregnancies are now in later age, and then malpresentations and so on. So the question is, can we prevent these high-risk pregnancy situation? As we have seen, on some, we may have some control, but on the others, we do not. But today, I want to discuss with you some of the new tools that we have in our hand, which may in future help us in preventing many such high-risk pregnancies. And these are genetics, epigenetics, and microbiome. And let's see what is this, future tools. Shouldn't actually call them future tools because they are available now to us, and we can start using them properly to, prevent these high-risk situations. So prevention has to start before conception, isn't it? Because then only we can really prevent. So preconception, and this is where preconception screening is important. Now, what kind of preconception screening we have? The simple screening for the diseases that we commonly encounter, like say hypothyroidism, can be just history taking. Again, as I said, where is the patient from? Because there are geographical areas in our country where we find hypothyroidism, goiters more common. We need to go into the history. We need to ask the patient about symptoms, which are many times not looked at. History of mental retardation in the family, previous birth history of recurrent. So many of the things, then the history itself can lead to that. And of course, and that's why we all advise universal screening, even preconceptionally, as far as hypothyroidism is concerned. Then again, there are situations where we have 58.7% women in anemia. Is it so difficult to anticipate and prevent anemia? Really not. But why it doesn't happen? Because we only like to treat the patient after diagnosis, and we are not able to do much as far as prevention is concerned. How can we prevent? Well, right from school and adolescent age, if we, what I was talking about, nutrition, if we insist on a proper nutrition, I think this condition we should be able to prevent by the time the patient comes to ask for pregnancy. But apart from that, what can we do? There are now, as we said, a lot of genetic problems that patients have, and there are so many things that we can screen genetically. What we have seen is over 15 million people have single gene disorders. Over 1 million babies are born with genetic disorders. 20 to 30% of all infant deaths are due to genetic disorders, and 1 in 100 babies are born with inherited diseases. So these figures may surprise you, but this is the standard worldwide evidence that we have, because we feel that rare diseases are rare, and why should we go around diagnosing? But rare diseases may be called rare, but when you take the world population or our population in our country, the genetic problems are not uncommon. What can we do for that? There is a preconception genetic screening available to us, and called as carrier screening test is done to know whether unaffected parents, the parents who apparently may look normal, carry any risk of having a child with inherited recessive disorders. We don't have time to go into so many of these, what are the recessive disorders, but recent advances in DNA sequencing and bioinformatics have led to an approach for identifying carriers of known mutations that cause more than 400 recessive genetic diseases. So when do we carry out? Obvious reasons, obvious history, like that is given here. A couple may be planning a natural pregnancy or especially ART treatment. One has to think whether these patients are carriers. Now we have many times, sperm donors or egg donors. Do we ever, test them for being carriers? And then we'll end up in trouble, and then one can have high-risk pregnancy, which later on has to be treated. So in all these conditions, it's important that we think about carrier testing. See, what is important about these genetic tests now, the cost has come down so much that there is no reason that why we should say, oh, this is very costly. Only the problem is availability of that test. the tests still are not available because the instrumentation is not there. But again, this is not a unsurmountable problem at all. And especially in our country, thalassemia is very common. Duchenne muscular dystrophy, Fragile X syndrome, and spinal atrophy are known genetic disorders in Indian scenario. Well, there is something now called as expanded carrier screening, and these panels can test for more than 400 different single gene or multi-gene disorders in a population. So is prevention impossible? No, but we have to start thinking differently. Rather than spending all the money and treating and all that, why not allot some of that? Even I'm not saying only for the individuals, I'm saying for the whole health system. And that is what in now advanced countries they're doing, that for prevention, they're giving more emphasis. Then there we have pre-implantation genetic testing. So pre-implantation genetic testing is possible in many of the situations. I will not go into the details of it, but we get babies who are labeled as mentally subnormal, and when you go into it, sometimes one realizes that the baby cannot hear properly. There's congenital deafness, GJB2 gene is mutated, and because obviously the baby couldn't hear, baby couldn't speak, and that's why it was labeled as mentally retarded. This is not a improbable scenario. So genetic screening, pre-implantation testing are important. PGTA, PGTM, I will not go into the details of it, but the embryos now can be tested for all these conditions. And even if IVF is going on, or if the condition is known, then patient can be taken for IVF with all an embryo being screened for either monogenic disorders or aneuploidies, and only the good embryos are utilized. Prenatal genetic testing, of course, we know that the baseline risk of some birth defects is 3 to 4%, and that's why prenatal diagnosis has become important, especially now when we have patients at advanced age, health conditions such as diabetes, obesity, exposures to teratogenic factors such as alcohol and viral infections. Then we have to think about prenatal testing. NIPS test or cell-free DNA is currently material of choice. Again, because the costs are coming down so much, it should, instead of doing the markers, I think this is the test which is also being advised by ACOG and ACMG because it's useful. Even RH sensitized patients, NIPS can help us in finding out what is the maternal RH genotype and treat accordingly. Now this test is advancing, and other chromosomal abnormalities also it will be able to tell us in many situations. Then we come to, again, something we many times feel that, yeah, we'll treat this condition. What is this condition? Recurrent pregnancy loss. But many times it is unexplained or labeled as unexplained. So diagnosing the etiology, providing the risk for offspring and PGD option, and also implications for other members in this situation are important. So can we identify genetic cause? Can we tailor the treatment? Can we plan the family accordingly and reduce emotional stress and improve success rate by personalized counseling in this situation? Yes, all this is possible. And how do we do that? There are genetic testing possible in this situation. The POC chromosome microarray can be done. Karyotyping of POC can help us diagnosing. Then fish and genetic single gene mutations, and of course parental karyotype all help in correct diagnosis and future treatment of these patients. And when assessing a new patient with 2 or more spontaneous losses, it's important to obtain POC karyotype and also later on if required, genetic testing of the parents. Then testing products of conception, it's not at all costly or difficult to do that. that at least gives us the diagnosis in many cases. And even if the patient cannot afford the DNA, extracted can be preserved for many years, and that cost as less as only 1,500 rupees, which I don't think is a big task for anyone. In future, if patient has further problems, this can be analyzed later on. So parental genetic testing also becomes important in RPL situations. So are single gene defects. We feel that single gene disorders are not common, but as you can see in these papers, there are so many single gene disorders which lead to such problems as repeated pregnancy loss. We feel that immunological causes there for rejection, but the immunological gene defects also can be identified, and then rather than treating at random or some a sort of unproven treatments, one can use mutation testing and find out whether these testings are needed. Thrombophilia gene defects are comparatively very common in repeated pregnancy loss, and especially what we have found in our studies that in Western countries, factor V adenine mutation is common. In our country, plasminogen activator inhibitor is quite common. So are MTHFR mutations. That is peculiarity of our population, and that's why the folic acid that we give sometimes is not effective and not utilized by the patient's metabolic issues. Then reimplantation genetic diagnosis we have already discussed. Let's look at some of the case studies in this. Non-consanguineous couple presented with history of RPL with an unknown cause. Reproductive history revealed fold myths, abortions during 8 and 11 week of pregnancy. Genetic analysis of product of conception was not done in these cases, but the couple was advised to go for karyotyping, and the male partner's karyotyping revealed balanced chromosomal translocation. So karyotyping helped identify the cause of the disease, and further counseling accordingly would be done. Another case, a couple with normal karyotype and 3 miscarriages, the product of conception analysis was normal, so the couple was advised to go themselves for microarray testing, and microarray test identified pathogenic copy number loss of 3.5 kb on X chromosome in the mother. So again, microarray test helped identify the cause of miscarriage in the couple, and accordingly the further steps can be advised. Now, so far we have been talking about gestosis or hypertensive disorders of the pregnancy. Okay, now I'm not going to go into what these conditions are. You have heard wonderful talks in the morning about it, but are there genetic aspects of preeclampsia or gestosis? Of course, familial incidence is noted by Chelsea in 19th century. Women with first-degree relatives with PV have 5 times more risk of developing the disease, while those with second-degree relatives have their risk double. Paternal genes also play an important role in development of PE, and this is evidenced by increased risk of PE in preeclampsia in patients with pregnancies of men who have previously been involved in pregnancies complicated with preeclampsia. Fetal genotype is important, and also home donor pregnancies show high incidence of preeclampsia. So all these points towards genetic aspect of preeclampsia. So can we not identify it even before pregnancy is the question. So what are called as candidate gene approach has been taken, and some genes, predominant functional genes have been identified. And these are the genes, because these conditions like thrombophilia, endothelial function, vasoactive proteins do play a role in, actual why preeclampsia occurs. And if that is so, we should be able to diagnose these mutations even beforehand. Can we do that? Certainly we can. And then we can even estimate the risk even before of that particular patient. But why only genetics? Epigenetics is important. What do you mean by that? That genes have to be expressed in a particular way. And sometimes gene expression is changed because of environment. As I was talking about, maybe lifestyle issues, then nutrition, So all this can sort of modify the gene expressions, and that's why epigenetic changes are also important. There is something called as a methylation, DNA methylation. When methyl group is added to the this particular the basis of the genes, then that gene may be either expressed or it may be either shut off, and the expression will not be there. And that's why all these conditions now can be studied by these DNA methylation testing. And if we are, because epigenome can be modified, and again, as I said, with various situations, and that's why we are able to find detailed treatment for preeclampsia and gestosis now, rather than just giving symptomatic treatment that we have been giving before. So there are studies identify the clinical relevance of genes in preeclampsia, and accordingly the various groupings can be done even before pregnancy on this, or even if we have a placental data set, that can also help us in detecting and classifying these patients or studies. I will not go into the further details, but this is the study that I would like to point out. We are looking at all these pathways, as one can say, and these pathways are dictated by the gene mutation and the epigenetics. And if we study the pathway with this, we expect that we'll be able to predict preeclampsia either much early in the pregnancy or even sometimes before pregnancy. And that's the kind of research that is quite exciting, and I'll let you know as the results are there. So also in our study, we use microbiota study, and we do the vaginal samples of the patients in first, second, and third trimester. And we have seen that from first trimester to third trimester, there is a shift in the population of various lactobacillus species. And believe me, there are hundreds of lactobacilli species, and their relation to each other and other microbes matters. So people have done the studies on preterm labor with this vaginal microbiota, and what is found, that one can again predict the preterm labor by doing this vaginal microbiome studies, because they go on changing as the chances of labor come there. There is a genetic test also. A panel of genes have been identified which, when mutated, lead to preterm labor. So I talked about microbiome. What is it? Some of you may not know why this microbiome is important. These are trillions of microorganisms which are all over in the body, and especially in the gut and vagina and all the different cavities. And they matter because our genes are only 20,000-30,000, and 10 times more genome of these organisms our body utilizes for metabolism and for our immune system. And that's why these form extremely important part of our body. And microbiome testing serves as a powerful tool for assessing composition and diversity of the microbiome communities in different body sites. And when there is a dysbiosis, means this balance is disturbed, then it can lead to all kinds of disorders, right from digestive disorders to immune dysfunctions, metabolic conditions, mental and health conditions, and of course, preterm labor and so on and so forth. So this science, what is called as human microbiome, just like there was a human gene project, now there is a human microbiome project, which is telling us more and more about what this microbiome is doing in our body and how can we modify it. So certain strains like Lactobacillus crispatus are protective against preterm labor. So what we are trying to develop now is, can we use this particular Lactobacillus in, maybe put it in the vagina and improve and give protection to the patient against preterm labor. This is something will come in near future, but these organisms or microbes are being identified, and there are so many helpful microbes out there, but we just have to identify them. And these studies are going on not only in our country, but mainly in European countries and United Kingdom. And this field is become more and more exciting. I'm not going to go into the details of it because the time won't allow us so. But finally, the gut microbiome, even gestational diabetes, depends on, for example, this systemic review showed that there is a relationship between intestinal microbiota and GDM. Gut microbiota could be a biomarker for early detection of GDM and could be considered a potential target for a modification to reduce the risk of GDM itself. So prevention, is it possible? Yes, it is possible if we go ahead and think of all these new tools that are in our hand. That's not at all difficult, and that's why it's an exciting field. Sometimes using proper genetics, sometimes using microbiota, sometimes using the epigenetic effects. So all these are going to help us in prevention. We are also working in this field. We are trying to identify some of these microbes and using AI to, because there are trillions of microbes, and we have to make sense of it and see how we can, modify to get the results. So in conclusion, high-risk pregnancies will remain the bugbear of obstetrics management always, because not all of them are going to be preventable, but prediction, early recognition, and of course, proper management is important. But if we are able to use the new tools at our hands, like genetics, microbiome, AI, we will be in position to prevent the high-risk situation in many cases and manage the situation early and in better ways in others. And that's why, especially, the youngsters out there who are listening to this, this is the field that now we have to look at, and this is the field which will really produce results for us. Whatever has been happening for the last 100 years, now there are these game changers, and we need to look into it for really making a difference to our patients. Thank you very much for your kind listening.
Thank you very much, Dr. Sanjay Gupta, sir. It was excellent oration as usual. You have touched almost all aspects as far as high-risk factors are concerned, considering hypothyroidism, anemia, HDP, GDM, and you have touched also DNA analysis and genome and that aspect also. So you have very nicely covered the subject. So many congratulations for that. You have remained always my good mentor, guide, and always well-wisher in any of my academic and other activity. So keep blessings, continue, and thank you for sparing time to have this oration and justify our invitation. Thank you very much.
Thank you so much. Thank you.
Thank you, MC sir, and thank you, Sanjay sir, for giving such a new topic. We know that there is so much work going on microbiome, and we are also doing so much research on PCOS and microbiosis. So thank you, sir, for simplifying the talk and giving us such a nice talk. Thank you, Kavita madam, for chairing this session. We are running up the time, so I am handing over this to the next coordinator, Dr. Monica and Dr. Aneet, for the next session. Thank you so much. Thank you, MC sir, and best wishes for your upcoming election, sir.
Thank you, Nilay.
I'll just take a few minutes. I think we would, while the next session is being set up and the chairpersons and the speakers are getting available, I would request Mr. Rahul to display Dr. MC Patel sir's slide. I think he needs no introduction, but still, for those who are new here, sir is a very wonderful person, I would say, first of all, and his academic achievements and social work and everything is so much inspiring, I think, for all of us. So please, I would like to give his introduction. He is a consultant obstetrician and gynecologist and a very well-known medico-legal counselor. He's been the vice president of Foxy in 2018. He's been the organizing secretary of AICOG 2017, which was very well appreciated by everyone. Chairperson of Ethics and Medico-Legal Committee of Foxy. He has been an honorary secretary of SOGOG, the State Organization of Gynecologists of Gujarat, organizing chairperson of MMCon in 2018, an honorary member, National Inspection and Monitoring Committee of PNDT Act of the Government of India in 2015. Also a State Supervisory Board honorary member of the PNDT Committee, President of Ahmedabad Obs and Gynec Society, an honorary member again, National Managing Body of the Indian Red Cross Society with the headquarters, National President of National Medicos Organization, President of IMA Ahmedabad branch, and honorary surgeon of Indian Red Cross Eye Bank, as has been already said, collected so many more than has been mentioned here. He has reached a higher figure, I think 10,000 eye pairs. An organizing chairperson of the Vivekanand NMO Conference 2013 and has been president of Lions Club of Ghatlaudia, Ahmedabad. That's amazing, sir. Our heartiest best wishes to you, sir, with such an illustrious CV. I'm sure we will be very happy to see you as president of Foxy, and best wishes to you for your campaign. Thank you, sir.
Thank you, Jack. Thank you. Thank you.
I now request
Yes.
our
Thank
next session to please go
Yes.
on, and those who are waiting for lunch, please have a working lunch because you are running late. So please carry on.
Thank you, Charu ma'am, and thank you, Dr. Nilesh. I would like Dr. Anit to take over and introduce our chairpersons for this session. Anit sir.
Thank you, madam. We had a wonderful session from morning, so I'm very honored to be the coordinator for this session. I'd like to introduce the chairperson for the session, Dr. Papa Dasari, Dr. Pima Sulaiman, and Dr. PPCM. Dr. Papa Dasari, she is officer in charge of human reproduction officer research center at Eclampsia Pondicherry. She has a second interest. She's head of EMF from 2005 and she's also principal of Nursing Care. She's vice president of JSF, vice president of JFA, member workplace safety, head Safe Motherhood Committee in 2016 onwards, head of the department from July 16 to July 2009. And she's also officer in the transfer session, miracle coordinator and personal basis. She's also had national and state level secretary, Pondicherry Society, vice president of Revenues, president of Pondicherry Society, and secretary of Pondicherry. I would like to introduce Dr. Kalita Madam. Kalita Madam is a consultant laparoscopic gynecologist and IVF specialist, and director of healing test multiple hospital national coordinator of NAC Foxy, diploma in advanced laparoscopy, University of Boston. Specialized training in reproductive medicine, diploma in IVF, and recipient of National Guest Speaker in 2021, and Health Excellence in 2018, accreditation, Award of Excellence for Champion months. The theme for intending her is pregnancy, in honor of giving the first IVF pregnancy in Eastern Bihar, Jharkhand. Congratulations.
Thank you so much. Thank you so much. Thank you.
And I'd like to introduce the third chairperson, Dr. PPCM. She is the head of the department of Lady Harding, and she is the director professor. She is one of the gold medalist, including she is the best paper in Foxy, Abdul Kalam Appreciation Award, outstanding contribution and also Center of Intelligence, chairperson in Infertility and Reproductive Committee of AOG. National Coordinator of Foxy Medical Committee, expert group member for Drug Control General of India, governing person member of Foxy, Secretary General of Board of Management editor of the release of FIGO Conference, editor of Hypertensive, editor of Book Pregnancy, Hypertensive, Foxy Focus in Diabetes. He is chair of SOP development of and facilitator of SPV. Welcome ma'am for the session. I'd like to ask Dr. Pratika to introduce the first speaker of the day.
Can Pratika ma'am? Yes, ma'am.
Yeah, hello.
Can I
Yeah,
request
yes,
the
ma'am.
technical team to mute everyone? There is so much of disturbance, we can't hear anything. This cannot go on the when the speaker is giving a talk, na? So please mute everyone other than the speaker.
Yes, ma'am.
Hello. Hello.
I request Dr. Pratibha ma'am to please
Yeah.
introduce our first speaker for session, Dr. Aparna madam.
Yeah.
And then PK madam to please introduce our next speaker, Dr. Sarita Agarwal ma'am.
Okay, okay. So good afternoon, everyone. And first of all, can you hear me? Hello? Hello? Can you hear me?
Yes, ma'am, we can hear you.
Yeah.
Yes, ma'am.
Yes.
So first of all, I want to thank Dr. MC Patel, sir, for giving me this opportunity to chair this session in High Risk Pregnancy Summit before best practice. And my regards to Dr. Alpesh, sir, Dr. Jaideep Malhotra, madam, and Jyoti Bindal, madam. And now it's my proud privilege to introduce Dr. Aparna Sharma. Can I have her CV? She is MD, DNB, FICOG, MNA, MS. And she is the professor in Ops and Gynae, AIMS, New Delhi. Fetal medicine specialist with expertise in fetal interventions. Treasurer Society of Fetal Medicine 24-26. Kamini Rao Orator in 2017 and recipient of many awards. And today she will be talking on endocrine disorders in pregnancy. So endocrine, if you say it is a common in pregnancy, and most pre-existing endocrine condition, if they are well controlled, then it will have a little impact on maternal and the fetal morbidity. But if it is uncontrolled, then it may have developed, associated with variety of fetal adverse outcomes and maternal morbidity. So now I request our speaker, Dr. Aparna Sharma, to start her talk on endocrine disorders in pregnancy. And with this, I take this opportunity to give my best wishes to Dr. MC Patel for the upcoming elections. So, Dr. Aparna, please. Hello. Yeah.
Yes, a very good afternoon to all of you. Thank you, chairpersons, and thank you to Dr. Patel, sir, for having me here. I'm really honored to be here today. And I've been asked to speak on management of GDM, a growing tide. And I think it's really difficult to talk about management of GDM in 15-20 minutes, but let's try to do that. And I'm happy that we have Dr. Picky here with us, and I've been a part of her book talking about GDM. So we know that we are in good hands when we talk about GDM. So let's talk about some of the definitions and how they have changed over the last few years. So if we just talk about these standards of care in diabetes, the ADA guidelines of 2024. So every 3 to 4 years, these guidelines are updated. And we can say that this is fresh off the block. So in 2024, ADA talks about standards of diabetes. And when they talk about this definition, so traditionally we know that any abnormal glucose tolerance, which was first recognized during pregnancy, has been talked about as gestational diabetes. But increasingly, it has been recognized that it may be important to exclude patients who were diagnosed in the first trimester because they are likely to have previous undiagnosed type 2 diabetes. So this is trying to go away a little bit from the classical definition of ACOG, which also talks about a condition of carbohydrate intolerance, which develops during pregnancy, which is irrespective of the time. So the contemporary definition says that the diabetes diagnosed during second and third trimester that was not clearly overt prior to conception. So this is a newer concept which is coming in increasingly, saying that the diabetes which is in the first trimester is more likely to be type 2 diabetes. And though that which develops in the second and third trimester is more likely to be gestational diabetes. So eventually we will come to that point. But currently, most of the societies would talk about any hyperglycemia or carbohydrate intolerance which develops during pregnancy. We stick to calling it as gestational diabetes. Now, why are we so worried about it? Is that there is the prevalence of diabetes. It is so, we know that we are the diabetic capital of the world. India and the Southeast Asia is actually the diabetic capital, and we have increasingly found the prevalence of diabetes. And this is another very interesting article which actually came out, I think, 2 to 3 days back.
and which talks about the management of gestational diabetes with a newer perspective, looking at all of the present evidence. And that also says that, the prevalence of diabetes in India is to the tune of around 11%. But if you actually look at the varying definitions, it can even go up to the range of 30 to 40% in pregnancy. So if you actually look into all of the criteria, some of the criteria would also say that even 1/3 of our women are diabetic by some criteria or the other. So a conservative estimate would be around 10 to 15% of all our pregnant women are diabetic. So we have to really see this diabetes in a bigger picture. Now, why are we worried about diabetes in pregnancy? Is it really harmful? What are the consequences of diabetes? So in a nutshell, it has short-term complications, it has long-term complications. The short-term, of course, could be preterm deliveries, hypertensive disorders, cesarean sections, higher fat to mass adiposity, macrosomia. The baby can result in having jaundice, respiratory distress, and neonatal special care admissions. The long-term risk could be type 2 diabetes to the mother, metabolic disorder, cardiovascular diseases, heart failure, NAFLD. Then, of course, the other problems in the baby, which when they grow up as the adult would result in having diabetes to them, adiposity, metabolic syndrome. So we know that diabetes in the pregnancy has problem to the mother, to the baby during pregnancy, and long-term problems to the fetus. Now, when we are thinking that diabetes is such a big problem, can we identify people who are going to have gestational diabetes? So what are the risk factors for diabetes, and can we identify the women that, okay, this particular woman is going to develop diabetes? So if the woman has a personal history of GDM in the previous pregnancy, impaired glucose tolerance, an A1C of more than 5.7, elevated fasting, family history, pre-pregnancy BMI which is raised, or an excessive gestational weight gain, medical condition like a PCOS, older women, or high-risk racial origin like ours, or a previous birth of an infant more than 4 kg, then all of these factors make the woman at high risk of diabetes. And this particular picture would tell us that these are the risks associated, like, the risk ratios which increase the risk of a woman having gestational diabetes. And the yellow ones tell us that these are the modifiable risk. So if we are increasing our physical activity, then we can reduce the risk. If we decrease the smoking, then we reduce the risk. If we decrease the weight, then we can reduce the risk of developing diabetes in pregnancy, and that is why they become important. So the interventions for risk reduction. So this was a very, very pertinent study which came up in 2023, which is called the TOGOB study, which told us that if we are actually looking at interventions like lifestyle interventions like exercise before conception, or interventions which are doing before 20 weeks of gestation, then the adverse neonatal outcome can go down in the treatment group as compared to the control group. And now why all of this actually came up is there was a lot of controversy that, okay, you are detecting a lot of early diabetes. You are detecting a lot of diabetes during 14 weeks, 16 weeks, 20 weeks. But if you actually do a lot of immediate intervention, are you really helping? Because, they may not be over diabetic. They may not have sugars in the range of 200. They may be 140, 160, 140, 150. If you are actually doing extreme intervention, are you helping? Are you not helping? So there was a huge controversy around it. And that is why in 2023, this study came in which said that if you are intervening early in this particular group, there is evidence to say that you might be improving the adverse neonatal outcome. However, you are not reducing the pregnancy-related hypertension or neonatal lean body mass. And this was the outcome of the study. So again, what is the rationale for screening? Should we be screening for diabetes in the early pregnancy? So we know from the WHO criteria for screening for any condition that it should be an important health problem. There should be a natural history. There should be a suitable test. There should be an agreed policy on whom to treat. There should be an accepted treatment. So we know that it complicates 37%. There is a suitable test. The people who are positive on GTT are treated as patients. There is an option of treatment, and women with early GDM can be managed, and diagnosis of gestational diabetes is cost saving, which came up from the TOBOGM study, which we talked about just now. So we know now that we have to screen, and we should be screening for diabetes. And it should be a standard of care for all our pregnant women that we should be screening for diabetes. Now that we have put that question apart, that yes, we should be screening, the question is how to screen for diabetes. And the government of India tells us that whenever a patient comes to you, screen them with the 75 gram 2-hour blood sugar value. And if that value is more than 140, then you manage this as per the GDM guideline. So this is a basic minimum that has to be offered at all levels. However, this may not be the very perfect. It has been seen that this method can lose out on a lot of patients. This has got a lesser sensitivity. So what is ideal is that universal screening we can actually do by a fasting. If the fasting is between 90 to 125, you call them GDM. If you are fasting but non-GDM, then you repeat a single step OGTT, which has to be done in the fasting state at 24 to 28 weeks. And then you will repeat it and you have a maximum pickup. And this is what we generally follow at all places that can actually follow. So these are the screening protocols by various methods. That early GDM you do by a fasting, and between 24 to 28 weeks you do by the DPSG criteria, which says a fasting value, a 1-hour value, and a 2-hour value. So ideally speaking, in all the resource not poor settings or all the resource affording settings, we must be ideally approach the IADPSG criteria for early GDM and 24 to 28 weeks of pregnancy. And this is the ideal protocol that we should be following. But of course, at least a DIPSI criteria is something that we should be doing at all levels. So now that we have screened, what are the protocols for management? So let us start with, so we know that there is A1, which is glycemic control without medication, and A2, which is controlled with medication. So A1 and A2 are the terminologies that we use now. Now, the targets for blood sugar. So the ideal targets for blood sugar, just to remember, is that the fasting should be less than 95. So all of us agree that the fasting should be less than 95 and the postprandial should be less than 120. So if we remember these small values, it is extremely useful. So the 4-pronged approach to management is medical nutrition, exercise, oral hypoglycemics, and insulin. So what are the basic principles of medical nutrition therapy? So 85% of the GDM should achieve normoglycemic state with medical nutrition alone. And the goals are to achieve normoglycemia, prevent ketosis, provide weight gain, and contribute to well-being. We know that the carbohydrate should contribute to 46 to 60% of the calories. Fats should be 25 to 35. Protein should be 10 to 35%. So that is how the medical nutrition therapy is planned. Importantly, for a normal weight person who has a BMI of 18 to 24, the 30 kilocalorie per kg plan is all right, and this should be followed, and a weight gain should be between 11 to 15 kg. So these are some of the basics that should be followed, and these tables are available everywhere to plan the diet, and we should always keep a dietitian in the loop to plan the calories. Important things to remember is that the complex carbohydrates with low glycemic index are preferred, and the foods should be spread over 3 small meals and 2 to 3 snacks per day, and a minimum of 175 gram of carbohydrate should be given to avoid ketonuria, and intake of sugar should be less than 25% of the total energy during pregnancy. So some of the foods of low glycemic index are carrots and corn, etc., and all of them should be consumed. So the protein intake, the average protein requirement is around 0.8 gram per kg, and at least 3 servings of proteins should be used. As for the fat intake, low-fat dairy product should be used, and lean meat in place of red meat should be used. Fibers are essential part of the diet, and minimum of 28 gram of fiber per day should be our requirement, and that should be taken in the form of flax seeds, husk, oat bran, legumes, and they delay gastric emptying and retard the entry of glucose into the bloodstream. So these are extremely important part of the diet. So this is an important pictorial representation where half of our plate should be by the non-starchy vegetables, 1/4 of the plate should be protein, and 1/4 should be carbs by the grains and the starchy food. So I think this is something that if we can remember that 50% is vegetables, and 1/4 is carbs and 1/4 is protein, is something to go by. So this is how in our institute, our dietitian prescribes an 1800 kilocalorie chart, and immediately after a patient is diagnosed, this is the first step that should be done and forms the cornerstone of management of GDM. The next part, of course, is exercise, which can be recommended are walking, jogging, running, aerobic, 30 minutes, moderate intensity, and at least 5 days a week. So brisk walking, arm exercises, if physically active prior, continue the previous exercise routine. So it is important to understand that there are certain contraindications of exercise that should be kept in mind. So exercise should always be under supervision, and whatever suits the patient should be advised, but at least a minimum simple exercises like walking should be advised to the patient. Now, you have advised diet and monitoring. So if a patient is on diet, a 4-point blood sugar profile with fasting and 2 hours after every meal, and if it is well controlled with diet, the frequency of monitoring can be decreased to every 2 weekly. Mean fasting glucose is useful in predicting increase in neonatal fat mass. So now this is our Government of India guideline, that you have given her MNT and physical exercise, and after 2 weeks, what you see is, if your fasting 2-hour postprandial is more than 120, it is now time to start on metformin or insulin therapy. So we are very open about starting metformin. So the Government of India advises metformin or insulin therapy. Important to remember is that if the GDM has been diagnosed late, then MNT is advised only for a week, and insulin is initiated if MNT fails. So here we don't wait for 2 weeks. So this is important. Now, as far as oral hypoglycemics are concerned, we have metformin and glyburide. The most of the recommendation, if you look at it, ACOG says insulin is first line, metformin is second line. ADA also says insulin and metformin or glyburide. SMFM says insulin or metformin and glyburide. In our practice, in our institute, we start metformin also as a first line drug, depending on the levels of the blood sugar. So we are open to using metformin. So the advantage of metformin is that there are no hypoglycemic episodes, does not stimulate pancreas, started at a dose of 500 milligram, and for a maximum dose of 2500 to 3000 milligram per day in divided doses. However, it should not be used in women with preeclampsia, as it can cause growth restriction. So we need to have a good patient selection. The side effects, of course, are some of the gastrointestinal side effects, and the contraindications are hepatic and renal insufficiency, ketoacidosis, and severe infections. So the trials have shown that there is no difference in perinatal complications and associated with a slight increase in preterm birth. Now, in one of the latest article that I had just shared on 2024 article, it says that the effect on neonatal adiposity is unclear as yet. So the results have to be yet seen. So it can be used depending on the practice, and presently the evidence is still unclear on the neonatal adiposity. Now, glyburide is another anti-OHA that can be used. The advantage, of course, is that it is, again, there is no hypoglycemia. It can be started with a dose of 2.5, onset of action up to a maximum dose of 20 milligram per day. The side effects are weight gain and hypoglycemia, and photosensitivity reactions can rarely happen. In our practice, for oral hypoglycemics, we use metformin, and we generally do not use glyburide. Now, myoinositol is being used as a newer drug. In our practice, we have used myoinositol in research settings, especially in women who are at risk of developing gestational diabetes, at-risk women, but not after they have developed GDM. So this is in research drug, not currently being used for therapy for gestational diabetes. Now, coming to the mainstay, which is insulin, we know that there is short acting and intermediate acting and pre-mixed mixtures of regular and NPH. So the regular has onset within 30 minutes and the NPH has onset within 1 hour and stays for a peak action up to 5 to 7 hours. Now, when we start the insulin therapy, the first trimester dose is 0.7 to 0.8 and the second trimester is 0.8 to 1. So the common misconception is that do we need the entire dose to be given? No, it is the overall dose, and some of it is actually produced within the body. So it's the top-up dose which is required. So the regular or the NPH is usually the first line insulin. Now, how do we start the dose and when do we start the dose? So whenever the fasting is more than 126 or the FBS is between 108 to 126 with macrosomia or hydramnios, then it's an indication to directly start the insulin. Or in the other cases, when you have started the MNT and of course the values are not getting controlled, then you start insulin. Now, the blood sugar monitoring. So what we do in AIMS is that we use regular insulin. For every 30 milligram, we add 1 unit of regular insulin. Now, suppose if the post-meal value is 150, then we add 1 unit of regular insulin pre-meal. And once the change is done, then further change is done after 2 days. Now, for fasting hyperglycemia, the intermediate acting dose insulin is added at the bedtime. 2 a.m. glucose is also checked for adding NPH. Now, there could be 4 times regimen. Like we said, that what we do in AIMS is a regular acting and a bedtime injection of intermediate acting. However, a twice daily regimen is also used where you give insulin in a combination of NPH and short acting, while the morning dose is 2/3 NPH and 1/3 short acting, and the pre-dinner dose is half and half of intermediate and short acting. So the Government of India guidelines, they come as human insulin premix, which is 30 and 70, 30 minutes before breakfast and once a day. So if you have a blood glucose range of 120 to 160, it is given as 4 units, 160 to 200, it is given as 6 units, and more than 200, it is given as a 8-unit dose in the morning itself. So the premix of 30 to 70 works for the whole day, and a dose is given according to this. And the insulin administration device could be pens, pumps, syringes, and a dual system. The insulin has to be stored in a refrigerator, the door. If it has been kept in the freezer, we need to discard it. If it shows haziness, it should not be used. Now, once we have started insulin, till the adequate control is there, 7 samples of fasting, pre and postprandial must be used, and after control, fasting and postprandial in a staggered approach, which means that one day I do the fasting and post-breakfast, the next day I do pre-lunch and post-lunch, and the third day I do the pre-dinner and the post-dinner. So this is how I do it over a period of 3 days, so that I don't have to do 7 samples in one day. So this is how a staggered approach is done. So, and in one day, I will do from the lab once a week to confirm that my glucometer is working well. Continuous glucose monitoring in pregnancy, we do for type 1 diabetes in our institutes. We do have these monitors for women who have labile diabetes or type 1 diabetics. So this is the guidance which is given by the Government of India. Simple concept is that if only the postprandial values are increased, then in that case, we increase the pre-breakfast dose, which is the pre-breakfast dose by 2 units, so that the immediate postprandial dose is increased. But if the fasting is also increased, then we will give the same dose pre-breakfast and 4 units at night also. So the night dose will control the fasting level. So if the fasting level is increased, add a dose at the pre-dinner value so that the fasting value can be controlled. So the simple concept is that if the fasting is increased, add a dose at the pre-dinner value. Sometimes insulin therapy can cause hypoglycemia, other things like weight gain and lipoatrophy. But we have to be aware of hypoglycemic symptoms like tremors, sweating, hunger, irritability, and be ready with, to take TSF glucose powder. So always advise patients to keep something sweet. The 15-15 rule, have 15 grams of carbohydrate, check it after 15 minutes. If still below 70, have another serving. Once the glucose pattern is trending up, consume a meal or a snack to prevent recurrence of hypoglycemia. So it's extremely important for all the patients on insulin to know how to manage hypoglycemia. So antenatal care, apart from the control of blood sugar, we must be aware not in pre-gestational diabetes to do a fetal echo, early gestational diabetes or pre-gestational diabetes, a routine anomaly scan, screen for infection. In pre-gestational diabetes, we also start them on aspirin to prevent preeclampsia. Maternal assessments, control of blood sugar, screen for infection, look for daily fetal movements count, ultrasound for fetal growth and AFI, 4 weekly from 28 to 36 weeks, and NST and Manning weekly from 32 weeks onward if the blood sugar is not controlled. A good biophysical profile is reassuring but cannot predict sudden death in cases of uncontrolled diabetes. Now, 36 weeks counseling is extremely important. Talk to the patient about the timing and mode of birth, analgesia, what is the care of the baby after birth, need for starting breastfeeding, because breastfeeding is good for blood sugar control, contraception. So this is called the birth plan visit, which should happen between 34 to 36 weeks. Now, when to deliver? In pre-gestational diabetes without vascular complications, we generally deliver between 38 to 39 weeks. Poorly controlled diabetes, it is somewhere early between 36 to 37 weeks. GDM, which is well controlled, can go up to 40 weeks. GDM, which is well controlled by medications, it is 39 to 40 weeks. So timing of delivery is extremely important. If the diabetes is poorly controlled, so somewhere between 38 to 37 to 38 weeks is something which is important to deliver. Elective cesarean, if it's a big baby or other obstetrical indications, more than 4.5 kg. So generally, if we have more than 4 kg baby, we will deliver by an elective cesarean, or there is evidence of retinopathy. In that case, we will deliver by a neovascularization. Then in that case, we deliver by an elective section. The intrapartum care, on the morning dose of insulin should be omitted. 2-hourly blood sugar control monitoring should be done. IV infusion with normal saline, and regular insulin should be added according to the blood sugar levels. Say, for example, 120 to 140, add 4 units. If it is between 90 to 120, we don't need to add any insulin to the normal saline infusion. Now, and urine ketones should always be checked. In the postpartum care, GDM on diet and no medications, usually they do not require any further medications. If it was a type 1 diabetic, 1/3 to half of the short or rapid acting insulin dosage can be started. And if the patient was on insulin pump, dose to be reduced by 50%. Type 2 diabetic may not require any medications during the first 24 to 48 hours. If they require insulin, usually 0.6 kgs of the postpartum weight. Alternatively, we generally start them on the oral agents that they were taking from before, or we freshly start them on the oral hypoglycemics once they resume taking their diet completely. So normally monitor blood sugars immediately in the post-cesarean period and then start them on insulin according to the sliding scale. Early breastfeeding is important, and they should be neonates should also be monitored for hypoglycemia. Monitoring should be started at 1 hour of delivery and continued every 4 hours, and evaluate for neonatal complications. Now, and postpartum diabetic screening is extremely important. Normally, we have a postpartum visit for the patients at 6 weeks when we screen them by a oral glucose tolerance test. So in the oral glucose tolerance test, if it is more than 125 or 199, it is diabetes mellitus. 100 to 125, it is impaired fasting. Less than 100 and less than 140, it is normal. Impaired fasting should be put on lifestyle management and counseling, and consider metformin if combined with impaired fasting. Contraception, most of the contraceptives are all right for GDM, unless it's a nephropathy or retinopathy. So generally, we avoid hormonal contraceptives in cases of vascular diabetes. But otherwise, GDMs are all right for most of the contraceptives. So just to summarize, most of the guidelines, this is a very good table which is given in the recent article, which says that most of the guidelines recommend ultrasound monitoring at frequent intervals for diabetic pregnancies starting 11 to 14 weeks, then an anomaly scan and a growth scan at 32 and 36 weeks. Antenatal testing for fetal well-being is usually not recommended. Monitor by fetal movements. Induction of labor, as discussed. The timing of delivery in medically treated or GDM with complications should be around 38 to 39 weeks. If the patient is uncomplicated, we can go up to 40 weeks. During labor, continuous CTG, they have not really mentioned, but we must be careful about fetal monitoring during labor. So to conclude, all pregnant women should be screened for GDM. Now, this is something that we have to remember, that we must monitor all our pregnancies for GDM. MNT plus physical activity is the cornerstone of GDM management, and 85% of our women will be controlled by this. Insulin is the standard of care, but OHA is being considered more and more. Metformin is the second choice in the patients who are unable to safely administer insulin. Glycemic targets is 95 and 2 hour of 120. Glyburide we are not commonly using. Aspirin should be given for type 1 and type 2, and women with history of GDM are at increased risk of diabetes and hence should be screened at least 6 to 12 weeks and then every 1 to 3 yearly. So thank you very much.
Thank you, ma'am. Are you there, ma'am? Ma'am, can you please give your expert comments and conclude the talk because Pratibha madam had to leave for an emergency, ma'am.
Okay, so I think Dr. Parna, that was a very nice, comprehensive talk and very well presented. And she has covered all the points from screening, diagnosis, how to proceed with medical nutrition therapy, and going to oral hypoglycemics and insulin. I just want to point out that the regulatory authority, till now, till last year, none of the regulatory authorities, that is the US FDA, DCGI of India, European Union or Australian Union, had not given approval for use of metformin during pregnancy. But the good news is that the European Union has already approved metformin after seeing a huge trial that was conducted, number of trials which were conducted. So now we will be legally safe to use metformin. And I think glyburide is out of use now because many of the guidelines have written, and we have seen that the children born to mothers who were given glyburide, the neonates develop hypoglycemia and the babies develop macrosemia. So I would recommend that. And I think none of us, as Aparna said, none of us is using glyburide. So the only options are insulin, the beautiful analogs of insulin which are available, and of course, the metformin, the bundle drug, which we have been using, have a long experience of using in PCOS, that can also be used. So thank you. Thank you, Dr.
Thank you. Patel sir, do you want to add something? I think sir is busy somewhere, ma'am. Can we go ahead with the next talk? Can you please introduce our next speaker, Dr. Sarita Agarwal, ma'am?
Yeah, so pleasure to introduce Professor Sarita Agarwal. She's a professor and head of Obs and Gynae and Dean Research at All India Institute, Raipur. She has had numerous contributions to ICOG and FOXY. She has been the Vice President of FOXY in 2015, ICOG Governing Council member as well as Academic Council member and Chairman of HIV Committee. She has been awarded with number of awards and prizes, and she has delivered innumerable number of invited talks in various conferences, organized number of talks, and she has so many accolades to her credit. I request Dr. Monica to proceed with her talk on thyroid. That is another very important endocrinological disorder that we encounter in the pregnancies. So over to Dr. Monica.
Technical team, please allow Sarita ma'am to share her slides.
And I would like to thank Dr. MC Patel for giving me the opportunity to be here. Thank you very much, sir, and wishing you all the best for your future elections. Sarita?
Am I audible?
Yes.
Yes,
Yes,
you are
ma'am.
audible, but your screen is not visible.
So I'm just starting. Thank you, Dr. MC Patel, sir, and the whole team who has given me opportunity to speak on this talk of thyroid disorder in pregnancy. We know it's a very important, one must understand why the thyroid disorder in pregnancy is important. Well, we are very much aware about that in pregnancy there can be hypothyroidism, hyperthyroidism, and there's a spatial entirety.
Dr. Sarita, your screen is not visible. We can't see the
But
slide.
I shared the screen.
Yeah, so just stop it
Ma'am,
and
you
then
can stop sharing and again reshare, ma'am.
Okay.
Restart, ma'am.
Share a screen. This is thyroid disorder in pregnancy. I'm sharing now. Is it visible now?
Yes.
Yes.
Okay, I'm taking the full show.
Make it slideshow, Dr. Sarita.
Is it in the slideshow mode now?
No, not yet.
Ma'am, you need to make it full screen.
I made it full
Kindly
screen.
click on the button. Kindly click on the button which is at the right corner, ma'am.
I'll just do it again. I'm just stopping sharing and then doing it again. The right corner slideshow, I'm making it slideshow. Why it's not taking up the slideshow?
Resume slideshow. In the top, there is a logo which is displaying.
Ma'am, you need to close the right sidebar which is there first.
The custom animation one.
The custom animation sidebar you need to close, ma'am, first.
I'm not able to see that sidebar custom animation part.
Technical team, can you please help ma'am with this?
Anyway, you can help me out.
Ma'am, you can send us the presentation if you don't mind otherwise.
Okay.
In the
Ma'am, you
WhatsApp
can just
I've done the control
reshare
window
your
name.
slide.
Just
Ma'am, you
try
can just
once again.
reshare your slide first.
At the
Ma'am,
bottom, arrow na, jahan, where your cursor is there. Just
Yeah.
press it twice.
I'm doing that.
You will have to close these 4-5 slides are there na, on the left side of the screen. Just close that.
I'm not able to see my screen actually, is the problem now.
Oh.
I'm sharing my presentation again.
Okay.
ma'am, and till the time that you mail, you can start with the talking with the introduction so that we can have the orientation in the meantime because we're already running late.
Actually, can you just help me? I'm sharing the screen. Why it's not going? View, I will take first the exit full screen. I do. Let me open my. This is something else is open. No?
Ma'am, you can open the PPT entirely on your screen and put it in the slideshow mode and then start sharing your entire window if it is possible that way.
It is in the slideshow mode only. Shall I
Technical
close the
team, can you please
presentation
help with
first?
that?
I'll close the presentation first. Let me try that.
Actually, you are able to share the screen, but only that animation bar, if you close, everything will be fine.
If I'm selecting this and sharing, then why it's not happening? This
Open the presentation first, ma'am. Then you share. Don't share first. First open the presentation.
And
First open the presentation, then share.
I did the same thing. It's my laptop. I can see the full screen here. I'm sharing the presentation on mail.
Thank you.
Or will it be okay if I share in the WhatsApp?
WhatsApp also fine.
Ma'am, we can see the slides in the meantime, even if they are not full screen, till the technical team takes over.
What is happening? I just try sharing, it not happening. To whom shall I share?
You can put it in WhatsApp group.
Ma'am, you can put it on the 23rd group, ma'am.
In the group only sharing. No?
I think
Yes,
share
ma'am.
in the, because you will not be having the phone number of the technical person, na?
Yeah.
So it is better, let's not waste time, and you can, and I think Dr. Sarita, you can start, even if it is not
In
signed,
the
all the view is visible.
Ma'am, we can see your slides. They are not only in the full screen mode. You can start speaking, ma'am, in the meantime.
Okay.
Already quite
Yes,
late,
ma'am.
na?
Now. Is it okay now? Are you able to see my slides scrolling?
No, ma'am.
So I have sent in the WhatsApp actually.
So it is there in the WhatsApp group, yes.
If you allow, can I screen your screen?
Why?
Vasu sir, I am sharing my
You
slide.
share. You can share.
Ma'am, you need to stop sharing your screen first.
Yeah, stop.
Yes, ma'am.
Visible?
Yes, perfect, ma'am. Ma'am, please. Yes, ma'am.
But the change is in your control as of now, no?
Correct, correct, ma'am.
Yeah, correct.
So anyway, I'm going to talk about the thyroid disorder. You will be taking care of my change in the slide, no? You can
Yes,
just
yes,
see the
ma'am.
speed. The thyroid disorder in pregnancy is a very common disorder which we need to understand. Next, please. And then why it is important to understand the thyroid disorder in pregnancy. We know the hypothyroidism, hyperthyroidism. If it is out of the pregnancy, we can manage it by the simple monitoring of the TSH, T3, T4, and even the FT3 and FT4. But there are the changes in the pregnancy because of the estrogen increased level. There's an increase in the thyroid bonding globulin, which can increase the total thyroid T4 and T3 level. Similarly, because of the SCG effect, which is mimicking with the pregnant with the TSH hormone, there can be transient rise in the TSH in the manifestation like hyperthyroidism picture, and there can be decrease in the TSH level at this time. So our interpretation of the lab value during pregnancy differs a lot. And next, please. Next, please. And therefore, it is very important that thyroid function test should be interpreted using the population-based trimester-specific differences for the TSH and also for the FT3 and FT4. Another problem with the FT3 and FT4 is that this lab value varies according to different lab, and the different method used for the testing this FT3, FT4. Next, please. Next, please. Our concern when you are having the thyroid disorder in pregnancy is the effect of the thyroid disorder in not only in the mother but also on the babies. If you look at the effect of the hypothyroidism, it is associated with this anemia and the can be the severe manifestation of congestive heart failure. Then it is associated with the increased risk of preeclampsia, placenta abnormality, low birth weight infants, and even the postpartum hemorrhage, and sometimes the myopathies are the risks. If you talk about the fetal risk, then there the fetus is very much related to the maternal thyroid level, because up to 12 weeks of the pregnancy, the fetal thyroid is unable to produce any of the thyroid hormone, and it's totally dependent upon the maternal thyroid. And we know that the thyroid hormone is required for the neurological development, and the result of this, if the thyroid supplementation is not good in the early pregnancy, in such cases, the baby born can have the manifestation of congenital hypothyroidism or the neurological abnormality and the developmental abnormality, specifically the cognitive impairment, which may be remain undiagnosed for a long period. It is not only the clinical hypothyroidism, but also the subclinical hypothyroidism associated with the adverse pregnancy outcome in the form of placental abruption, preterm birth. Next, please. Next, please. Next, please.
Yeah, ma'am, screen have already
Next,
changed.
please. It is very
Yes.
important the hypothyroidism early pregnancy has to be addressed. Otherwise, the first trimester abnormal thyroid hormone level can have a serious adverse effect on the fetus.
And if it is in a later stage, then they lead to less severe manifestation and usually the reversible brain damage and the cognitive impairment can be there. Next, please. If you look at the hyperthyroidism, next, please. And hyperthyroidism also associated with the complications in the form of preeclampsia, heart failure, and the death. And the thyroid storm, which can manifest during pregnancy, can be lethal to the mother. Similarly, when talk about the perinatal outcome, apart from the preterm delivery, growth restriction, and stillbirth, the manifestation in the form of fetal thyrotoxicosis, fetal hypothyroidism, and fetal goiter are the things which needs to be addressed. If you look at this figure, if it is a well-treated and the patient's euthyroid, then the outcome is quite good as compared to then when it is uncontrolled and associated with the poor outcomes. Next, please. Therefore, it is recommended in India that the routine screening has to be carried out as a thyroid dysfunction or the thyroid disorder is quite common in our settings. While the ACOG and American Thyroid Association and American Association of Clinical Endocrinology do not recommend the routine screening. However, in India, even in the POXI recommend that all the women in the first antenatal visit should undergo a TSH level, FT4 and an anti-TPO antibody. Why the anti-TPO antibody is recommended? Because the raised anti-TPO antibodies associated with the poor pregnancy outcome in the form of abortions and the preterm birth. Next, please. Now, question comes, what cutoff of the TSH level should be taken? If you look for the out of the pregnancy, the cutoff usually taken by the endocrinologist is more than 5. But when you talk about the pregnancy, the cutoff TSH level to be 2.5 milliliter unit per liter in the first trimester, 3 in the second trimester, and again in the third trimester, 3, which is recommended by the most of body like the ITS, ETA. However, the American Thyroid Association says that a locally derived reference rate has to be taken as a cutoff, and if not available, and that the 4 milliliter unit is taken as a cutoff. If you look at the RCOG, it gives the lower limits also, knowing that is 0.1 to 2.5 in first trimester, 0.2 to 3 in second trimester, and 0.3 to 3 in the third trimester. The awareness of the lower limit is again very important for us if you are concerned with the diagnosis of hyperthyroidism. So both the upper limit and the lower limit cutoff should be known. Next, please. So I'm talking about the FT3 and FT4, then we know that what happens in the hyper and hypo. I don't think that it needs to be elaborated. We are very well known. But the important is the interpretation and the lab reference rate varies lab to lab. Hence, the test to be interpreted very carefully, specifically when you're monitoring the patient with a hyperthyroidism. In that case, the monitoring of the patient and the further regulation of antithyroid drugs are required based upon the FT3 and FT4 level. But when you are monitoring the hypothyroid, then the TSH level is being monitored. Next, please. So, when we talk about I'm going to talk in detail about the hypothyroidism. Most of the time it happens, we look at the TSH value and we see the TSH level is high and then we start the thyroxine to these women. We never try to find out what is the cause for this hypothyroidism. So we have to understand that in a country like India, the developing countries, iodine deficiency is the most common cause, and developed countries is the Hashimoto's thyroiditis, which is the most common. Apart from this, every time the history should be looked into that. Can it be in a secondary hypothyroidism? Is it an iatrogenic, like if the history of radioactive therapy, history of thyroidectomy, history of anti-thyroid drug intake, then history of viral infection, which is occurring in the subacute thyroiditis. And then we need to differentiate the secondary hypothyroidism because of the pituitary failure. So we have to look for the deficiency features of the other pituitary hormone. And of course, the hypothalamic failure leading to tertiary hypothyroidism as such not common in our country. Next, please. So when we talk about the hypothyroidism, the entirety which need to identify is the overt hypothyroidism, the subclinical hypothyroidism, and isolated hypothyroxemia. So what is overt hypothyroidism? In overt, you get a high serum TSH level but decreased T3, T4 level. Here, if the patient is a known case of overt hypothyroidism, she is already on the thyroxine. It is very well important that the patient's dose should be increased by 30% as early as possible as the patient is screened. Because again, as I said, the first trimester control of the thyroid hormones is very important. Then in case of the subclinical hypothyroidism, you get a serum TSH level to be high, but the normal T3 and T4 level, I already told that the subclinical hypothyroidism needs to be addressed. In such case, it is again very important. We must know the anti-thyroid peroxidase antibody levels, because a subclinical hypothyroidism associated with the positive anti-thyroid peroxidase antibody has a higher risk of adverse pregnancy outcome. Then about the isolated hypothyroxemia, where the TSH levels are normal and there is a decreased T4 level. In such cases, we don't much need to do during the pregnancy. They usually do well without any supplementation. Next, please. Next, please. Symptoms, I think we can skip. We know very well. Next, please. Then when we talk about the management, we know this is a preconception counseling is very important in patients who are known with an overt hypothyroidism. This is because when you are in the non-pregnant state, the cutoff value can be 4 or 5. But when you are planning in a pregnancy, the TSH level should be less than 2.5 units before milli international unit per liter before she plans for the pregnancy. Otherwise, the outcome is not good. So even in the preconceptional period, you may need to increase the dose of the thyroxine during the pregnancy, during the preconception period itself. Next, please. So once you diagnose it is in a case of hypothyroidism, the two conditions, patient is already on the antithyroid, already on the levothyroxine, the diagnosed case, other when you're the newly diagnosed. So whenever they're in a newly diagnosed case, but the TSH level is high, then you have to look for the value. If it is in a less than, if it is between the trimester specific lower limit or normal and 2.5 units per liter, in that case, statement is euthyroid and treatment is not required. But if it is between 2.6 to 4, you have to look for the anti-TPO antibodies if positive, or there is history of recurrent miscarriage. In such cases, always supplementation with the levothyroxine is very, very important. However, there are certain guidelines which recommend that if the patient is in low 2.6 to 4 and there is an antibody negative, in that case you don't need treatment until unless there is a history of recurrent abortion or the previous pregnancy poor outcome. Of course, whenever the value is more than 4, you have to look for the free T4 level. If it is low, indicates overt, and that needs to be treated with higher doses of the levothyroxine, as the starting dose is 1.6 microgram per kg daily. But the T4 level is not low. In that case, it is recognized as a subclinical hypothyroidism, and the starting dose is less, that is 1 microgram per kg daily. Next, please. However, when the patient is a previously diagnosed hypothyroid, I already told there is a need of immediate increase by 25 to 30% at 4. Initially, at a 4 to 6 weeks of gestation, that means as soon as the pregnancy is being diagnosed, the dose has to be increased. And then the recommended how to increase is that 5 to 10. If the TSH is 5 to 10, that you have to make it increase by 25 to 50 micrograms. If 10 to 20, need dose to be increased by 50 to 75 micrograms. If it is more than 20, then even the dose needs to be increased by 75 to 100 micrograms per day. And then whenever you're doing the dose increment, the TSH level should be monitored 4 to 6 weekly till delivery. It is again important after the delivery also, the TSH level should be checked at 6 weeks and then 12 weeks to standardize the dose back to the non-pregnant state. Next, please. Next, please. Then again, whenever the patient with a hypothyroid delivers, it is very important the newborn should be screened. Though in the many of the institutes, like in our AIMS, we are doing the routine newborn screening for the thyroid. That is, the TSH is being done after 48 hours of the birth, and the hearing test in the form of photoacoustic emission test is done within 3 months. And if the patient reports for the first time after 3 months of the birth, in that cases we go for the BERA testing. And if you find an abnormal OAE, in that case also the BERA to be done after the 3 months. And the baby should be warned very well about the cognitive function, because the late recognition itself can lead to permanent mental retardation in this neonates. And then the initial supplementation of thyroid, early diagnosis and hypothyroidism in the infanthood is very important. Next, please. Then coming to the hyperthyroidism, when we talk about the hyperthyroidism in pregnancy, it can be because of the intrinsic disease of the thyroid, which amongst that the Graves' disease is quite common, which is an autoimmune disorder associated with the production of the thyroid stimulating hormone receptor antibody. And that thyroid receptor and thyroid stimulating hormone receptor antibody is the main culprit and associated with the many complications during the pregnancy as well as the neonate. I'll be discussing in detail in the subsequent slide. The other cause is having the thyroid nodule. Examination is very important. If having a thyroid nodule, FNAC may be required, ultrasound followed by the FNAC may be required to make exactly the diagnosis is a benign nodule or it is a malignant nodule. And the third subentitle is subacute thyroiditis. I'll be talking in detail. The another condition which the obstetrician must know is a pregnancy-induced transient hyperthyroidism, which can occur in the first trimester of the pregnancy because of the SCG, initial SCG mimicking the beta SCG mimicking the TSH. Apart from that, the hyperemesis, hydratiform mole, choriocarcinoma, multifetal gestation, they do more manifestation of the transient hyperthyroidism during pregnancy. Again, the history of drug-induced hyperthyroidism should always be taken in the form of the patient is on any drugs like amiodarone, lithium, or the iodine. Next, please. Next, please. Symptoms, again, I think we are very well aware of the symptoms of the hyperthyroidism, so I'm not going in detail. But of course, the ophthalmic examination has to be looked in the form of the ophthalmopathy if it is there, and then the skin examination in the form of dermatopathy that has to be looked for. So this is the algorithm which shows that how you're going to make a diagnosis of hyper and a hypothyroidism based upon the TSH level. Here I specifically want to mention, of course, in the hyperthyroidism, then you have a low TSH level, low FT3 level, and low F2, FT4 level. There's one condition is subclinical hyperthyroidism, where you have the isolated decreased TSH level with a normal F3 and FT4 level. Here important that should we treat this subclinical hyperthyroidism or shouldn't we treat this subclinical hyperthyroidism? Is still in a question mark. Should I treat? Most of the authorities, they say the subclinical hyperthyroidism does not need any treatment until it is symptomatic. However, the symptomatic and the known laboratory diagnosed hyperthyroidism needs to be addressed during the pregnancy. Next, please. So the reason for that, the pregnancy outcome is not good only for the mother, but also the baby, which in the form of thyrotoxicosis, hypothyroidism, and the neonatal goiter. Next, please. So let me talk first about the gestational hyperthyroidism. This is a transient hyperthyroidism. 1 to 3% you are able to see, and mostly in the first trimester of pregnancy. Here, you should declare the patient a gestational hyperthyroidism only when you're tested for the serum markers like a thyroid autoimmunity. If it is negative, then you can label it as a gestational hyperthyroidism, because missing the thyroid autoimmunity can be disastrous both for the mother and the baby. And usually they do not require a treatment. Next, please. Then coming to the Graves' disease. The Graves' disease symptoms initially worsens during the pregnancy because of the SCG stimulation. Later on the second trimester, third trimester, the symptomatically the patient may be better because the blocking antibody also declined during the pregnancy. And the clinical examination in the form of having the goiter, but not in all cases. The diagnosis is confirmed by the presence of thyroid stimulating TSH receptor antibody, which has to be tested. Whenever you are doing the thyroid stimulating TSH receptor antibody, it is very important. One must look for the thyroid stimulating antibodies as far as the thyroid blocking antibodies, because the effect of which is high is varied during the pregnancy. Next, please. So now the question comes, how we are going to manage the hyperthyroidism during pregnancy. We have the two groups of the drug. One is the propyl thyrouracil group and second the methimazole. We know that both of drugs are quite effective in controlling the hyperthyroidism as an anti-thyroid drug. So if you look at the propyl thyrouracil, it decreases the T4 to T3 conversion. Therefore, if it's a high T3 level, which is the predominating, the dose, the drug preferred is the propyl thyrouracil. It can be used in all the trimester, but the significant hepatotoxicity on prolonged use is a concern. Therefore, it is recommended that first trimester use the propyl thyrouracil very safe, because methimazole having the some of the fetal effects cannot be used. So it is recommended that in the first trimester of pregnancy, the woman should be started with the propyl thyrouracil, and then it can be switched over. It has to be switched over to the methimazole, and the dose adjustment has to be done. So usual dose for propyl thyrouracil is 100 to 600 milligram in 3 divided doses, and it has to be adjusted according to the fetal FT4, according to the FT4 level. When we talk about the methimazole, the fetal effects of the methimazole are esophageal and the choanal atresia, as well as the aplastic cutis can be there. It is there when you're using in the first trimester, not in the second and the third trimester. Therefore, the methimazole is not used in the first trimester, but propyl thyrouracil has to be switched over to the methimazole in the second and the third trimester. So when you're switching over from the propyl thyrouracil to the methimazole, then it is very important because you don't want a sudden increase in the T4, T3 level. So the ratio has to be known. So it is a ratio of 20:1, that is the propyl thiouracil to the methimazole. That means if your women is under 20 milligrams of propyl thiouracil, then it has to be replaced with the 1 milligram of the methimazole. In that way, you can get a good control of the thyroid level during the pregnancy when you're switching over from the one drug to the other drug. The usual dose of the methimazole is 5 to 30 milligram in 2 divided doses. Next, please. So what is important when you're managing the patient with the hyperthyroidism? The goal is to treatment with the lowest possible dose of the antithyroid drug to maintain the FT4 level slightly above or in the high normal range, regardless of the TSH level. So monitoring is with the FT4 level, not with the TSH level. And the Graves' disease, the required dose of this antithyroid drug is less as compared to the hyperthyroid psychosis or the other causes of the hyperthyroidism. Now, it is very important how to monitor. So, you're monitoring the thyroid stimulate TSH as well as the FT4 value. Postpartum also 6 weeks and the 12 weeks interval during the pregnancy, 6 weeks and the 12 weeks interval, and then postpartum also it needs to be monitored. Because the risk of relapse of the Graves' disease is always there, is quite high in the postpartum period. Next, please. While the woman is on an anti-thyroid drug, it is very important one has to be monitored with the agranulocytosis, which can be the lethal complication of the ATDs. It is seen most in the women with the Graves' disease. Who are on the ATD, and that is made if you are getting the absolute (500 micrograms there, and therefore this and the clinical manifestation
I think there has been some network problem. Hello.
Yes, ma'am.
So madam is not visible. I think she is logged off. Can you just
Till
talk
the
to her?
meantime, yes, ma'am.
Yeah,
I'll
we can
just call her. In the
we can have some
meantime,
inputs. We can have some inputs from the chairperson still then.
Vicky, ma'am.
And either we can complete other than or we'll have to carry on because we can't keep waiting. Please request the chairpersons to give some inputs on the two topics which we just heard. Do we have Dr. Vicky Saxena, ma'am, here? Okay, otherwise, I think if we can't get through to madam, we carry on with the next part of the session.
Hello.
Yeah.
Am I audible, ma'am?
Yeah.
Ma'am's number is not reachable. She isn't picking up. In the meantime, Picky ma'am, can you please give me your comments?
I think no one else is also available. So I think we'll have to wrap up this. Okay, ma'am is back. Fine. Welcome
I'm
back,
very
ma'am.
sorry, my internet got disconnected. I will just finish up the slide.
Ma'am, yeah, please, can you just wrap up? Let's, Prana, we have to go to the
I
next
think
session.
without presentation, I can go ahead with that. So I
Thank
have
you.
completed with the hyperthyroidism part, which is the Graves' disease, which has to be addressed, and the postpartum follow-up is very important in this patient because the recurrence risk is also there. Then coming to the neonatal effect, this is very important. The patient with the Graves' disease can have the autoimmune, the hyperthyroid goiter or the hypothyroid goiter, and the fetal tachycardia. If you find that you don't find any cause, in that case, it is very important that you need to get a workup done for this, for the hyperthyroidism in pregnancy. Because whenever you diagnose that, and then again when the patient with an hyperthyroid is recommended, then they should undergo an anomaly scan to look for the goiter, and then even in the each growth scan, the goiter has to be looked for. Because if you get a neonatal goiter, in that case, the in utero therapy is very much important. And even if the women's ATD drugs are controlling her, maintaining a euthyroid status, you need to increase the dose of the antithyroid drug for the fetal effect. And something it can happen that when you're giving the antithyroid drug in higher doses, the mother can develop the secondary hypothyroidism. Even in such cases, it is recommended the women can be supplemented with the additional levothyroxine along with a higher dose of ATD to maintain her euthyroid status. Because when you're giving the ATD, they crosses the placenta, they take care of the fetal hyperthyroidism, but the thyroxine drug or the levothyroxine does not cause it to that extent to the placenta and is not going to affect the fetus. So it is very important in utero management for the avoiding the late complication to the neonate. So I think this is about the hyperthyroidism and the management. The next is an autoimmune thyroiditis, which can still be there in the postpartum period to the women. So in such case, what is important, the postpartum hypothyroidism and the postpartum thyroiditis, the women has to be the manifest. Sorry, I will just open my screen and then I'll talk about. I just want to mention something that is about the this is postpartum thyroiditis, that is a destructive thyroiditis, which because of the chronic autoimmune thyroiditis, usually Hashimoto's thyroiditis, and it manifests within 1 year after the delivery. And whenever the history of previous postpartum thyroiditis is there, or the positive antithyroid peroxidase antibodies are there, and the women with the type 1 diabetes, they are at high risk of having the postpartum thyroiditis. Clinical presentation may be varied, either it is a transient hypothyroidism, or it is a transient hyperthyroidism, or hyperthyroidism followed by the hypothyroidism. Therefore, these patients need a very good monitoring 4 to 6 weekly for the thyroid function test and the dose, whether the management, that depends upon whether the woman is hypothyroid or the hyperthyroidism, and accordingly you need to change with the thyroxine during the hypothyroid period and the antithyroxine drug during the hyperthyroid phase. Prognosis is like that most of the women recover during with this condition within a year, but many of the women can still have the permanent hypothyroidism or the goiter during the pregnancy. So important here is that the postpartum thyroiditis has to be differentiated from the Graves' disease, because the long-term complications of the Graves' disease is not good, while the postpartum thyroiditis is usually self-limiting. So I think with this, I am ending with my conclusion that the thyroid screening in the first trimester is very important to diagnose both hypo and the hyper. A careful management throughout the pregnancy to address and maintain the euthyroid status with the TSH level between 2.5 if in hypothyroidism, and if it is in hyper, to the upper limit of the normal FT4 level. And the careful monitoring during the pregnancy saves both in case
Hello?
I think there's a technical problem. So, Dr.
Yes,
Monica, I
ma'am.
think we can wrap up the session.
Ma'am,
Our
I
other
would
speakers are
request
waiting.
you, ma'am, I would request you to please give a concluding remark for this session, because Piki ma'am also has joined some other meeting. She has requested you to please give the concluding remarks so that we can move forward with the next session, ma'am.
Yeah, please. Yeah. Okay. So we've had a very good
I
discussion,
submit my
very
apology
elaborate.
for the poor internet connection in between.
No problem. Technical problems are always there, ma'am. Thank you for covering it in a very elaborate fashion, and we've got a lot of inputs on the topics. We will not waste any more time. We go to the next session, infections in pregnancy. And I asked the coordinators, Dr. Prerna and Dr. Monica, to please take over and introduce the chairperson.
Thank you, chairpersons. Thank you, Sarita madam, and thank you, Aparna madam, for being there for my session. And thank you, Patel sir and Charu ma'am, for giving me an opportunity to coordinate. I hand over to Dr. Prerna Krishan madam.
Good afternoon, everyone. Thank you, MC Patel sir and Alpesh Gandhi sir for giving us this opportunity to be a part of such a nice webcon. Our session is on infectious in pregnancy. And me and my coordinator, Dr. Prerna, is there. And our first chairperson is Dr. Vidhu Modgil. She is just joining in few seconds. She is an infertility expert and her special interest is in high-risk pregnancies. She has got N number of awards, International Foxy Achiever Award, Vice President North Zone Yuva Foxy. She was an organizing chairperson for the IAG Punjab chapter, North Zone Coordinator of PAC Committee, Manata Coordinator in Punjab, member of Drug Committee Foxy, member of Presidential Task Force, and so on. And she is a member for Foxy, ISAR, SAFCOF, and IFS. I invite you, madam, and due to some constraint, Dr. Sudhir Shah is not able to join. He is traveling and he is not having a net access over there. So we will miss his presence. Over to Dr. Prerna to introduce the next chairperson.
Thank you, Dr. Monica. In fact, great honor for all of us to have such a string of
Prerna ma'am, you are not audible clearly.
With us around for this one HRP summit and this pertinent session on infection. Yeah, I'm Mike. Can you hear? Hello.
Yes, ma'am. Now you are audible.
Okay. So it is a matter of immense pleasure that we are all here for this wonderful HRP summit and a string of stalwarts we have around with us for this wonderful sessions that we are going on to now. We are having this infections in pregnancy session, and for this we have our chairperson. Can we have the next slide, please? The next CV. Next to this, sir is not able to join because of some network issues. We have Dr. Venus Bansal. Please get to Dr. Venus Bansal. Yeah, we have Dr. Venus Bansal. She is a consultant OBGYN, and she has a lot many number of affiliations and degrees to her credit, and awards, national and international publications to her credit. Ma'am, we are really, really honored to have you amongst us to make this session more interesting and fruitful. We ask our first coordinator, Dr. Monica, to kindly ask the first chairperson to introduce the first two speakers.
I request Vidul madam to please introduce our first speaker, Dr. Prakash K. Mehta, for his talk.
Yeah, thank you, everybody. May I be allowed to share the screen, please?
Rahul, stop the screen.
If Dr. Vidhu is not there, Dr.
Madam, are you there? Ma'am, please
Dr.
introduce for as a first speaker.
Yeah, okay. Yes. So before I begin, I need to really thank Dr. Alpesh Gandhi and Dr. MC Patel. MC Patel doesn't ask me, always orders me. And the moment he orders, I need to come. I have no alternative. So thank you, Dr. Patel, for having me here. Today's topic is about the chickenpox chronicles. How do
Prakash sir, please, sorry for interruption. Please let Vidhu madam to introduce you first.
Okay.
Vidhu ma'am, you are muted. Vidhu madam, you are muted.
Can we share the CV slide for Dr. Prakash sir?
So we have among ourselves Dr. Prakash, and thank you, organizers, for giving me this opportunity. Dr. Prakash is a Chief Division of Maternal Fetal Medicine Head of the Department of Bhagwan Mahavir Jain Hospital, Bangalore. He has numerous articles and delivered various orations on fetal medicine and various places. And so he's the president of Society of Fetal Medicine of India and ISSSP World Organization. He's a past president of Bangalore Obstetrics and Gynae Society and past joint secretary Foxtree, and has been awarded as best teacher NEP institution in 2019. And we welcome you, sir, for your presentation.
Thank you. Okay, I hope the slide is seen.
Yes, sir.
Perfect, sir. All right.
Yes.
So today we'll be talking about the chickenpox chronicles. And although chickenpox is not a very common disorder, the effects that it can have on the mother as well as the fetus, and also the surrounding other patients and health workers, is something that is really great. So although it is not too common, we definitely need to know much more about it, this particular disorder. What happened? I'm not... Something's up with this. Okay, I think somehow something happened and I'm not able to make the screen big, but we continue. The first thing is, why the name? Because the specks that appeared looked as though the skin was picked up by chickens. So that's why it was called as chickenpox. The other alternative explanations are that this disease was named after chickpea, from a supposed similarity in size between the seed and the lesions. And finally, Dr. Samuel Johnson suggested that the disease was not a very great danger. So it was a chicken version of the pox. Remember, these were the days when smallpox was rampant. And smallpox had a lot of morbidity and mortality, whereas the chickenpox was not all that bad. So that is why it was, since it was a watered down version of the pox, it was called as the chickenpox. Now, the chickenpox virus is a varicella zoster, which is the DNA virus of the herpes family. The issue is that it is highly contagious and is transmitted by respiratory droplets and by direct personal contact with the vesical fluid, or indirectly even via the fomites. That means the patient's discharge from the vesicles, if it has touched any area, it can infect the next person who comes into contact with it. The typical features are fever, malaise, pruritic rash, and it's usually more severe in an adult than in a child. So the pathogenesis goes like this. The herpes zoster virus enters through the upper respiratory mucosa. Day 2 to 4, viral replication occurs in the regional lymph nodes of the upper respiratory tract. Day 4 to 6, you have the primary viremia. So as obstetricians, for us, the day 4 to 6 is very important, because this is a time when the viremia is occurring and which could go to the placenta and undergo a transplacental transfer into the fetus to cause a fetal infection. Once the viremia ends, the second round of replication occurs in the spleen and the liver. And on day 14 to 16, a secondary viremia comes in. And this leads to the intra and intercellular edema in the malpighian layer of the skin, resulting in a vesicle. And once this initial infection is over, the herpes zoster virus goes and resides in the dorsal ganglion, where it stays in the inactivated form till something makes it to activate again. And when this latent herpes zoster in the dorsal ganglion becomes activated, then you get the condition called as the herpes zoster. So chickenpox and herpes zoster are both interrelated, and more than chickenpox, actually, the herpes zoster that sometimes, we are asked questions about during the pregnancy. So we'll be covering both these aspects. Now, the course, the incubation period of chickenpox, I already told you, about 10 to 21 days. The infected person can spread the virus for up to 48 hours before the rash appears. So this is very important for us because, chickenpox is a disease of childhood. and especially our multigravida patients who have got children at home, who might have gone to the school and got infected from there. But remember, the infection comes 48 hours before the rash appears, and it remains contagious until all spots crust over. So the rash begins about 48 hours at the onset of headache, malaise, and fever. And I already told you that varicella zoster is more serious in adults than in children. It has been calculated that it is 25 times more serious in adults as compared to a child. The chickenpox rash goes through 3 phases: the maculopapular, the vesicular, and the crust. The raised pink or red bumps, papules, which break out in different spots over several days. Then the fluid-filled blisters or the vesicles forming the raised bumps about 1 day before breaking and leaking. And this is the time when it is very, very contagious. And the vesicles then crust over within the 5 days. But remember, unlike smallpox, where you get a single crop of vesicles, new bumps continue to appear for several days. As a result, all the 3 stages of the rash, that is bumps, blisters, and scab lesions, can be seen at the same time in a patient. Next, we come to the important aspect of chickenpox in pregnancy. So chickenpox is an uncommon disease. And why is it uncommon? Because 93 to 95% of women of childbearing age are seropositive with viral-specific IgG antibodies, because most of us have had chickenpox during pregnancy. But unfortunately, something has been happening, and in spite of having chickenpox once, there are many adults who are now getting a repeat attack of chickenpox. And I can vouch for it because I got my second attack of chickenpox when I was in my final year MBBS. So it could happen at any time. Now, roughly, chickenpox complicates only about 3 in every 1,000 pregnancies. And the maternal varicella, which results in viremia, will transmit the virus to the fetus by 3 routes. Number 1, the transplacental spread. Number 2, the ascending infection from the lesions in the birth canal. And the third would be a direct contact or a respiratory droplet from the mother coming in contact with the baby after birth. So there are 3 different ways by which it could be transmitted, either to the fetus or the newborn. The transmitted rate during maternal viremia has been estimated to be about 25%. And the consequences for the infant, both the fetus as well as the newborn, depends on the time of maternal infection. So it's not same throughout the pregnancy. As we go further, we'll see what happens if the infection is in first trimester, second trimester, or third trimester. The clinical presentation is pregnancy is absolutely similar to general population, same fever, rash, and all those things. And there is no difference at all in the presentation. But excess morbidity is associated with varicella infection in adults, especially pneumonia, hepatitis, encephalitis. All these 3 can occur, and they could result in the mortality of the mother. The pregnant patient subject who get chickenpox will develop the high fever, and which can last for even up to 7 days. Now, the patient can develop a chickenpox pneumonia, that is 10 to 30% of the patient will develop the varicella pneumonia, which will be more severe in a pregnant woman and is associated with mortality rates of about 40%. So how do we diagnose chickenpox? The diagnosis is on the basis of clinical history and the classical signs and symptoms. Remember, there is no need for laboratory tests. If my history, if my clinical examination tells me it is chickenpox, it is chickenpox. Well, there are some laboratory tests available, including the testing for the PCR for the virus or the viral antigen detection by IgG, IgM or whatever, and viral isolation by doing cultures and serological diagnosis. But these are useful only for atypical cases. For a routine chickenpox in pregnancy, we do not need any laboratory tests. And the differential diagnosis during pregnancy could include bullous pemphigoid, drug eruptions, impetigo, or insect bites. I've had many cases coming to me, sent to me rather, as chickenpox, and ultimately they turned out to be insect bites. You know, Bangalore has got a very big population of mosquitoes, and some of the mosquito bites really give rise to those bumps. And so there is some confusion whether it is chickenpox or just an insect bite. Next, we go to the obstetric complications. Now, I already told you varicella can cause maternal mortality and morbidity.
Hello.
Sorry? Alternatively, the other obstetric complications that we could have is the preterm labor. The mechanism of increased prevalence of preterm labor is unknown, but it's probably that the inflammatory mediators, including cytokines, which are released due to viremia, may cause the preterm labor. The fetal involvement in varicella has been traditionally divided into three forms. Number one, the varicella embryopathy, which stems from the maternal disease resulting before 20 weeks of gestation. Number two, the fetal varicella syndrome, which is a congenital varicella resulting from maternal infection, which occurs after 20 weeks of gestation. And third type is the neonatal disease occurring when the pregnant patient has active lesions around the time of delivery. So when you have an infection before 20 weeks, there are three possibilities that could occur. The first and the most important to remember is that there is a very, very low chance of infecting the unborn baby. The risk appears to be less than 1% before 13 weeks and less than 2% if the infection occurs before 20 weeks. So roughly the maximum number of your patients who can be affected by varicella, the fetal infection, is only about 2%. So our job is to just reassure the patient, tell a lady, don't worry, nothing is going to happen. The next one that could occur before 20 weeks is the spontaneous miscarriage. But the risk is not generally increased, especially if the chickenpox occurs in the first trimester. And the last, which is a little worrying, is a varicella embryopathy, which was first described in 1947 by Lafayette and Lynch. The embryopathy includes limb hypoplasia, skin scarring, central nervous system involvement, and other skeletal lesions. Fortunately for us, varicella embryopathy is extremely, extremely rare. So next we go to the fetal varicella syndrome. The congenital varicella can result from maternal infection after 20 weeks of gestation. It occurs only 1 to 2% of the maternal varicella infection. So it is not all that common. Please do not do a termination of pregnancy just because the patient has had a chickenpox. We should be very careful about that. And this fetus has a very, very small chance of being affected, and we need to be careful about it. And if you have 1 to 2% of varicella infection, it's characterized by skin scarring, eye defects, microcapillary cataract, hypoplasia of the lungs, gastrointestinal and urogenital malformation, and neurological abnormalities. Now, what is more important is that most of these malformations can be seen by ultrasound. So after 20, if you have an infection at, let's say, 23 or 24 weeks of pregnancy, and you do a scan at around 28 or 30 weeks of pregnancy, if there are no defects, please reassure the patient that nothing is going to go wrong. Now, between 28 to 36 weeks of pregnancy, this kind of a late infection is not associated with adverse fetal effect. What it can do is it can present as shingles, that is the herpes zoster, in the first few years of life, but it is not going to do anything else to the fetus. That means up to 20 weeks and between 28 to 36 weeks of pregnancy, if you have got chickenpox, you can very easily reassure the patient that nothing is going to happen. Now, let's see what happens if the infection occurs after 36 weeks of pregnancy. Now, the timing of maternal infection in relation to delivery determines the risk to the infection. So basically, you have the transplacental inoculum versus the time for development of the protective maternal antibody, which being IgG in nature, goes across the placenta into the fetus and can protect the fetus from any effect of the virus from coming in. Now, newborns whose mothers develop varicella rash from 5 days before and 2 days after delivery are at risk for neonatal varicella, which has a very high mortality of about 30%. So for us, the lesson as obstetricians to learn is that if you have a patient with varicella around term, try to postpone her delivery at least by 5 to 7 days. And the baby will come out very, very well, and you don't have to worry about it. Now, neonatal varicella, I already told you, has got a very high mortality rate, and it is associated and manifested with skin lesions and pneumonia. Now, if varicella manifests in the mother more than 5 days before delivery, there is essentially no risk to the infant because the varicella antibodies have been transferred to the fetus. So, which I already told you, I repeat again because it's very important, is that if you have a patient with chicken pox around term, avoid delivery for at least 5 to 7 days after the onset of maternal rash. But one thing we need to remember, even after the baby is born, is that avoid direct contact with the respiratory droplets, because this can result in infection in the neonate. Now, the next question comes is, okay, well, I have had a patient between 20 to 28 weeks, and I'm a little worried that there is a fetal varicella syndrome. Can I diagnose it prenatally? Yes, there are many ways of diagnosing this infection prenatally. The first one, and the most common that we use, is a detailed ultrasound, where you can have limb deformity, microcapillary, hydrocephalus, soft tissue calcification, and FGR. So in a patient who has had varicella, if you find any of these defects, please start thinking whether there is a fetal varicella syndrome. The next test that they can do is the fetal MRI, and you can again look for the same morphological abnormalities. The third one that we do quite often is the amniocentesis. So I do an amniocentesis on the patient and send the amniotic fluid for a PCR, that is a polymerase chain reaction, to identify whether there is VZV DNA present in this amniotic fluid or not. But what we need to remember is that maternal infection is not equal to placental amniotic fluid or fetal infection. That is the first principle. The second principle is that if there is a placental infection, it is not equivalent to amniotic fluid or a fetal infection. The third most important point is that if there is an amniotic fluid infection, still it may not mean that there is a fetal infection. So we need to keep all this in mind when we are counseling the patient. And this is one of the reasons that amniocentesis is not routinely advised, because the risk of fetal varicella syndrome is very low. Now, supposing I have had some doubts and I've done an amniocentesis and I find that it is positive for VZV, but the ultrasound examination is normal. There is no limb shortening, there is no microcapillary, there is no FGR, then the risk of FPS is very low. Now, I have not done amniocentesis, but I've done an anomaly scan, which was normal. I repeat an ultrasound at 23 to 24 weeks, a second delayed anomaly scan. And if this anomaly scan is normal, then FPS is very remote. You can reassure the patient for all practical purposes that the baby is not going to suffer from the varicella issue. But if I find that the ultrasound shows features which are compatible with a varicella infection, like microcapillary or hydrocephalus, or a soft tissue calcification, I do an amniocentesis and I find that the amniotic fluid is positive for herpes zoster PCR. Then the chances of this baby having an infection is very, very high. So please do not straight away order a termination for a patient who has had varicella. Do not do that. The chances of the baby being infected is very rare, and even in those rare conditions can be easily picked up most of the time by only ultrasound. And if you're still worried, then you do an amnio and you will definitely pick it up. How do I manage a pregnant patient? So first thing is avoid contact with susceptible individual. Now, we get many multiparas, as I already told you, that children go to school, pick up chicken pox from the school and come back. Now, once the first child at home for this lady has chicken pox, then it becomes our duty to make sure that she doesn't come into contact with the susceptible individual. Then if she still develops the infection, they give her symptomatic treatment. The most important treatment that we can give is oral acyclovir. Now, if I start oral acyclovir within 24 hours, this is very, very important. Within 24 hours of the development of rash, then the acyclovir is going to act very, very well, and I may not have to worry any further about this patient. Now, we are always worried about using a drug during pregnancy, and acyclovir, we have heard some stories which had come a few years back. But remember, there are no adverse fetal or neonatal effects which have been proved till today about the use of acyclovir. So without hesitation, we can definitely use acyclovir, especially after 12 weeks of gestation is over. Now, the other important point as obstetricians we need to remember is that do not deliver this patient when she's viremic. Do not deliver her for the first 5 days after she gets the fever, because this would be an extremely hazardous delivery, and there could be maternal risk like bleeding, thrombocytopenia, DIC, and even a viral hepatitis. Apart from the mother, there is a high risk of varicella in the newborn with significant morbidity and mortality. So supposing the patient has gone off into labor, for us as obstetricians, it's very easy to say, don't do anything, wait, try to push those 5 days. But the pregnancies have a mind of their own. And 2 days after the so-called infection, if the patient goes off into labor, then I'll have no choice but to deliver her. And when I do that, I need to give her IV acyclovir. Oral acyclovir will not be enough. I'll have to give her IV acyclovir. Now, what are the drugs that we can use to treat during pregnancy? So the main treatment for herpes zoster is antiviral medicines. Drugs commonly used are acyclovir, valacyclovir, and famciclovir. These are all pregnancy category B drugs, meaning that they appear safe to be for use during pregnancy. Only thing is that use them with caution in first trimester. You have to use them if required, but try to avoid them in first trimester. And acyclovir, I repeat again, should be preferably started within 24 hours of the onset of rash. And how much do you give? Look at this, acyclovir, 5 tablets. So 800 milligram, 5 times per day for 7 days. If you are using valcyclovir, the valacyclovir is a prodrug, which is an esterified version of the acyclovir, and it has got greater oral bioavailability. So in my practice, most of the time when I have chickenpox, I've been using valacyclovir rather than acyclovir. And valacyclovir, you give 1000 milligram, and look at this, 3 tablets per day. That means 1000 milligram PID for 5 to 7 days. And as I told you, severe infection or infection where I'm forced to deliver the patient, then I would use IV acyclovir. Or if the patient develops pneumonia at any stage of the pregnancy, then we have to use acyclovir. Then there is another drug available to us, that is the varicella zoster immunoglobulin, or what is called as the VZIG. Now, this is used for passive immunization. So it's a ready-made antibody which you are giving to the patient. Each vial contains 2 ml, and the recommended dose is 6 ml for the adult. It is given by deep intramuscular injection with very few side adverse effects other than the local discomfort that the patient can have. Now, this can be lessened because generally VZIG is preserved in the refrigerator. So if you bring it out and make it to the room temperature and then you inject the drug, then the local reactions are definitely much lesser. But one thing we should remember, generally we give immunoglobulins quite often. The other immunoglobulins we have been giving IV. But remember, VZIG should never be given IV. It's an IM drug. Now, all pregnant who have had significant exposure to VZV infection and who have no history of chickenpox and who are seronegative or the serological testing is not available should be offered VZIG. Now, what do you mean by significant exposure? Significant exposure is defined as, number 1, living in the same household as a person with active chickenpox or herpes zoster. Number 2, face-to-face contact with an infected person for at least 5 minutes. This would include most of your nurses, your ANMs, or even if you are somebody like me who likes to spend more time with the patients, then it would definitely be a more than 5 minutes exposure. Or you are staying in the same room. For example, the patient is delivering in the labor room and you are also present in the labor room for more than 15 minutes.
Can we just make it faster because time is over?
If you want, I can stop now, no issue.
No,
Okay,
no,
we'll
but
go straight to conclusion.
Okay.
Okay, we'll go straight to conclusion, no problem. So what we are going to miss out in how to give the anesthesia, what is the algorithm for it, should the breastfeeding be allowed, can the neonatal infection of varicella be attenuated, is the herpes zoster shingles, how do we manage it, how do you manage a person who has a contact with having a zoster, what kind of vaccination you give, what happens if you give vaccination to the patient. And if you are more interested, you can read this book, which was edited by Dr. Alpesh Gandhi, where there is my chapter with pregnancy with chickenpox.
Hello.
And thank you all for the very patient hearing.
Namaste, sir.
Thank you.
Thank you, sir. Sorry for,
No problem at all. I understand the time constraint, not an issue.
Time constraint. But yes, it was very important session because, we all are confused right now. If patient is exposed to herpes, what we should do. Usually people say terminate the pregnancies, and we have seen in our clinical practices also that people do come that they have terminated the pregnancies because they had chickenpox. But now the take-home message is absolutely clear that we should see whether the baby is infected or not, and there are treatments available. And only if we see any problems with the fetus, we should go ahead with it.
Yeah, the
Thank you.
chances of infection is very, very less. So before you order termination on a patient who has had chickenpox, please think 100 times. Then only order termination.
Thank you.
Thank you. Thank you, chairpersons, and thank you, sir.
Dr. MC Patel is here. Thank you, Dr. Patel.
Yeah, thank you, Prakash bhai. You have justified our invitation and you have covered subject very nicely. And Monica, now invite Dr. Reena Vani madam. She is already there. She has joined. Thank you.
We really apologize to madam. Her talk was first, and because of some misunderstanding, she has to wait. We are really sorry, madam. And I request chairpersons Venus madam to introduce Reena madam. Venus madam, please introduce Reena madam.
Vidhu ma'am, maybe you can introduce.
Vidhu madam, you can.
Okay, fine. So everybody knows Dr. Reena Vani. She's a professor and head at Department of OB-GYN at HBT Medical College and Hospital, Mumbai. And ma'am has been associated and very active working in Foxy, and we have heard her many times. So not taking much of her time, we will just call her for her talk.
Yes, thank you so much. Thank you, Dr. Patel, for your invitation. And unfortunately, the program is running very late. So I think everyone has other commitments. So I will, without much ado, please allow me to share my screen. I'm not getting the option of share screen option here.
You can share, ma'am.
Please enable me to share the screen. I'm not seeing the share screen option. It is not showing the sharing screen option. I'm sorry. I've done many webinars, but it is not showing. I think there's a lot of technical issue here. Okay, now I'm getting the share screen. I'm going for it. Thank you. Share screen. All right. Good afternoon, and thank you, friends, for inviting me to talk about this very important thing. Amartya Sen, our Nobel Prize winner, has said, amongst the most important freedoms we can have is the freedom from avoidable ill health and escapable mortality. And unfortunately, maternal mortality rate, although we have done very well with our Prime Minister Narendra Modi ji leading us, we have reached the rate of 97. There are many states which are lagging behind, and I'm proud to say my state, Maharashtra, has reached the number 33. But still, thanks to the mosquito, certain areas, we do in fact, community surveillance, and certain areas take a beating in maternal health. And in COVID, of course, things were different, but we can save these precious lives and improve by looking at all these infections, because the top 3 causes of mortality in our country are hemorrhage, hypertension, and infections. So friends, my brief today is to talk about malaria and dengue in pregnancy. And you can see it is the mighty mosquito who has even taken down somebody so big as Yash Chopra, who has made the iconic movies. He died of mosquito-related illnesses at the age of 80. Vidyanu Rugvi Mukte. Through knowledge we shall conquer disease. And Arogyam Dhana Sampada is the motto of Cooper Hospital, where I am now working as head of department. But wherever we are working, whether it is in Assam, where Prerna is working, whether it is from the south, we are all giving priority to maternal health as Mata Devi Janani. So the overview of my talk today would be talking about malaria, dengue, in general, the principles of management, and what are the challenges we face as obstetricians. It is impossible to cover both these topics in complete detail in 20 minutes, but I'm going to talk about what are the important things. A brief review of our parasitology, but we must remember it is the female. Again, the female is mightier than the male and takes the infections also all across. And this is responsible, the female Anopheles mosquito is responsible for 1 to 3 million deaths per year. Of this, we know there are 4 types of plasmodia, but vivax and falciparum are the ones we have to remember as obstetricians, because 50% of the vivax are the causes in our country, whereas when falciparum malaria occurs, it is considered the more deadly form. In our own country, there's a distribution of more infections in certain states. And if any of you are in those states, you'll be more careful. But we, even though Maharashtra is not listed in this, in the monsoon, we are actually having in each of our hospitals meetings for monsoon preparedness to control malaria and dengue. And our community medicine departments are actually doing surveillance in the community by going from door to door and taking a record of whether the patients have taken treatment or not. Here we must remember that as obstetricians, we talk about primi gravida being a high-risk pregnancy in general. They don't have any pre-existing immunity. And it has been found that for malaria and pregnancy, primies are more susceptible. There are certain placenta-associated proteins which make the infection more, and they are the ones who are going to have worse outcomes in the high transmission areas. In low transmission areas, it does not really make a difference. The transmission, as you know, is the bite of the infected mosquito, but there's a small proportion in which you'll actually find congenital malaria, which I'll be talking about. Yes, friends, we must remember that we check the blood bags for HIV and HBsAg, HCV, but malaria can also get transmitted through blood transfusion, contaminated needles, and rarely organ transplantation. So this is a complex group of protozoa with more than 120 species, but only 4 cause human malaria. But what I want you to remember is, of course, falciparum and vivax, but malaria and ovale, not so common, but the life cycle, we as humans are only the secondary or intermediate host. This is a little busy slide, but I thought it was worth talking about it, about how the sporogony and the burst of the oocytes is what actually happens. And you'll find there's a lot of hemolysis and a drop in hemoglobin. A lot of us will actually pick up a patient who's anemic in pregnancy because of a severe attack of malaria. And that, in fact, friends, is one of the most common manifestations. Why is it double trouble in pregnant women? Because it's often atypical in presentation, so can be diagnosed late. The parasitemia tends to be more than 10 times higher as compared to a non-pregnant woman. The mortality, unfortunately, for the deadly malaria falciparum is double, almost 13% as compared to non-pregnant population, even with the same complications. In the mother, you can have hyperpyrexia, and as I already said, hemolytic anemia, but metabolic problems like hypoglycemia, lactic acidosis are very common. And in fact, the hypoglycemic drop can in fact lead to fetal demise. Concomitant folate deficiency, bleeding disorders, including DIC, and kidney shutdown and pulmonary edema can also be seen. We have cerebral malaria, which can mimic the HELLP syndrome and eclampsia. Jaundice, again, this is why it leads to confusion and sometimes a late diagnosis. So when I have a patient with jaundice, with borderline high blood pressure and a fever, I have to rule out these causes in addition to the standard PIH or HELLP syndrome. Postpartum hemorrhage can be associated, circulatory collapse, and challenges in fluid and electrolyte balance. Black water fever and death have also been described. Specifically for our second patient, which is the fetus, yes, there is a higher risk of miscarriage, preterm birth. Growth restriction is when there is a long-term or an endemic kind of malaria with low birth weight. But as I said, hypoglycemia or maternal metabolic problems can lead to IUFD. Congenital malaria, I will talk about in a minute or so. But if the malaria persists, the baby may have failure to thrive and a higher PNMR. Why does this happen? And does pregnancy worsen the outcome of malaria? We always describe the fetus as a paternal allograft in the mother. So pregnancy is basically an immunocompromised state. And infection is higher in advanced pregnancy. And as I've already discussed, severity is more in primi-gravid women, and there's a higher morbidity due to the complications of and various organ damage in pregnancy. We know the 3 stages how we describe a typical malarial fit. There's a cold stage, a hot stage, and a sweating stage. And we had the tertian rhythm or the quotidian rhythm depending on the type of the malaria. However, as I've already mentioned, the manifestations are atypical and you won't get the cyclical fever always. The severity of disease depends on the species, the host resistance, and the speed of diagnosis. Anemia is the most common feature of malaria, and splenomegaly may or may not be appreciable. And in fact, repeated attacks of malaria may only be associated with this. But other than the typical fever with rigors, severe headache, malaise, nausea, vomiting, delirium, hemolytic jaundice, and cachexia may be seen. So friends, it's not just a single point which can make the diagnosis. It's a combination of serology, immunology, clinical features, microscopy, and molecular diagnosis. And here I'd like to tell you that we have rapid diagnostic tests for workers in the field, especially in certain countries where malaria is endemic. Although, of course, we all know that the gold standard is light microscopy of thin and thick films. Very often, this thin and thick films, PS for MP, may not be coming positive. So the HRP2, histidine-rich protein 2, is actually a very commonly used rapid diagnostic test, which is used and useful as a screening. Only thing, because of the sensitivity, sometimes you may get a false positive. There are certain other tests like the parasite LDH, which can detect any of the 4 plasmodia or the Plasmodium aldolase. You have other modern methods of technology like the DNA probe, dot blot assay, PCR amplification, but serology, indirect immunofluorescence, ELISA, and RIA. But again, I'm reminding you that it is usually a clinical diagnosis and RDT. And of course, the gold standard is the smear. Now, how are you and I going to manage? Please remember, primarily, she is our patient. Yes, do a multifactorial management, call for the medicine person, but basically, we have to start the treatment. In all trimesters, these are the drugs which can be used. You must be knowing that artemether, artesunate were all an outshoot of Chinese medicine, but they are extremely useful, and WHO has said to avoid using them as single drugs. Mefloquine is also useful for resistant malaria. Sulfadoxine has been used. But the other drugs, which are very commonly used in non-pregnant patients, Primaquine, which is important for radical cure, tetracycline, doxycycline, maloprim, are all not actually recommended. Even mefloquine comes under category C, so you may not always be using it. So what should we use? The correct way to treat uncomplicated malaria would be, of course, the good old chloroquine, and give the Primaquine after delivery. Quinine is used 10 milligram per kilogram orally 8 hourly for 7 days. But please remember, all these can also aggravate the hypoglycemia. So proper hydration and caloric intake. And these drugs make you feel more nauseous and feel like vomiting. So these are the things where they go into metabolic complications. There's a newest drug which has been approved by US FDA, not yet available, I think, in India, called Trintafel, which is a single dose to prevent relapse instead of Primaquine, to be given for 10 days. But, of course, not yet in pregnancy, but can be used post-delivery. What shall we do for the complicated cases of malaria? Again, as we have already said, we can use the chloroquine and quinine, but 7 days treatment is required. IV infusion can be considered in patients who are severely dehydrated or toxic or unable to take intake. If the hematocrit is below 20, we do need to give them blood. And that is, but again, they may be in a hyperdynamic state. So you have to be careful not to push them into fluid overload. If the patient has gone into labor or she has come in labor with malaria, please remember, it is much better to manage her in an ICU setup. Of course, Alpesh sir is the father of critical care in our country and has talked about how we can set up HDUs. And we as obstetricians should know about it. But falciparum malaria, in fact, induces uterine contractions, leading to premature labor. And in fact, the height of the fever may cause this. So be prepared that this patient who you think is not yet going to deliver may give you a surprise. Fetal distress is common, may not be recognized, and these are the patients who may have an unexplained silent IUFD if you're not careful. Definitely, we would like to deliver them vaginally, but if it's not possible, if we have to do an LSCS, we have to do it with general anesthesia because they may be having thrombocytopenia also along with it, and dehydration and fluid overload. The balance is very tricky. And in high parasitemia, exchange transfusion has also been described. If you feel there is oligohydramnios coming up, patient is not getting better, only then you can consider induction of labor. And definitely, if she's breathless and is unable to push, cutting short the second stage by forceps or vacuum can be done. I had talked about congenital malaria. This is due to transplacental or peripartum infection reported in 8 to 33% of pregnancies from endemic and non-endemic areas. I'll remind you that we are in an endemic zone. Almost the entire Southeast Asia is in that zone, and most are following falciparum or vivax malaria. These infants may be born in and show this in the first few weeks of life, as early as the first day or up to the 8th week, with symptoms like fever, anorexia, lethargy, anemia, and hepatosplenomegaly. Other features of neonatal sepsis, which may be confused with other causes like irritability, poor feeding, loose stools, drowsiness, may be seen. So hence the history and knowing the maternal reports are very important to make the diagnosis. Coming next to dengue, because this is the other one which is also causing the problem. 40% of the world's population lives in the dengue-prone zone, and there are almost 100 million infections every year and 22,000 deaths. But proper access to medical care can reduce case fatality rate from 20% to less than 1%. And dengue is an arbovirus of the Flaviviridae family. And again, it is the mosquito, but here it is more importantly the Aedes aegypti and the Aedes albopictus, which are the two main carriers or vectors of dengue. There are 4 serovarieties. This is important when we are talking about the molecular testing, so we should be aware of this. And the clinical manifestations of dengue fever would be a continuous high fever. This usually lasts for 2 or more days, up to 7 days, but more importantly, a hemorrhagic tendency, petechia or epistaxis. This, friends, is more common when there's a second attack. And in fact, the second attack of dengue tends to be more dangerous. Thrombocytopenia and evidence of plasma leakage as manifested by hemoconcentration, pleural effusion and ascites has been described. This is a simple chart which is showing you what you would be able to pick up in these cases. Initially, it would be just the fever with headache, arthralgia, myalgia with the tourniquet test positive. Patient can get dehydrated.
Hello?
Yes, sorry. The WBC count is low, and this lasts for 1 to 4 days. Next, they can go in the 3rd to 6th day to bleeding, shock, multi-organ involvement. 7 to 10 days.
Yeah. क्योंकि उसके patch तो already लगा हुआ है.
There is somebody talking in the background. Ritu, can you mute yourself, please? Volume overload, a hematocrit may be stable, and that's usually seen on the 7th to 10th day. This is just a flow chart for management of dengue without alarm signs or severe ones. Without alarm signs, most important, forget all this which is on the chart. Remember, hydration, rest, and proper diet is the key. Do not give platelets unless there is evidence of bleeding or the platelet count has gone to less than 20,000. In fact, we have managed a lot of cases in our hospital with the medical team, and only if there is alarm signs or there is actual evidence of bleeding or suspicion of internal hemorrhage that we actually give platelets. And please remember that platelets are something which get destroyed very fast. So if she is going into labor, then only you need to give it. Before I go further, I'll just illustrate, this is one of the cases we have managed, which was a very severe case who came G4, P2, NND1, 32 weeks, who came as a gynec reference after ICU admission for fever, weakness, and productive cough. And they had first suspected TB. Pulmonary cox 5 years back, taken ATT, but now she had, and then one neonatal death after the LSCS. Now she was registered at 12 weeks and had come at 32 weeks with this problem. The X-ray showed bilateral patchy infiltrates. Nobody suspected dengue. They first thought of cox, but we have gene expert in our lab, in our hospital, and it came negative for MTB. And here in dengue, we do the NS1 antigen. Before the ELISA comes positive, you will get the antigen positivity in dengue cases. She was NS1 antigen positive. She probably had an underlying pulmonary disease which had got worsened with the dengue. She had a spontaneous preterm delivery in the ICU, but unfortunately went into ARDS, DIC, and sepsis because there is no specific treatment we can give for dengue other than hydration and support. And it's very tricky. And she unfortunately passed away with cardiopulmonary arrest. So friends, this is a notifiable disease. It is sometimes they go into this hemorrhagic fever because, like if you remember in COVID, there was that cytokine storm. There is sometimes an activation of the immune system to release cytokines and chemokines with apoptosis of the cells, which leads to features of shock, third space loss, and a cascade of injury, which very little can be done about it. So we have to be careful, to be very vigilant in these cases with fluid balance. Look for complications like serositis, thrombocytopenia, ARDS, multi-organ dysfunction, and PPH. Oligohydramnios, preterm birth, etc. are known to occur. What can we do? Again, you can see there are no specific medications, but antipyretics, Dolo 650, or your injectable paracetamol, hydration, maintaining nutrition, making sure she doesn't get hypoglycemic, correction of DIC, and only give blood components as indicated, as I've already discussed before. Obstetric management as per standard protocol to prevent complications. Certain things are not in yours and my hand, but prediction of complications when you have a patient with this problem is what is going to help. Do not give the other strong NSAIDs because those will worsen the thrombocytopenia. Monitor the serum electrolytes, monitor the blood coagulation. If there's a presumptive diagnosis, you have to look for the warning signs. And group A, it can be managed in outpatient basis, group B inpatient, and group C, hold on, sorry, just a minute. That was why I was getting a little stressed. I am also looking after one baby. Hold on. Very sorry. I was actually on babysitting duty from 3:30. So I'm sorry I was stressed. My grandson is with me for the last few slides. The presumptive diagnosis is where you live in or travel to endemic areas, plus have fever, no warning signs. Management of labor, blood and blood products should be cross-matched and saved in preparation. Transfusion of platelet concentrates to be initiated or at delivery, but not too far ahead, as the platelet count is sustained by platelet transfusion, but only for a few hours in the critical phase. Fresh whole blood should be made available, and the need of the hour is working together for health and harmony. Sorry. Okay. Potentially life-threatening. It's a near-miss condition. And due to this, friends, we as the torchbearers of women's health should remember, even though this is a gynec issue, we are not a gynec issue with the medicine people, the center being the woman. We have to remember, how was your first flight, son? Feels great, Dad. Everyone was clapping for me, says the baby mosquito, as my little baby is saying. And we are saying, thank you for the patient hearing. Thank you very much. And I'm going to mute myself. Sorry.
Thank you. Thank you, Dr. Reena. It was very, very concise. I know the time is less, but still we all are living in this endemic, areas. We should first is prevention. As far as possible, we should look for prevention and then rest as you have advised. Thank you for your talk.
And we greatly appreciate, ma'am, that you joined us in spite of your personal commitments.
My son is giving some exams, so my son and daughter had put me on babysitting duty.
We greatly,
so I was stressed.
really appreciate it.
Thank you.
Really
Thank
appreciate
you.
Reena madam, thank you for everything. You have joined again and you have justified the topic in our invitation. Thank you for blessing us, giving us time also.
But thank you very much. And I'll be, now he's quiet. I can take any one or two questions if there are any questions.
Yes, Chairperson, is there any question in chat box?
No, I don't think so, Doctor. There isn't.
Okay. Yes, then we can proceed further.
Thank you so much. Thank you for the invitation.
Thank you, Doctor. Thank you.
Thank you,
madam, for your excellent talk.
Thank you, ma'am, for excellent deliberation. We now invite our chairperson, Dr. Venu Bansal, ma'am, to introduce our third speaker, Dr. Shikha Sheth, ma'am. Do we have Dr. Venus Bansal, ma'am, with us? If not, Dr. Vidu, ma'am, can introduce Dr. Sikha Sheth, ma'am. Dr. Vidhu, ma'am.
Yeah. So, Dr. Shikha is a professor and head of the Department of OB/GYN, AIIMS, Gorakhpur. Ma'am has many achievements to her name, and we invite, as not taking much of time, we can see she is life member of so many organizations, and her special interests are in preventive oncology, high-risk pregnancy. Welcome, ma'am, for your talk.
Good evening, everyone. First of all, I would like to thank Patel sir for giving me this opportunity. I am not able to share screen. Yeah. Are you able to see my screen?
Yes, ma'am.
Okay.
Ma'am, put it in slideshow mode.
Okay.
Perfect, ma'am.
So, good evening once again, everyone. The topic which was given to me was battling tuberculosis, protecting mother and child during the pregnancy. So this infective session, probably tuberculosis is the most chronic infection, and the India tops most of the infectious diseases in the world. So I will be talking basically how this tuberculosis affects the pregnancy and the vice versa, who are at risk, how to screen, and what is the treatment for the maternal as well as the neonatal sake. So just few facts about tuberculosis. We all actually know that it's quite a deadly disease. 2 deaths every 3 minutes takes place world over. TB is a major infectious cause for maternal mortality also. Out of the total maternal mortality, 16% is because of tuberculosis somehow. And when TB is there along with pregnancy, there are 2 stress factors which is associated with the mother. And this increases the 6-fold increase in perinatal mortality. So the disease is really alarming kind of a thing. India accounts for 20 to 25% of the global burden of tuberculosis, and women who are living with HIV, if they are pregnant and the co-infection with tuberculosis adds on, it becomes a further deadly in the sense that the death rate further increases a lot. The major problem or the challenge which we face with the tuberculosis is that it's a paucibacillary disease, it's a chronic disease, a slow developer, vague symptoms, and often the common pregnancy symptoms are misdiagnosed, and we always there is a delay in diagnosing actually that there is a tuberculosis also there along with the pregnancy. So challenges mostly we define into 2 categories. One is the client related or the patient related challenges, which means the patients are there is a lack of awareness among the patients about the presence of this disease. Chronically, they may have a family member or a neighbor affected with the tuberculosis from where they can get infected because it's an airborne infection. And there is some, if it is diagnosed, they have to repeatedly go for follow-up for drug administration there, because DOTS kind of a therapy is there. There are costs related with these things also. And secondly, in the provider region also, being a doctor or a healthcare personnel, there are a lot of challenges related with the tuberculosis, whether it is a pregnant case or it is a not pregnant case, means because there's a high load of disease burden, good number of patients are there, difficult to diagnosis is delayed. X-ray in pregnancy, a lot of people are afraid of getting X-rays being done in the pregnancy, especially in the first trimester. There are lack of trained persons who can diagnose, who can test the things. The availability of the molecular test, availability of the X-rays, availability of cytology is also limited in most of the parts of the developing countries or middle income countries. So there are a number of challenges which are there with the tuberculosis. Let's start how the disease can be there in pregnancy. There are 2 kinds of disease phases. One is active disease, another is latent disease. So active disease means active tuberculosis, where the patient have the actual symptoms in the form of fever, cough. If a severe kind of a disease is hemoptysis can be there, weight loss, fatigue, these kind of things are there. The bacteria, that is the mycobacterium, is there. It is dividing, and the patient is able to transmit the disease to the other persons nearby. While the latent tubercular infection is an infection when the bacteria is there in the body, but it is in latent phase. It is not developing. It is not dividing. And it is a non-infectious kind of a thing. The patient is not having any symptoms also, but the infection is there in the body. So as an obstetrician, whenever the patient comes with some kind of a vague symptomatology, we have to think about, because we are in a place where the tuberculosis is quite endemic. So whether it may be tuberculosis, if we have to think about, and we have to recognize the active disease, especially because it has to be treated. So let's go how the TB affects the pregnancy, or whether the pregnancy have its effects on the tuberculosis also. So TB in pregnancy, tuberculosis, if gets infected during the pregnancy, there are chances in first trimester of, I think, abortion. There are chances of being low birth weight babies, FGR babies. There are chances of prematurity because of the disease. High perinatal mortality is there, and there are chances of the baby born to be getting infected, either congenitally in transplacental route, although it is very rare. But yes, during the stay, rooming in with the mother, then the baby can get affected. And similarly, if the pregnancy effect on tuberculosis, if we say, it is really difficult to diagnose at the pregnancy, because we usually don't think about at that time. But there are chances that if the patient is having a latent disease during the pregnancy because of the change in the immune status, their immunocompromisation is a bit there, and the latent disease can get activated. And sometimes if the patient has been diagnosed and even the treatment has been started, the medications which are the four basic medications, and they have nausea and vomiting as a common side effects. And then ultimately in the pregnancy itself, first trimester, the nausea and vomiting is there. And sometimes the intolerance to the drugs and all those things, and hepatitis, liver enzymes, these kind of things comes up in the pregnancy. And often we are again in doubt whether to continue them, stop them for some time, or we add on some other drugs, which again complicates the things further. So these are how the things matter, and the challenges are there. So we should know who are at risk. As such, pregnant ladies, as well as the postpartum period of first 3 to 6 months, these women are actually increased risk of developing tuberculosis if they are in a place where the infection is the prevalence is high. If somebody in the family or nearby or has tuberculosis, active tubercular disease in contacts, if they are workers, like healthcare workers themselves have become pregnant and they are working in some like TB sanatoriums or the medical colleges or any of the place where the TB patients are coming, or they have traveled to some other places, babies born to these mothers active tuberculosis, they have a high chance. So these are the basic risk groups. Because of immunocompromised status of the pregnancy, this disease is more common. So whenever we have this group like HIV positives, immunocompromised, the women who are at some immunosuppressant drugs for any other chronic diseases, symptomatic cases who have chronic cough, persistent fever, who have some active tubercular patient in the family itself, or who have come from travel to some other very high prevalent zone. So these are the patients who actually should be completely screened for tuberculosis even in the pregnancy. And there is a thing which has been given, the terminology which is given by WHO, that is called as systematic screening for the tuberculosis, whether it is pregnancy or whether it is not in pregnancy, for all those high-risk patients. All the high-risk patients includes, yes, of course, the pregnancy. That's why I've included this slide here. So systematic screening includes the starting from symptomatology. There are 4 basic symptoms which have been defined for the tuberculosis. Common symptoms: prolonged cough with expectorations, low-grade fever persistently for a long period of time, weight loss or failure to attain optimal weight gain during the pregnancy as it is expected, malaise, lethargy, fatigue, anorexia. These are the 4 main group of symptomatology. And if it is a severe disease, yes, of course, we all know that hemoptysis and chest pain can be there. So first, the symptomatology has to be screened. And if the woman comes out to be screened positive for this for this symptomatology point of view, then we have to go for some other TB-related tests. The TB-related tests are usually based on whether it is a pulmonary kind of a tuberculosis or an extrapulmonary kind of a tuberculosis. Mostly it is the pulmonary tuberculosis which we come across in our country. So investigations for pulmonary tuberculosis may be sputum cytology or the sputum culture. 2 samples of the sputum has to be taken, one anytime whenever the patient is coming, or in the next early morning sputum sample. 2 samples are must, which should be sent for cytology. AFB staining it has to be done, or the culture can be done. The newer thing which has recently added up is we have so many of molecular tests available which gives the result early. They are fast and they have a higher sensitivity in the sense that even a smaller number of bacteria, if it is there, they can identify. So we can do a PCR kind of a test and the TrueNat or a CBNat kind of thing, which are usually available even at the peripheral centers for the TB diagnosis. Gene experts and line probe assays are the further advanced kind of versions of these diseases. Imaging is the thing, the chest imaging, because chest pulmonary tuberculosis, X-rays can be done with the shield and the abdomen in any of the trimester, preferably. We should avoid first trimester, but yes, if there is a doubt, there is no problem with the abdominal sheet. X-rays, CTs can be done. And we have, if there is some other extra pulmonary tuberculosis suspicion is there, suppose lymph node is enlarged, we can go for FNAC. If the meningitis kind of a thing is suspected, we can go for lumbar puncture. So whatever from where we can get the tissue, we can have the tissue histology also for helping us in diagnosing the tuberculosis, where the granulomas or caseation kind of a thing can be seen under the microscope. Immunological tests, they have a thing of a doubt, but yes, of course, they are there, which are like T-spot or quantiferon TB gold. These are also being suggested, but not so very diagnostic for the tuberculosis. So we have, for the active disease, we have the symptomatology, and any of these tests can come out to be positive, which will confirm that is a case of active tuberculosis. Whenever there is the test, which we all have done many a times, is the Montoux test or a tuberculin skin STST, tuberculin skin test, that where we inject 1 to 2 tuberculin units of that protein into the intradermally, and then after 72 hours, we read the induration, we have to measure it. And if the duration comes out to be more than 10 millimeters, then it is suggestive that the patient is having a latent tuberculosis, means there was an infection which can be there latent. But if she is not having any active disease features, active symptoms, it means it's a latent tubercular infection. So pregnant patient can have a latent tubercular infection or the active tubercular infection. Latent tubercular infection, we don't have to worry much, but in active disease, we have to identify first with the symptomatology, and then we have to do some of the tests to confirm the disease so that we can do the treatment. So now coming for the treatment of the tuberculosis disease. So latent tuberculosis, as I have said earlier also, there is no need for the treatment in pregnancy for all the cases, but there are few cases where we need to have the treatment for the latent disease also. So those are the cases where those latent tubercular infection cases who have recent exposure to some infected case, active infective case. If they have got the exposure, then yes, of course, they should get some treatment. If the TST conversion has recently been taken place, earlier it was done for some other point of time, it was negative, and now this time it has come with the more than 10 millimeters cutoff margin. Since a recent TST converter is there, then it also needs to be treated within pregnancy. And if say immunocompromised woman, a pregnant lady, that is if she's HIV positive, CD4 count is less, then of course these are the women, even with the latent tuberculosis, it is said as per the WHO, that 6 to 9 months of INH prophylaxis, 300 milligrams daily should be given. And whenever we give an INH, because of chances of neuropathies are there, we should always add pyridoxine 40 to 100 milligrams per day to these things. So all women with a latent tubercular infection does not need the treatment. Only those who have got a recent infection, exposure to the active tubercular disease, who have got recent tuberculin skin test conversion, and who are actually having immunocompromised status, especially additional immunocompromised status because of the HIV or some other kind of a disease. These only
Dr.
need...
Sikha, can we see the time? If we
Yes, I'll try to finish. So active disease treatment, we have 2 basic categories now. It's a DOT strategy, means directly observed treatment, short course. Earlier, we used to give an intermittent kind of a therapy 3 days a week, but nowadays we give a daily treatment regime. The category 1, we all know it's a 6-month therapy with 4 drugs at the intensive phase and the 2 drugs, that is INH and rifampicin, in the continuation phase, while the category 2 is a retreatment. Retreatment means the patient has got the treatment earlier. Either it was cured and it is a relapse which has come across, or it was the sputum positivity has persistently been there, or she was an defaulter in cases of incomplete treatment, something like that. Those all come under the retreatment category, and category 2, where the treatment is of 8 months, that is 2 months of intensive phase with 5 drugs, including the streptomycin, 1 month of HRZE, 4 drugs, and 5 months of HRE, that is INH, rifampicin, and thiambetal. So this is the basic treatment regime everyone should follow, whether it is pregnant, whether it is non-pregnant. The same categories is being continued. We have all those drugs, 4 common drugs, the first line drugs which we have, and the dose should actually be given as per the weight of the patient. This is again very much important. All are mostly are the category C drugs, except the streptomycin, which is category 3. So it should be avoided in the pregnancy, especially the first trimester. There are other drugs related with the tuberculosis which are contraindicated, like fluoroquinolones, kanamycin, capreomycin. These are basically the label second generation drugs which are basically used for the management of MDR and XDR tuberculosis. But yes, of course, the first line tubercular drugs all are safe in pregnancy and can be given even in the pregnancy from the first trimester. Labor management is almost like the same of any other non-tubercular patient. There is no need for cesarean section or anything like that. But yes, of course, in the second stage of labor, if the patient is really cachexic, very weak, febrile, and then of course the second stage can be made to cut short either with the forceps or the ventouse if required. MDR and XDR, we all know the things are increasing in number. They have to have a second line level of therapy, and even some of the second line drugs may have got the resistance. So there is no fixed regimen for these second line drugs especially for the pregnancy. WHO has come up, if the isoniazid is resistant but rifampicin is susceptible, then we can give a 6 months of rifampicin, pyrazinamide, thiambetal therapy. But if both the drugs are resistant for a particular woman, then it becomes again difficult. There is a new drug which has recently come up, that is bedaquiline, but its effect in the pregnancy or the safety in the pregnancy has not been taken care of with a good number of results. If we talk about neonate, yes, we can have 3 kind of things with the neonate: that the baby is not having any disease when it is born, or maybe a baby who has born with
we are running out of time.
just finishing. Congenital active tuberculosis is really very, very much rare, or transplacental transfer of tuberculosis to the baby is very rare. But yes, of course, after the delivery of the baby, because of the rooming in with the mother can have. Special situation is the HIV positivity, and the co-infection with tuberculosis is quite common. So in this particular thing, I just want to enumerate that there is a thing again which is recently added by the WHO, is the tubercular preventive treatment, TPT. This should be given to the patients if they are pregnant, HIV positive, and they have a co-infection with the tuberculosis also. So TPT is given regardless of the antiretroviral treatment, irrespective of degree of immunocompromisation. See, that is whatever is the CD4 count, whether she has taken the treatment or not. So this is a preventive treatment which includes basically the isoniazids for 6 months, the same dose level, 6 months of isoniazid, or if it is resistant to isoniazid, then 4 months of rifampicin has to be given. This is called tubercular preventive therapy, should be given to the pregnant ladies with the tuberculosis living with HIV and AIDS. So whenever there is a co-treatment is to be identified, started in the pregnancy itself, it is to be said that TB treatment should be started first, even before ART, because if you start ART, there can be a chances of some immunological changes, which is called as immune reconstitution inflammatory syndrome. So better to start TB treatment first, and after 6 to 8 weeks time, then we can start on her ART treatment. Rifabutin is preferred over rifampicin in these particular cases. Breastfeeding, yes, of course, should not be discouraged. But yes, of course, if it is an active phase of tuberculosis,
we can take
just finished.
Yeah.
This is the key
Thank
message.
you. I know it's a little but there's a lot of, I think.
Yes, of course. I know the things are going quite late. Thank you, Dr. Patel, sir, and the whole of the team for giving me the opportunity.
Thank you.
Thank
We
you,
can take the
ma'am. Thank
questions
you.
later.
Thank you so much thank you so much for excellent deliberation. We have Dr. Venus Bansal, ma'am, will be giving the closing remarks for the session.
This was a very wonderfully curated presentation by Shikha ma'am. Just want to say that untreated tuberculosis is much more hazardous than the treatment per se, which is needed for the tuberculosis. And the treatment, yes, definitely there is some crossing of the barrier in the placenta, but still the treatment is less harmful than the untreated pregnant patient. And great presentation. Thank you so much, Shikha ma'am.
Thank you, ma'am. Thank you for your words of wisdom. And thank you, chairpersons, Dr. Vidhu, ma'am, who has been a savior because our two chairpersons couldn't join right on time. Thank you, Dr. Venus, ma'am, for creeping in at the last minute. And Dr. Reena, ma'am, in spite of all confusions, ma'am still made it so bright and sweet. Thank you so much, ma'am. Dr. Prakash Mehta, sir, and Dr. Shikha, ma'am, for a wonderful deliberations. Thank you all. We now move on to the next session. And I hand over to our coordinators, Dr. Dhawan and Dr. Ashok. Our next session, please, on liver disorders in pregnancy.
Thank you so much to all the faculty and the coordinators. And I will again please request all the speakers to please maintain the time. We still have 3 sessions to go, 6th, 7th, and 8th, and people have joined in time and are waiting. Thank you so much. Please carry on.
Hello. Hello.
Yes, sir. You are audible, sir.
Yeah, I am audible. So, thank you and best wishes to our MC Patel sir for the next election. And without wasting time, I would like to introduce our chairpersons. Our first chairperson is Dr. Pushpa, and she is a professor and HOD OBGY at Amravati. And our second chairperson is Dr. Sudha Gandhi. She is a senior professor and head of the department at R&T Medical College, Udaipur. And our third chairperson is Dr. Sujata Dalvi. She is attached and associated with Varia Maternity Home, Bhatia, Saifi, and St. Elizabeth Hospitals. And without wasting time, I would like to hand over this session to our chairperson would invite request them to introduce our speakers. Thank you.
Hello, good evening. Now we are on the next section, which is very important section, that is liver diseases and pregnancy. Any liver disease complicating pregnancy, we are extremely apprehensive. That is not only for the mother and baby, but what will happen to the course of pregnancy and the liver disease. Most of the liver diseases, they deteriorate if the pregnancy is continued. So Dr. Poonam Verma will be session will be the first session. May I have her CV? Dr. Poonam Verma. He is medical superintendent at MGIMS Sevagram. Before that, she was heading the department of OBGY at Sevagram, and she has a lot of things to her credit. She is busy in most of the projects which are very useful for the womanhood and especially rural women. So over to you, Dr. Poonam.
Thank you, ma'am. I'll just take a minute to share the screen. Is my screen visible?
Yes, Dr. Poonam.
Yes, ma'am.
Am I full screen or not?
No, ma'am.
No, you have to adjust the screen in the center.
Slideshow.
Slideshow at the top. Right.
Yes. Does it come?
Perfect, ma'am. Go ahead.
Okay. So a very good evening to all of you. I bring greeting from Mahatma Gandhi Institute of Medical Sciences, Sevagram. And without wasting time, I'll go into the topic. We are doing high-risk cases and low-risk cases, both where we have introduced midwifery. So coming on to the introduction and a little bit more about what the liver disease is and why this liver disease is important for all of us. Liver disease during pregnancy is a challenge for an obstetrician because it ends up with severe hemorrhage, DIC, and extreme fatality. Approximately 3% of pregnant women are affected by some or the other form of liver disease leading to jaundice during pregnancy. And there are 3 types of liver disease which need to be differentiated during pregnancy. Liver disease could be directly related to pregnancy, not related to pregnancy, or pregnancy occurs in cases where liver disease is persisting. So coming on to the content of my presentation, that I'll talk a little bit about the physiology, liver disorders in pregnancy, jaundice, basically, general evaluation, common modality of management, a specific disease, I don't know, it's moving, specific diseases and their management, a bit of recent advances. So when we talk about physiological changes in pregnancy, liver size remains unchanged in pregnancy. Hepatic, arterial, and portal venous system flow increases. Prothrombin time, bile acids remain unchanged. This reduction in ALT, AST, gamma transpeptidase, bilirubin, and serum albumin, where if you look on this side, cholesterol, triglycerides, alkaline phosphate, clotting factors 2, 5, 7, 8, 9, 10, 11, ceruloplasmin, total albumin, transferrin, and serum fibrinogen increase. When we go into the physical examination, the skin will show palmar erythema and spider angiomas, but these are usually seen in liver diseases. But some portion of the women, you will find that this is also normal because it is secondary to high estrogen levels. Also in 3rd trimester, because of this enlarging uterus, it displaces the liver superiorly and posteriorly. And a palpable liver is abnormal always in pregnancy. When we do sonography, we will find that biliary tract is usually normal. And in pathology, there are no specific changes in the liver. These are the normal values, and we are more concerned about 2. One is AST and another is ALP. Slight increase of ALP is there. Now, coming on to jaundice in pregnancy, the incidence is around 0.1% in the developed countries, whereas it is 3 to 20% in developing countries. And there are some areas where even higher incidence has been reported. When we look into a particular study which was done by Government of India, it was noted that the incidence reported in the hospitals was 0.4 to 0.9 per 1,000 pregnancies. When we say jaundice causes, we are talking about 3 categories. One is unique to pregnancy, which is intrahepatic cholestasis, acute fatty liver of pregnancy, hyperemesis gravidarum, HELLP syndrome, and preeclampsia. Coincidental with pregnancy is, of course, all variety of hepatitis, drug-induced gallstones, and Budd-Chiari syndrome. And antedating pregnancy are chronic hepatitis, cirrhosis, congenital hyperbilirubinemia, so on and so forth, where even you have liver tumors and liver transplantations. Also, I would like to say that jaundice also happens because of hemolysis. So many a times because of hemolysis, such as sickle cell disease, you may see jaundice. Now, it's extremely important that we take a good history where we know the duration of jaundice. We know what are the symptoms like nausea, vomiting, weight loss, and how long it has been persisting. Any history of drug intake, any history of epigastric pain, which is going on to the right upper quadrant, and there's abdominal distension, headache with difficulty in vision, increased or decreased urinary output later on, and high BP records, yellowish discoloration of urine, clay-colored stool, fever, bleeding from any side, itching all over the body, hematuria, blood transfusion, and past history of jaundice, liver disease, gallstones, and related surgery. Now, when we look into these kind of cases where a woman has presented with jaundice, it's extremely important to look into the level of consciousness, signs of encephalopathy, where fetal hepaticus is there or not, and what are the alertness changes? Does she have hepatic flap, stupor, etc.? We look into the vital signs, which is mandatory, and look into the various bleeding disorders, some kind of purpuric spots. Many a time, subconjunctival hemorrhage itself is an issue. And then, of course, looking into the chronic diseases like spider angioma, dependent edema, and ascites. Now, it's extremely important to do abdominal examination, not only for obstetric reasons, but also to look into the liver size, because anytime if there is hepatomegaly, it's extremely significant. And of course, sometimes you may see the masses, you may see different presentations of the liver enlargement, where you may see it nodular, enlarged, and so on and so forth. Of course, obstetrical examination is important to assess the fundal height, to look into the gestation presentation which is normally done. Why it is important here? Because we would also like to know what is the weight of the baby and so as we can go ahead more for vaginal delivery than cesarean section, which is becoming very common now. So we would prefer here in such cases vaginal delivery. And of course, vaginal examination is done as and when needed. Now, what are the common clinical features when we talk in terms of jaundice? So I already mentioned that there are these symptoms with which women will present: loss of appetite, weakness, yellowish discoloration of eye, urine, fever, so on and so forth. And then when we look into the sign, we'll find significant pallor, icterus, which has to be graded, because icterus is something which will tell you how bad is this disease and how is she progressing. And of course, edema, so on. And this I have already discussed, flapping tremors and all, so I won't take time. Now, coming on to the common investigation, which everyone would like to do for a case of jaundice, is complete blood count, peripheral smear for hemolysis, PT, APTT, the liver function test in which total bilirubin, direct and indirect, along with it, transaminases, which are very, very important because they are the ones which tell you the diagnosis, because if they are in thousands and all, they go in the diagnosis of hepatitis, whereas if they are in the lower range, there are a number of things like acute fatty liver of pregnancy, HELLP, and so on and so forth. Total protein is also very important. Urine examination, especially for bilirubin, KFT, serum creatinine, serum uric acid, serum electrolytes, cholesterol to know certain other disorders, blood sugar, and of course the routine markers in case we are suspecting viral hepatitis, so IgM, HbA, HbSAg, and many other markers which I will be talking to you subsequently, autoimmune antibodies. What is very important here is to do sonography of whole abdomen to understand the hepatic enlargement, parenchymal structure, any obstruction, stone, and so on. Liver biopsy is only limited for some cases. So how do we go with initial workup? A pregnant woman presents with abnormal liver test, one should go for these things. As I have already told you, the basic investigation, they are mandatory, and imaging is something which is going to give us most of the ideas. Here, I would like to tell you that for the normal jaundice cases, we will do a simple sonography, whereas if we are suspecting that there is some kind of hepatic tumor, some obstructions which are not being relieved, or there is some suspicion of cirrhosis and all, in those cases, MRI becomes the test, and many a times ERCP and endoscopy also can be done. Now, common management step for all the jaundice patients is you admit them. There's no role of domiciliary treatment, restriction of protein intake and increasing high carbohydrate diet. Giving lactulose, a colonic acidifier to decrease ammonia in the blood. Ursodeoxycholic acid 300 milligram twice daily for increasing conjugation of bilirubin, and it relieves pruritus as well. Vitamin K is mandatory, 10 milligram must be given if platelets are normal, otherwise we can give even IV. For preventing bowel bacterial flora proliferation, either neomycin or rifaximin, which is being given nowadays 550 milligram twice a day. Symptomatic management of fever, and in case of hypoglycemia, IV dextrose 25% can be given. And if the woman is critically ill in hepatic coma, then multidisciplinary approach to manage this case should be done. So these are the basic management steps of women with jaundice. Now, role of vitamin K is very important. When PT is prolonged, water-soluble vitamin K in doses of 5 to 10 milligram per day is indicated. When PT is normal, vitamin K in low doses to be given only after careful counseling to the patient. Increased fecal fat excretion in these women can lead to deficiency of vitamin K, and that needs to be replaced. Usually, oral doses of vitamin K 10 milligram per day may reduce PPH and fetal and neonatal bleeding, and postpartum vitamin K must be administered to the baby in the usual way. Coming on to the obstetrical management, antenatal, confirm the gestation, strict maternal and fetal monitoring. If term, can induce the labor with all aseptic precaution. Symptomatic treatment is the choice, and treatment of cause if it is detected. Intrapartum period, we prefer doing non-touch technique, and that's what is the recommendation. Avoid unnecessarily PV examination. Normal delivery is preferred over cesarean section. Blood products availability is to be checked. Episiotomy or any unnecessarily incision should not be done. Careful instrumental delivery if necessary to support mother with full aseptic precaution. And strict post-operative monitoring is mandatory. LFT is repeatedly done because it takes time for the bilirubin to be normal. However, SGOT, SGPT, they come back to normal within a period of 2 to 3 weeks. Now, coming on to the specific management of common liver disorders, so I'm going to talk about very few which are important. We all know that hyperemesis gravidarum is unrelenting nausea and vomiting. And this is so much that a woman loses more than 5% of her weight, the pre-pregnancy weight. She's dehydrated. She has ketosis, alkalosis, and hypokalemia. Etiology is multifactorial. In some women, transient hepatic dysfunction develops. And in all, 50 to 60% of them are hospitalized, and there is some or the other changes in the renal as well as liver functions. And this is the score, which is called Pregnancy Unique Quantification Score of emesis and nausea. And this, if it goes high as 4 to 6, we say yet patient can be taken care of. But when it starts going beyond 12, it is severe, and this woman needs real treatment because she can end up with liver failure. So the treatment for hyperemesis gravidarum, again, it is supportive. We have to ensure that she doesn't go into dehydration and ketoacidosis. So, of course, the hydration and crystalloids and 5% dextrose is given so as to avoid any kind of ketosis. Glucocorticoids also are not very effective and not really recommended because of early pregnancy, but parenteral nutrition is necessary, and it is the last resort of the treatment. Coming on to intrahepatic cholestasis of pregnancy, this is also known as recurrent jaundice of pregnancy. In this, this is actually the most common liver disease in pregnancy, prevalence ranging from 0.3 to 5.6%. Again, the etiology is multifactorial because of high estrogen level, but there is some genetic predisposition, and basic pathology is decreased canalicular transport of bile acid and increased bile acid in plasma. So patient presents to you with severe pruritus, persistent, and typically it is in the palms and soles. Jaundice occurs in less than 25% of these cases. However, when it comes, it is a problematic situation. Investigations, if we do in these cases, bile acids are to be seen, which are more than 10 micromole per liter. ALT, ASTs increase as high as 200 to 300. And this is the differentiating point from active hepatitis. Bilirubin may be elevated 5 to 6 milligram per deciliter. ALP is increased 4 times than the normal. The first line of therapy is ursodeoxycholic acid, 10 to 15 milligram per kg maternal body weight. Pruritus can be controlled with fexofenadine, which has come up very good results, 120 milligram, or along with chlorpheniramine, 4 milligram. Local calamine lotions and all may help. Here, dexamethasone may be used, especially for promoting the lung maturity before delivery, and it has some effect on reducing the inflammation, which is because of intrahepatic cholestasis. Early delivery at 37 weeks is indicated. However, the first cutoff is 34 weeks, but we can pull the patient till 37 weeks. Beyond 37 weeks, one should not really. The third and most important is HELLP syndrome, which is characterized by hemolysis, elevated liver enzyme, and low platelet. All of us know this complicates merely 20% of severe preeclampsia and typically presents between 28 to 36 weeks. Generally, it is asymptomatic beyond certain gestation, but then, of course, it becomes symptomatic where, you have right upper quadrant pain, epigastric pain, and all the symptoms of preeclampsia. Mississippi's classification, all of us know, class 1, class 2, class 3. Class 1 is the one where we are really concerned because platelets are less than 50,000. And the bilirubin here increases, but it is not as high as what you see in other conditions. LDH is very high. Platelets significantly are low. Here, elevated liver enzymes are double than what they are, so more than 70 international units per liter. Now here, the treatment for HELLP syndrome is delivery. Only thing is that if the patient is more than 34, we always induce labor. But if it is less than 34, for a time, we do expectant management where we try to pull the patient to a level where the baby can also survive. People have tried steroids here. Steroids have helped slightly, but it is a controversy. It has a controversial role. And it may be very beneficial to the fetus, but not really to mother. So the treatment for HELLP syndrome is immediate delivery of the baby. Coming on to the last few reasons for jaundice, viral hepatitis is the most common liver disease which is encountered during pregnancy and the common cause of jaundice in tropical countries. There are various variety of viral hepatitis, A, B, C, D, E, G, HSV, EBV, and so on and so forth. But we are mainly talking about AB in particular. Clinical features of viral hepatitis are same: anorexia, nausea, vomiting, malaise, right upper quadrant pain, low-grade fever, jaundice, clay-colored stool, and so on and so forth. HAV is an acute infection which is associated with preterm labor and premature rupture of membrane, very clearly mentioned in the literature. Pregnant women presenting with acute hepatitis should be tested for HAV IgM, as vertical transmission of HAV has been reported. CDC recommends HAV immunoglobulin treatment for the neonate if the maternal HAV infection occurs within 2 weeks of delivery. Otherwise, treatment is supportive, as I told you. Now, HBV, chronic hepatitis B infection, is related to cirrhosis and hepatocellular carcinoma. Mother and child transmission of this particular virus remains an important source of incident. Active passive immunoprophylaxis of hepatitis B immunoglobulin and vaccination series should be administered to all infants born to the mother and to prevent perinatal transmission. But infants born to HBeAg positive mother are at much higher risk of mother-to-child transmission. Women chronically infected with this infection with high viral load should be offered antiviral medications such as tenofovir or telbutane, especially in third trimester, to reduce the transmission. Vaginal delivery is allowed yes, should be preferably held on. And the current WHO recommendation is that we can allow breastfeeding as no evidence of additional risk. HCV infection is now being seen in India quite commonly, which was really not there before, but now the many cases have been reported. It has little impact during pregnancy with minimal risk of either to mother or infant. However, it has higher risk of premature rupture of membrane and gestational diabetes. So vaginal delivery again here is allowed. In all these cases, we are going to prevent cesarean section as much as possible. There's no contraindication for breastfeeding, and interferon and ribavirin are contraindicated during pregnancy, but they can be given after delivery. HEV infection is most severe and may lead to fulminant hepatitis and hepatic failure. Pregnant women presenting with this acute hepatitis should have to be really taken care of, because these are the ones who are going to have liver failure, and they will be the one who will need liver transplantation. So here also treatment is supported. Diagnosis is surely made by viral markers. All these cases will have their viral markers positive. The bilirubin will be more than 15 milligram per deciliter. Dense jaundice will be there, and enzymes will be in thousands. So this is one very important way of diagnosing hepatitis. Management is supportive. Hospitalization in acute phase is mandatory. Rest, restriction of physical activity, high carbohydrate and low fat diet, IV dextrose, avoiding any hepatotoxic drug, and taking care of pruritus is the treatment. There are other reasons like sickle cell disease. Crisis has to be maintained. So this becomes a separate chapter on its own. We have to take care of sickle disease women, multidisciplinary approach, and ensuring that we give them enough hydration and symptomatic treatment. One of the major reasons of jaundice is acute fatty liver of pregnancy, which will be discussed by my colleague subsequently, so I am not going into it. And then coming on to my last two slides, there are hemangiomas, hyperplasias, hepatic adenomas, portal hypertension. These are also the reason for having jaundice. So if you have excluded the major causes of jaundice, you must think of these things, and this can be very well diagnosed in the sonography and subsequently the further investigations which are to be done. So friends, coming into the critical care management of liver disorder with jaundice in pregnancy, specifically when you talk in terms of liver cirrhosis, you talk in terms of hepatoma, multidisciplinary approach has to be there, because it's the hepatic physicians which are going to tell you how to go ahead with the further investigations beyond pregnancy once we have delivered the baby. So key point of my presentation today would be that prevention and treatment of hypertension and cerebral edema whenever there is critical condition, volume replacement. So these are a few basic things which we can do before we call the specific person. Volume replacement, if necessary, we can put central line. Here we have to give vasopressor support and ensure that there's enough renal perfusion. Avoid any kind of hepatotoxic drugs. That's first and most important thing, because there is infection and we tend to give several antibiotics which pass through liver and create further issue. Correcting the coagulopathy, maintaining adequate hemodynamics, doing ABG, CBC, LFT, KFT repeatedly to ensure that we are on the correct path. Correction of metabolic parameters like hypoglycemia, dysrectolemia, and then, of course, delivery of the baby after 34 weeks of pregnancy. So these are some very interesting, literature reviews where you can see liver disease in pregnancy, and not much has changed, but there are some drugs which have come up which can be used for jaundice, but as they are in the research stage, none of us are using it. But for our clinical knowledge, we can look into these literature. Finally, my take-home message is that jaundice is a common manifestation. It is not uncommon now as it used to be sometimes before. The management most of the time is symptomatic with treatment of the root cause. The major treatment modality is to avoid any hepatotoxic agent. Classify jaundice as per the cause is most important. Case deteriorates very fast, so immediate management is must, and critical cases need multi-speciality treatment. Thank you very much for your patience here.
Thank you, Dr. Poonam. It was a very crisp and precise information about all the types of liver diseases which usually happen during pregnancy. And I think cholestasis is the most common thing. And at one time, it is usually, sometimes it may lead to stillbirth also, but most of the time it has a benign course. So as you said, the diagnosis of the cause is really important. So thank you very much. Can we move on to the next speaker? Dr. Serena is our next speaker, and she will be talking about the acute fatty liver of pregnancy, which is another very dreadful condition, dreadful liver disease during pregnancy. So maybe have the CV of Dr. Serena.
Just a minute. We wanted to inform our speakers and the audience that we have 4,000 people who have registered for this web conference. So we are very happy that it has been reaching such a wide audience. Thank you so much to all the participants. It is a pleasure for everyone to be here, and we are learning a lot from all our esteemed speakers.
Yeah.
Thank you everyone for joining.
Dr. MC Patel sir and you all, the whole team.
No,
Really
it is all a teamwork. All of us have been working hard since so many days. Thank you so much. Please carry on.
Dr. Serena?
Yeah, is my presentation seen?
Okay, but we can't see the CV, so
no, it's okay. It's okay. Don't worry.
Okay, so you may start with your CV, the slide first.
Okay, I will. Can you see my presentation?
No, you start sharing this screen, Dr. Serena. Give us a minute. We'll introduce yourself. Give us the pleasure to introduce you. Just a second. We can introduce Serena ma'am.
Okay. Should I?
Yes, ma'am.
It's not actually clearly visible on my screen. If someone else, another chairperson, Dr.
Yeah, you want me to introduce Dr. Sudha?
Yeah, sure, ma'am. Sure, ma'am.
Yes.
Sure.
Dr. Serena is a she is a postgraduate teacher from 1994. She's presented various papers and publications. She has organized several conferences in vaginal surgery, ultrasonography, and an endoscopy. Currently, she is heading the Department of Obstetrics and Gynecology at Jubilee Mission Medical College and Hospital. And she was a president of Thrissur Obstetrics and Gynec Society in 2003 and 2004. And she was a scientific chairperson of All India Congress of OBGYN, which was held at Kochi. She has written many chapters at undergraduate and postgraduate level. She has got many awards to her credit. And she is going to be speaking on acute fatty liver of pregnancy, which is a most dreadful condition. So over to Dr. Serena, please.
Thank you.
Serena ma'am, you want me to share the presentation, or you would like to?
I'll share. I'll let me see whether I can do it, and then. Can you see it?
We can't see. We can see only you and not the presentation.
Okay. Then I don't know whether you should be sharing it. Can you see it now?
Yes.
Now we can see the presentation.
Okay, right.
Perfect.
Yes. Thank you all so much. At the onset, I should thank Dr. Patel. Sir, I think this is a mammoth webcom, and I think a lot of effort has gone behind it. And I really appreciate you and Dr. Alpesh Gandhi for organizing this, and wishing you all the very best in the upcoming election. respected chair, Dr. Arun, Dr. Pushpa, Dr. Sudha, and dear friends. The very fact that you have given me a standalone session on acute fatty liver tells you the importance of this particular condition, okay? This is a condition very unique to pregnancy, meaning to say you will not see it in any other condition except in pregnancy. It is an obstetric emergency, and that leads to fulminant hepatic failure. You know what you mean by the word hepatic failure? These three components are important for you to say that the patient has gone in for hepatic failure. When you find that the enzymes, the transaminases have gone up to huge values, when you find that there is presence of a hepatic encephalopathy and a coagulopathy. These are three important components. It's then that we say the patient has gone in for hepatic failure. And one condition which can give rise to hepatic failure, and you might even lose your patient, is acute fatty liver of pregnancy. Its incidence is about 1 in 6,700 and often always seen in the third trimester of pregnancy. We don't see it in the early part. Now, acute fatty liver, also called acute fatty metamorphosis or acute yellow atrophy, it has got so many names. It is something recurrence in subsequent pregnancy, though we say is uncommon, it can happen. It can happen. Something which really recurs is the intrahepatic cholestasis of pregnancy, but you can get a recurrence in a subsequent pregnancy, sometimes in acute fatty liver. Now, what exactly is it? It is actually associated with microvesicular fatty infiltration of the hepatocytes. Without, see, look at that word, without inflammation or necrosis. Because now when you take a condition like hepatitis, as Dr. Poonam was telling you all, when you got hepatitis, there is actually hepatocellular necrosis. So that is why you find the enzymes are raised to huge values. Whereas here, there is no inflammation and there is no necrosis. It's only microvesicular fatty infiltration of the hepatocytes. So because of that, you will find that the value of bilirubin is also not more than 10, and even your enzymes are not more than 1,000. But basically what you see that liver is small, soft, yellow, and greasy. As I told you, it often occurs in the third trimester of pregnancy and even a little later on, see 34, 37 weeks. That's the time that you normally get it. It's caused an autosomal recessive gene error, the maternal genetic mutation that affects the mitochondrial fatty acid oxidation pathway. And there is a deficiency of the fetal LCHAD, that is the long chain hydroxyl acyl coenzyme A dehydrogenase. So the fetus, in the fetus, there is a deficiency. So what happens? There is an excessive fetal fatty acid accumulation, which is released into the maternal circulation. So because of the fetus, that is why when as management, the most important thing, in fact, if you forget all what I'm going to tell you now, the minute you recognize acute fatty liver, terminate the pregnancy immediately. So because you know that it is the fetus who's the cause for this, okay? She releases that into the maternal circulation and then it gets deposited in the hepatocytes as microvesicular deposits. And then it leads to impaired hepatic function. Now, this pathophysiology is very important. See, the most important thing in the pathophysiology is the endothelial activation. Because of that, there is capillary leakage. Okay, so the capillary starts leaking in fluid. There is hemoconcentration. And because of that, so you don't really get only a liver disease. You would often see there's an acute kidney injury also in this. So there is an acute kidney injury, there's ascites, she can go for pulmonary edema. Rarely you do find conditions like diabetes insipidus, MI, fatty emboli of the lungs, and so on and so. So you can get a lot of associated conditions. Why? Because of the endothelial activation and the capillary leakage, which is a basic pathology in this condition. So there is severe hemoconcentration, there's a decreased uteroplacental perfusion, and that's why it goes in for a fetal death. So when you smell that the patient has got acute fatty liver, terminate the pregnancy. You will first lose the baby and next you might lose the mother also. So as I told you all, just remember this one word, terminate stat. Now, what are the symptoms? How do you suspect this? Normally, it develops over a few days to weeks. There is nausea and vomiting. Like any liver disease, these are the commonest things. Anorexia, lethargy, nausea, vomiting, epigastric pain, and then, of course, pruritus. Then ascites, because I told you, because of the leakage. And there is progressive jaundice, okay? And the diagnosis is really based on the clinical features. That is very important. And the second is on the labs. You really on imaging, you will not get anything very big. A hepatic imaging is not reliable in confirming AFLP, but it can remove the other differential diagnosis. Like supposing there is a hematoma subcapsular hematoma, or there's a rupture or things, or an infarction of the liver. All that can be excluded, but you cannot diagnose AFLP. So what is the clinical features and the labs? And the hepatic biopsy, normally it is not necessary, but rarely may be required. So, once I lost a patient, a twin pregnancy with acute fatty liver. And then in order to establish the diagnosis, we did a post-mortem liver biopsy. We did not do the full post-mortem, but we did a post-mortem liver biopsy. And what will you see in that? You'll find that the hallmark of this is in the liver. You'll find there's a microvesicular fatty infiltration of the liver that is most prominent in the hepatocytes surrounding the portal areas. And this microvesicular steatosis has a homogeneous appearance on microscopy. And you will not see it on normal hematoxylin eosin staining, but you will have to stain that tissue which you take from your biopsy with a fat on oil red or on electron microscopy. And when you fix it in glutaraldehyde, you will be able to diagnose a steatoric disease. They do not have the periportal hemorrhage and the sinusoidal fibrin deposition seen in preeclampsia and HELLP syndrome. That is periportal, okay? But often they are not, we don't have to differentiate really between acute fatty liver, preeclampsia, and HELLP. And how did I make such a big statement? Because in all these three conditions, you're going to terminate the pregnancy. So whether you diagnose it or not, you don't have to really differentiate it between preeclampsia, because in over 60% of these patients have also got evidence of preeclampsia. Okay, so as I told you all, terminate the pregnancy. The faster you terminate, if the cervix is not favorable, then you better do a section, but just terminate stat. So because I told you about the endothelial activation, you'll find that it's often associated with acute renal failure in 60%. So you might get your raised creat, etc. You'll get a hepatic encephalopathy, which I told you she is going in for a hepatic failure. I told you 3 components of hepatic failure, which is hepatic encephalopathy, raised very high liver enzymes, and a coagulopathy. All that you will get in a patient with acute fatty liver. And you can get preeclampsia hypertension in about 50%. So even in the most severe cases, that's very, very important. Even in the most severe cases, you will have a complete recovery of the liver and the function of the liver and the kidney after delivery. However badly it has been damaged, complete recovery is the rule. But don't take it to the extreme, okay, when there is an irreversible change. So as I told you all, you can get a lot of other associated conditions along with acute fatty liver. They can go in because they can go for a postpartum hemorrhage because of the coagulopathy. As I told you, 60% she can have renal failure, and hypoglycemia is a hallmark. Hypoglycemia, because the liver cells are not able to make the glycogen, and you'll find that there is severe hypoglycemia. Less than 72 is telling you that it could be an acute fatty liver. Then we check for DIC. First of all, you check the platelets. If the platelets are less than 1 lakh, then you check the fibrinogen. If the fibrinogen is less than 100, she's gone in for a coagulopathy. And that tells you there's hypofibrinogenemia. And I told you sometimes they can have diabetic insipidus, they can have pancreatitis in 20%, pulmonary edema. So there can be other associated conditions. But 3 important things I told you was acute fatty liver, preeclampsia, HELLP, etc., and the renal failure. In what type of people do you see it? Do you see it in the older maternal age group, primaries, multiple gestation like I had, preeclampsia? It's commonly seen in a male fetus, women who are underweight, and with the previous history, I told you sometimes it can recur. Now, this is a very, very important slide. I told you find out from the clinical features and the labs. Now, the serum transaminases, they're not very high. I told you there is no inflammation and necrosis, so you don't find it very raised. But whereas in a hepatitis, you get 6,000, 7,000, 10,000 SGOT, SGPT. The bilirubin, again, you said there you saw it's more than 15 milligrams, here it's always less than. These are 2 very, very important liver tests which you can do. Then there is leukocytosis, hypoglycemia, I told you just now. Check the ammonia. Ammonia levels will be raised more than 42. You'll find thrombocytopenia, neutrophilia, coagulopathy, renal dysfunction. Now you understand why I told you all this. Now, often you'll hear people say that this is the Swansea's criteria, which was devised by Shang. More than 6 out of these, all these which I'm telling you now, if you get more than 6, it's a diagnosis of acute fatty liver. But as somebody was telling me the other day, more than diagnosing, it will rule out acute fatty liver. So it has got a more negative predictive value than a positive predictive value. So if the patient's got pain, abdominal pain, vomiting, ascites, coagulopathy, I told you ammonia raised, bilirubin raised, but not more than 10. The serum urate could be encephalopathy, hypoglycemia less than 72, leukocytosis, microvascular steatosis on liver biopsy, polyuria, polydipsia, renal impairment when you find the creat raised. All this, if you get more than 6, if you can tick, that is called the Swansea's criteria for diagnosis of acute fatty liver. And what's the management? The hepatologist should be involved, the nephrologist should be involved, the anesthesiologist, the intensivist, and the obstetrician. Very, very important, because in case it becomes a medical legal problem later in the event of a maternal death, they will ask you, did you involve them in the management? Prompt delivery is a definitive management which stops the fatty load on the liver. Induction of labor is okay if you've got a favorable cervix. If not, if it is cesarean section, avoid regional anesthesia because, there could be a coagulopathy. And supportive management, correct the hypovolemia, the hypoglycemia, correct your coagulopathy. Just support the liver till you deliver the patient. Once you deliver, the crisis is half solved. Recovery seen in about 40 to 72 hours. Severe disease, it is associated with very high mortality. I remember when I was a PG, we used to say 90% mortality, but now it is not so much, comes down to about 20% mortality. Support the kidney. If required, you do a dialysis, support the liver. And now, though we say 10 to 20% mortality because of hepatic failure, renal failure, and coagulopathy. Mortality rates are lower in tertiary care centers. So if you suspect it and if you do not have the facilities, please transfer this patient early on. So you would have done all the investigations. Looking at that invite, you see not so raised enzymes, not so raised bilirubin, the hypoglycemia, the raised ammonia, etc. You know it could be a fatty liver in the 3rd trimester of pregnancy. And look at the perinatal mortality, 85%. The hepatic dysfunction completely resolves postpartum, even in the very ill and in the very sick in a few weeks. And in interim period, just give support. If they require ventilation, give mechanic. Blood products, give blood products. The dialysis, give dialysis. Antibiotics are important. Sepsis is very high in these patients. Hemorrhage is very high. Aspiration, renal failure, pancreatitis, and GI bleeds, etc. So they can actually go to different things and confuse you. So unless you think AFLP, you will not diagnose it. So some centers have even advocated a plasma exchange and even a liver transplant because I told you AFLP can go into liver failure and might require a liver transplant. So early diagnosis, you think AFLP and you will diagnose it. Prompt delivery are very imperative in minimizing maternal and fetal morbidity and mortality. Thank you.
Thank you, Dr. Sarina, for an excellent and very clear presentation on acute fatty liver disorders of pregnancy. Though it is rare, it's a very important because this disorder, there is very high neonatal mortality, but that includes even a maternal mortality also if it is not diagnosed well on time and not treated. And as what you say, the moment you suspect something, please transfer it to a tertiary care center where you have a multidisciplinary approach where patient can be handled much better as compared to a smaller center. Before I ask my co-chairpersons to say a few words, I would like to express my gratitude to Dr. MC Patel, the convener of today's program or chair in charge of today's program, along with scientific chair Dr. Alpesh Gandhi, and my best wishes to Dr. MC Patel for his future endeavor in POXI. Yeah.
Now, Dr. Patel, I also take this chance to wish you all the best.
Thank you, madam. Thank you. Thank you.
We would like to see you as President Foxy.
Thank you, madam. Thank you. Sarina, madam, thank you for accepting our invitation.
Thank you, sir.
Last time you couldn't join where you were at US, but this time you have made it possible.
Yeah.
Thank you for saying.
Thank you, sir. Thank you.
I think we can carry on with the next session. The please coordinators take over. Dr. Dhwani is there, I think. Thank you so much to all our chairpersons and the speakers. And I hope we'll maintain the time in the next 2 sessions also. Dr. Dhwani, are you there?
Can I start sharing the screen, Dr. Ritu? Yeah.
Oh
Yeah,
yes.
sure, sure, ma'am. Sure,
Sure,
ma'am.
ma'am. Sure. Hello.
So,
Till then, we will introduce the chairpersons, I think.
any Dhwani,
Yes, yes.
Charu, yes,
Yes, sir.
Dhwani has joined. Yes, fine.
Okay,
Yes, yes.
okay.
Thank
Fine.
you so
Please
much,
carry on.
MC Patel sir, for inviting me for the webinar. Thank you so much. My co-coordinator, Dr. Priya Gupta ma'am, is currently an emergency OP. That is why she's not available here. I would like to introduce the chairperson for the next session. That is Dr. Usha Nath ma'am. She's the medical director and chief consultant obstetrician and gynecologist at Nath Hospital, Ranchi. She's a senior colposcopist, Women's Cancer Prevention and Colposcopy Center. She's the past president, Ranchi Obstetrics. Hello. Hello. She's the past president of Ranchi Obstetrics and Gynec Society. Welcome, ma'am. Dr. Usha Nath, ma'am.
Yes, thank you.
Thank you,
For
ma'am.
thank you.
For the next chairperson, we have
I-
Dr. Sushma Chawla, ma'am. She's the consultant gynecologist, laparoscopist, hysteroscopist, colposcopist, and IVF expert, honorable professor at ICMCH, Chawla Nursing Home and Maternity Hospital at Punjab, India. She's the joint secretary, IMA Women Doctor Wing, founder, chapter secretary of IMS, and sorry, the screen is not yet visible for me. Welcome, ma'am. Dr. Vipul Kapadia sir is currently traveling, so he has sent his regards and won't be able to join. I request the chairperson to take over and introduce our speaker. Thank you so much.
Yes, may I introduce Dr. Ritu? Dr. Ritu Joshi.
Yes, ma'am, I'm here.
Yeah. Hello. A very good evening to all of you. It's a wonderful webinar, and I congratulate Dr. Patel and wish him the best for being the president next time with us. Wonderful sessions going on. So Dr. Ritu Joshi served as a faculty in various national and international conferences, organized conferences and workshops in obstetrics and gynecology, locally as well as on the national level, contributed various chapters in the books of obstetrics and gynecology.
I think enough, ma'am.
And today,
Let's start.
we're going to discuss about, since we have already talked about the
Thank you very much.
now it's your turn to talk about the kidney. Kindly go ahead with your thought, please.
Thank you, ma'am.
Yeah.
Can I start sharing the screen?
Yes, ma'am. Please go ahead, ma'am.
Actually, it's not coming only.
Technical support team.
Here,
Yeah.
Yes.
it is not sharing.
Ma'am, have you opened your PowerPoint presentation?
Yeah. No, I haven't opened it.
So if you open it, it'll be visible, ma'am.
Give me a minute, huh?
Yeah, please take your time.
But by the time she opens her screen, I think we all as obstetrician gynecologists look for the multi-specialty, and we must involve our medical specialists specialized in the specific field to treat. Then the others suggest. No doubt we should know everything about it.
Ritu, ma'am, you're muted, ma'am. If you can unmute yourself, we can hear you, Dr. Ritu. Yeah, could I request the technical team to please help madam?
I take
Mr.
this
Vasu?
opportunity.
Yeah, please, ma'am, please say. Go ahead, ma'am. Usha, ma'am, please.
I take this opportunity to thank Dr. M.C. Patel for such a nice webinar whole day on this very important topic. And I wish him good luck. And also I thank Dr. Alpesh Gandhi for organizing it in such a nice way. So thank you very much. I'm just waiting to hear about this renal disorder in pregnancy, which is very, very common And though it is easy to diagnose and treat, but if it is left untreated, it has got very big consequences. So thank you very much again. And
thank you, ma'am. It's an honor to have senior colleagues like you with us today.
I really am enjoying. Since morning I have joined, and I have been watching it, and it's really very interesting, I felt.
Ritu ma'am, you want me to share the presentation for you?
Thank you, go ahead.
Ritu, you are muted. Please unmute. Ritu, Dr. Ritu, you are muted. Please unmute.
Yeah,
Yes,
I'm
ma'am.
unmuted. I wonder.
Yes, now you
You
are
want me
audible.
to share the presentation?
Vasu?
Yes, ma'am.
Vasu, I put it off. Can you share it?
Yes.
Yes, now we can see it. Yeah. Kindly go ahead.
Are you doing that?
Yes, we can see
it.
Yeah, but I can't see.
Nani, your first slide is there on screen.
But I can't see.
I have shared the presentation for ma'am. I don't know. Ma'am, you are using mobile or a laptop?
No, I'm on the laptop.
I'm sharing your presentation actually.
I can just see Corona here. Yeah, now I can see that. Now, can you increase the font? Yes. The first slide, please. Can we get on to the first slide? So let's talk about a very interesting topic today. And before I start, I would like to thank Dr. Patel and Dr. Alpesh Gandhi for giving me this opportunity. Now, this is a very important and a very common problem which we come across in our day-to-day obstetric practice, and that is urinary tract infection during pregnancy. Next slide. It's a common complication, and it's seen in about 2 to 10% of cases. Usually it is because of the ascending infection from the vagina and the rectum. And the most common organism which we come across is E. coli. And whenever we see E. coli on us, the reports are all very scared about it. But also remember that the lactobacillus does not cause any urinary tract infection. The next slide, please. The next slide, please. It is also defined as the presence of at least 100,000 organisms per milliliter. Please, I think it's interfering a lot. 100,000 milliliter, it's interfering in urine and in asymptomatic women. So whenever the patient first time comes to us in pregnancy for an examination, we should always get her urine examination done, and with the other routine examination, and we find that there is presence of at least these organisms of 100,000. They are asymptomatic. It becomes an asymptomatic bacteriuria for us. And if it is pus cells, more than 7 white cells, blood cells seen, it is symptomatic. A diagnosis of UTI should be supported by a positive culture, and particularly in patients who have very vague symptoms. Next slide. Can we be quick in changing the slides? No, you've gone very far away. So the incidence, coming to the incidence, oh God, the incidence is around 8% in pregnant women. And in asymptomatic bacteriuria, the incidence is 2 to 5%. In acute cystitis, we find it is 1 to 1.3%, and in pyelonephritis, it is 2%. Next slide, please. Next slide. So we classify the urinary tract infections in pregnancy to be clinical and anatomical. And in the clinical, we have the asymptomatic and the symptomatic. We could also anatomically divide it into lower tract disease, which is asymptomatic bacteriuria and acute cystitis, or the upper tract disease is acute pyelonephritis. Next slide. So defining what asymptomatic bacteriuria means, it is persistent colonization of the urinary tract by significant numbers of bacteria in women without urinary symptoms. Acute cystitis is presence of symptoms such as dysuria, urgency, frequency, nocturia, hematuria, etc., with no evidence of any systemic illness. And in pyelonephritis, well, they have all the symptoms as well as the systemic illness, which could be in the form of flank or renal angle pain. They could have pyrexia, they could have rigors, nausea, and vomiting. Remember something here very clearly is that we come across asymptomatic bacteriuria very commonly, and we should not ignore this entity. Next slide. The risk factors for urinary tract infection in pregnancy is because of the mechanical obstruction, which the gravid uterus is pressing on the uretropelvic junction. It could lead to even urethral stenosis. There could be a functional obstruction, which I've already spoken about. It could also be because of systemic diseases like diabetes mellitus, which is very, very common. Next slide. The etiology of the urinary tract infection in pregnancy is because of the anatomical changes in pregnancy which have happened, the physiological changes of pregnancy. It could be hormonal because of the progesterone which causes relaxation. There is immunomodulation during pregnancy. That means the immunity of the patient is quite low. There could be a concomitant maternal disease where diabetes is one of the most common ones. And even if we've done a medical intervention during pregnancy of giving her an IV line again and again, or even putting in a Foley's catheter again and again. Next slide. So remembering all these etiology, we find that, next slide please. Vasu, next slide. What are the signs and symptoms which are very important? Now, the women usually in our practice, in our day-to-day OPD, come and complain to us that she's got increased frequency of urination. She has to get up at night again and again. Then she's passing small amount of urine, which is more frequent. She's not able to evacuate her bladder. So these are something which are very, very common signs and symptoms in which we should evaluate these women for that. Next slide. The changes, this slide depicts to us the changes which are there during pregnancy. And next slide. Let's look into the anatomic changes which is there. That the kidney size increases by almost 1 to 1.5 centimeters. The volume of the kidney increases by 30%, and the urinary collecting system is dilated. So we do sometimes come across physiological hydronephrosis, almost in 80% of pregnant women. Next slide. So these changes, we find that the ureters are dilated or hydroureter, especially on the right side. Kidney is more in increases in length and weight and all. On the right side, there's mechanical, hormonal, or there could be mechanical obstruction. All these lead to increased risk of urinary tract infection in these women. So what could be the changes that during pregnancy? Within the week of conception, we find that the GFR increases by 40 to 60%, which is very important because of the drugs which they will take will also depend upon elimination of them, depends upon the GFR. The total body weight water increases by 6 to 8 liters. There's volume expansion. There is also chances that until the middle third of the trimester, the creatinine production remains fortunately unchanged. Next slide. So here are the depiction of all the physiological changes which happen in pregnancy. Next slide, please. So there is 40 to 50% increase in the renal blood flow and the GFR, creatinine clearance also. There is decrease in the serum level of creatinine, urea, uric acid by 25%. The sodium and potassium levels, though maintained, but they can decrease. The fluid volume increases, and there is chronic loss of renal carbohydrates leading to increase in the metabolic acidosis. Next slide. These are all very important for us to know when we start treating our patients, and we consider all these factors when we are going to give them the antibiotics. There is glycosuria, there is proteinuria, there could be amino acid urea, and the water soluble vitamins of folate and vitamin B12. So there is excretion of these which is more. Next slide. And whenever we come across and we do a dipstick method for the proteins, always remember that if there is +1, we must take it into consideration that she might be having proteinuria. So increased clearance in a physiological decrease in circulating creatinine is there. I've already spoken about increase in protein excretion, and women at pre-existing proteinuria may exhibit an exaggeration of protein excretion in the 3rd trimester. Next slide. So what diagnostic evaluations we have to do about her? Number 1, we must take a detailed history. There should be a physical examination of whatever her complaints have been. A urine examination is very important, and as far as the urine examination, the collection of the urine, always remember, for your routine as well as for the culture and sensitivity, has to be a midstream urine. Please ask her to clean herself a little, dab herself dry, and then take, because at times even the vaginal discharges interfere with the urine examination results. We've got to get a CBC done, the blood culture, the urine routine culture, and the renal function test. Next slide. So the normal urine is a liquid byproduct of the body secreted by the kidneys. Physical and chemical characteristics are there, which I'll be taking up later. It is usually sterile till it reaches the distal urethra, and the anaerobic gram-negative rods and cocci are present routinely in it. Next slide. The composition of urine is 95%. It is water. Organically, it could have urea, urobilinogen, uric acid, creatinine, and the metabolites of the hormones. And inorganic, it could have anions and cations. The anions could be chlorides, bicarbonates, and the cations which commonly seen are sodium, potassium, and calcium. Next slide. And even ammonia at times. The color should be yellow, amber. It could be orange, red if there is hematuria. This usually it is odorless. Otherwise, it could be strong odor and fruity. A pH between 4.5 to 8. Now, density over here is very important. A lot of us don't look into the density. Density tells us about the osmolality of the urine, which is between 1.002 to 1.03. And the turbidity, usually it is clear, could be cloudy or turbid. Next slide, depending upon the presence of proteins. So the chemicals which are present there is glucose, proteins, urobilinogen, uric acid, creatinine, nitrites, and esterases. Next slide. And microscopically, when we examine a urine, there could be RBCs. We've got to look around for the leukocytes, the epithelial cells, the cast, and the crystals. Next slide. So what are the changes in the urinary system during pregnancy? We are very much now going through the previous slides, know that there's kidney enlargement, there's compression of the ureter and the bladder, there's incomplete emptying of the bladder, the urine is not acidic, and it contains more of sugar, proteins, and hormones. Next slide. So this is routinely there in pregnancy. The factors that actually act protective against the urinary tract infection is the acidic pH, the high osmolality, the high urea concentration, and the free antigrade flow through the urethral and the urethral valves. Next slide. The most common causative organism which we come across is the E. coli, and the other organisms could be group B streptococcus or the sexually transmitted gonorrheas, and chlamydia also is quite often being seen. Next slide. The urine culture. Now, when the culture report comes to us, you keep wondering what is MIC written against that. What does it mean? Basically, the MIC is minimum inhibitory concentration of that particular drug. Next slide. And so we come across this sensitivity of the so-and-so drug, let's say amoxicillin, it's highly sensitive, or it gives us a range of 15 to 17, which means that organisms inhibited by usual serum drug concentration by usual recommended doses. Intermediate mean organisms inhibited by maximum recommended doses, and resistance means that it's resistant to the achievable drug level, serum drug level. Next slide. So we actually choose the drugs according to that sensitivity. The factors which are favoring it is glycosuria, amino acid urea, which is physiological, and the fall in osmolalities. Next slide. And also the concomitant diseases present like diabetes, sickle cell disease, and renal transplant. We come across, because I'm working in a tertiary healthcare center, I come across, women with renal transplant who've had renal transplant and pregnancy. Next slide. So these are the various gram-positive bacteria. Next slide shows us the gram. Next slide, please. Shows us the gram-negative bacteria. So how do we manage these women who come to us? We have to, the first line management is that we should await for the culture report. We always tell increase fluids in your diet, increase your fluid intake. Basically, the nice guideline says that there's no recommendation for that, but she should not get dehydrated. So have adequate amount of fluids. Next slide. We also tell our women, very commonly these days to have cranberry juice, or there are a lot of capsules available in the market by as cranberry capsule, but the nice guideline says that there is no evidence of its benefit and no good quality evidence to show an effective management by its treatment, by taking that. Next slide. Also, the alkalizing agents, we always give them a lot of KOH solutions and all that, but that also according to the NICE guideline is not to be recommended. Benefits have not been established. Rather, in turn, it causes hypernatremia and the use of citrate in pregnancy. Next slide. So the advice people with lower UTI about drinking enough fluids to avoid dehydration, and beware that no evidence has been seen with cranberry products or the urine alkalizing agents. Next slide. So what are the antimicrobials we are going to give and what effect it has in pregnancy? There's an increased GFR, which we know. There's increased elimination of the rate of drugs. There's increased plasma volume. There's reduced drug concentration because of all that, and also reduced drug bioavailability at the target tissue. Next slide. So the most commonly used drugs are nitrofurantoin, cephalosporins, and amoxicillin. Next slide. The dosage of the nitrofurantoin which we can use is 50 to 100 milligrams twice daily. It does cause nausea, epigastric pain, and diarrhea. And it can cause hemolytic anemia, which is very, very rare. Next slide. I was initially very fond of using fosfomycin in most of my women coming in pregnancy with UTI. But the evidence says that fosfomycin did not offer any additional benefit other over the antibiotics and did not reduce the rate of adverse events or withdrawal from the treatment compared with other antibiotics. Very, very, very low to low quality evidence is there for its use. Next slide. So I usually stick to fosfomycin or the cephalosporins. The first choice of treatment with us is the antibiotics, which is nitrofurantoin. We could also give her amoxicillin if required. The second line of treatment is amoxicillin, which is there. We could add on with even the nitrofurantoin, which could be in the dosage of 500 milligrams 3 times a day for 7 days. And cephalexin also is a good quality, has good quality evidence. Alternative second choices is according to the culture report which we have got, and we must also consult our microbiologist of our hospital as to what culture report they've given and what did they find as we should use the drug. Next slide. A lot of hospitals, as I work in a tertiary center, we have an antibiogram which is given by the hospitals to us, and we get back to, with our reports, we do get back to our microbiologist to know exactly what the situation is. Next slide, please. Next slide. So this is a sort of microbiome which was given. Now let's deal with the complications. If not treated properly, it could lead to septicemia, renal abscess and scarring, preterm labor and delivery, increased perinatal mortality and morbidity, and even DIC at times. Next slide. There are some very important terms which we should know about, that when the types of UTI recurrences. Relapse means same organism within 2 to 3 weeks, secondary to already know the perennial colonizer or inadequate treatment. Reinfection is a new organism within 12 weeks, and superinfection is new organism by already on the treatment. So these are some things which we must know. Next slide. So to prevent the urinary tract infection, what should we do? We should have a perinatal screening for asymptomatic bacteriuria always. Drink a lot of fluids, urinate promptly. Women are very fond of holding the urine. I always tell them, increase your frequency of going to pass urine. Don't hold it for a long time, and avoid potential irritants. They are all very fond of using the sprays in the perineal region, and to keep the genital area clean and dry. Next slide. So this slide actually is the algorithm which tells us about how we must treat our women with urinary tract infection who are pregnant. Thank you very much. I think I just wanted to lay a stress upon what we should know about MIC, how to know what is the sensitivity, the resistance of the drugs, and how to use those. So we have only actually 3 drugs which we need to use during pregnancy with UTI, and that is nitrofurantoin, we have cephalosporins and amoxicillin. Thank you very much, Dr. Patel. And thank you, my coordinators, Priya and Dwani, and also my chairpersons, Dr. Usha Nath, Dr. Vipul Kapodia, and Dr. Shushma. Thank you very much.
Thank you very much, Dr. Vitu.
Thank you for that wonderful talk, ma'am. I would request the chairpersons to give their concluding remarks.
Yeah, I think it's a wonderful talk, and I think having more of fluids and nitrofurantoin has been a very long, for the last 50, 60 years, I think we've been using it, and very safe drug also. But I think a very important thing is the washing of the perineal area, the hygiene, which most of the ladies don't know. Washing from front to back. That is very important. Tell all my
dabbing themselves dry instead of using the tissue paper front and back.
So important, so important. Yeah. Thank you very much for a very lovely talk.
Thank you, ma'am. Thank you.
Dr. Usha, do you want to add something?
It was very nice, actually.
You,
I only, whatever Dr. Shushma said to that, I only want to add one. That when I was working in UK, it was very common to add this drink, which now it is shown that it doesn't have any effect. So that's what I wanted to add to it. It was a psychological relief, I suppose.
Thank you, ma'am. Thank you very much.
Thank you so much, ma'am. Moving on, I request the next speaker, Dr. Achint Vivekananda, sir.
Yes, madam. I'm Dr. Vivekananda. Thank you. Could you share my slides? It would be better.
Yes, sir. Yeah, I'll request the technical team to share your slides. And I would like to request... yeah, please. And I would request Dr. Usha Nath, ma'am, to please introduce the speaker, Dr. Achint Vivekananda. And the technical team, please take over with regard to the screen sharing.
Yes, I can introduce. He is Dean, Professor OBT by IMS. Karimnagar, awarded Distinguished Services Moral by the RCOG in London and in 2021 for excellence in women's health. Chaired NARCO and UNICEF session on ART in HIV positive women, drafted guidelines. In February 2010, he is awarded the best doctor for work in PLHS by the government of Andhra Pradesh in December 2011. So here is the chair for you. Thank you.
Thank you. First of all, at the outset, namaskar to MC Patel sir and Dr. Alpesh Gandhi. Both of them, I am grateful for giving me this opportunity, and to the coordinators and to the chairpersons. Could I have the first slide, please?
Yeah, Mr. Vasu, could you please share this? presentation?
Give me a minute, ma'am. Give me a minute.
Yeah,
I'll
okay,
just...
fine. Yeah, please.
Sure.
Ma'am, in the meantime, would Dr. Shushma Chawla like to add a few introductory remarks about the topic? Would you want to say something, ma'am? Ma'am, please unmute yourself, ma'am. Please unmute yourself.
Our very common things which I usually see in women while traveling, our hygiene, the using of commodes, less of water, the hygiene, hand washing, they're very simple things which are, lacking in our ladies. And even the girls are
Mr. Vasu, can I have the first slide?
Yes,
Next
sir.
one.
Yes, sir.
And before
Next one.
pregnancy, before getting married also, they got UTI. So I think these are the important things which maybe looked after at the school
Put it on
level.
the full screen, huh?
And
Yes, sir.
Dr. Vivekanand, are you ready?
Yeah, I can start my presentation, madam.
Yes, yes.
Yeah, today's topic is acute kidney injury. Now, this topic is very, very important in the clinical perspective for all OBGYNs because we need to have a multidisciplinary approach for this problem. And knowing the way to approach this problem can save a lot of maternal lives and also improve the maternal and the fetal outcome. Now, the latest terminology for this is pregnancy-associated kidney injury. So this is what is the latest terminology. Can I have the next slide, please? Next slide, next. First one. Yeah. So introducing this, 5 to 20% of all in the obstetric in the antenatal, they are complicated. High-risk pregnancies are complicated by acute kidney injury. This problem is very, very important for us to recognize the same and to take immediate corrective measures because it can occur in a woman with previously healthy kidneys. There is a rapid deterioration of the renal function. And if we cannot understand the physiology, pathology, and the clinical symptomatology, we will lose the patient. So it is very, very important for us to address many issues. Most of the AKI cases in OBG obstetrics are due to obstetric complications. So in that, hypertensive disorders take the big seat, that is preeclampsia, HELLP syndrome. These two take the big this thing. And then you have the spectrum of liver disorders also, like acute fatty liver complicating pregnancy, which can lead to hepatorenal failure. And then you have the issues of also the thrombotic thrombocytopenic purpura and hemolytic uremic syndrome, which are very important entities, especially in the postpartum period. You have the spectrum of abruptio placenta. You have the PPH. Because of the pre-renal condition, they can have a renal failure, and then sepsis, the most dreaded complication of any obstetrician, especially because of the rupture uterus, because of the septic abortion, and not to forget hyperemesis gravidarum. So if you see this whole spectrum of AKI, this covers all the trimesters and also the postpartum period. And this AKI has a significant maternal, fetal morbidity and mortality, and it is definitely preventable. Now, the prevalence of AKI in pregnancy in the studies overall throughout our country is 10%. And one more thing is now, because of the advent of nephrology and dialysis, this has significantly improved the maternal and the fetal outcome. So this is the brief introduction and the overview of this particular issue. Next one. Next slide. Yeah, I hope I am audible and the slides are visible. Thank you. Physiology. Yeah. Now, if you want to understand the clinical spectrum of AKI, just if you understand the physiology, because altered physiology is always pathology, which gives rise to the clinical spectrum. The size of the kidney is increased because of the vascular and interstitial volume. The dilatation of the renal pelvis is there, as you all know, in the second trimester. And all these changes, they regress after 6 to 12 weeks. So if you want to do an assessment of any case, after 6 to 12 weeks, you have to do an anatomical as well as a physiological assessment of these cases. The renal blood flow increases by 150%. there is dilatation of efferent and efferent arteriole. The glomerular filtration rate is increased from 40 to 50%. That is very significant. Because of the increased glomerular filtration rate, there is a drop in serum creatinine values. So whenever you want to take the lower cutoff for the serum creat, it should be 0.3 to 0.5 only. And because of these changes, most of these changes in the renal pelvis are due to progesterone, relaxin, and nitric oxide. So the thing to be noted is that because of the increased GFR, serum creatinine, the bar is reduced very much. Next one. Next one, please. Next slide. Yeah. The increased basement membrane pore of the glomerulus increases, and that causes physiological proteinuria. So the normal proteinuria is in pregnancy is 300 milligrams per 24 hours, and significant proteinuria, as you all know, is more than 300 milligrams per 24 hours. There is also increased renin-angiotensin and aldosterone activity, increased erythropoietin, and as I already alluded to you, serum creat, the lower cutoff is 0.4 to 0.5 mg per deciliter. So always it is better to assess the baseline proteinuria, especially if you are dealing with an already known case of CKD in the first trimester. If it comes to you, you should have a baseline proteinuria and then you reassess after her delivery. Then there is also a reduced bicarbonate level to combat respiratory alkalosis because of the progesterone, and that leads to the reduced osmolality. These are basically the physiological changes. Can I have the next slide? Yeah. Now the definition, see, there are many criteria. I just go through some of the very important criteria called Rifle and Akin criteria. Later, kidney disease using global outcomes released their criteria in 2012. So that will go with the Rifle criteria. Can I have the next slide, please? The Rifle criteria says that if there is 1.5 times raise of serum creatinine or 25% reduction in the GFR, or if the urinary output is reduced by 0.5 ml per kg per hour in 6 hours, it is considered as a risk. Then as the risk increases, there is a twofold rise in serum creatinine or a 50% reduction in the GFR, or the urine output is 0.5 per ml in 12 hours. This increases to threefold as the disease progresses, and then the loss of kidney function is seen in 4 weeks, and it can last for 3 months. So this is significant. It's based on serum creatinine, and it is also based on the urine output. 2 simple parameters. There is something obstructing my slide. Next slide, please. Next slide, please. There is a small modification called an Akin modification to this Rifle criteria, which is very simple for us. Serum creat more than 0.3 mg per deciliter, or increase of 1.5 times over the baseline, or oliguria for 6 hours. I think it is very simple and it is very easy for the clinician. Now, if you want to go to the etiology of very, very important slide, just put your attention to this. You can divide it into pre-renal. See, something is obstructing my slide, Mr. Vasu. Yeah, hyperemesis gravidarum and sepsis. These are the 2 conditions where you see a pre-renal etiology for acute kidney injury. Because of the hypovolemia in hyperemesis gravidarum, because of the sepsis in septic abortion, or it could be rupture uterus, or it could be puerperal sepsis. In these conditions, it is pre-renal. Now, even in a postpartum hemorrhage or abruptio placenta, when there is massive blood loss and the plasma volume is reduced, the renal perfusion is reduced, there is a pre-renal etiology. Now, if you go to the renal, so this renal, you will have the hypertensive disorders like preeclampsia, then intrauterine fetal death, which is very important, HELLP syndrome, interstitial nephritis, nephritis, then the spectrum of thrombotic microangiopathies like thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, AFLP, very important, lupus nephritis, acute pyelonephritis, something is obstructing, sir. Analgesic nephropathy, especially due to analgesia, and also contrast drugs used in the CT, blood transfusions, blood and blood products, and the drug aminoglycoside, which my previous speaker has already alluded to. So these are the if you see the whole spectrum, the renal causes are more. Then the post-renal causes is obstructive uropathy, which is very, very rare in today's setting. That is bilateral ligation of the ureters. It could be possible post-cesarean if there is more bleeding. So that is, or if there is a underlying obstruction already, the patient is suffering from obstructive uropathy because of the calculus. Now, pregnant women, as it is, according to a study, have a 60% more chance of developing AKI independent of age and comorbidities. That is very, very significant. Now, if you take the trimester wise, majority of them occur in the late third trimester and in the postpartum period, especially the hemolytic etiology ones. That is especially the hemolytic uremic syndrome, thrombotic thrombocytic purpura, and the HELLP syndrome. So what is important is to watch out the third trimester and the postpartum. Next one. Next one, please. Pregnancy outcomes in different studies reveal that 17 to 30% of all hospital deaths are due to AKI, which is very significant. Hypertensive disorders and HELLP contribute to increasing maternal and perinatal morbidity and mortality. And there is also an increased rate of increased CS rate, increased ICU stay. Yeah, could you put that again, please? Yeah. And reduced birth weight. So the maternal and the perinatal outcome are significantly, affected by the acute kidney injury. Next slide. Next slide, please. Now, how to evaluate? The most important thing I feel in the management of AKI in pregnancy is evaluation. So you should take a detailed history, especially drugs, especially analgesic drugs which are abused, or aminoglycoside. Both of them can be dose related, or it need not be dose related also. So drug induced is important. History of preeclampsia, you know very well. Sepsis, very important for you to take a history of any septic abortion or puerperal sepsis, or sometimes we do get cases of rupture uterus landing in sepsis and renal failure. Then hyperemesis gravidarium, yes, take a good history. Then you take a history of APH, antepartum hemorrhage, especially due to placenta previa, which may not be, we may be neglected. PPH, and then history is suggestive of SLE. This is very, very important because I work in a tertiary unit and we are seeing more cases of lupus nephritis. We have got a rheumatologist and a nephrologist also with us. More and more cases of lupus nephritis are coming now in complicating pregnancy and having a good pregnancy outcome. Then history of coagulopathies, history of intrauterine fetal death, patient having already a pre-existing CKD or chronic pyelonephritis. And very, very important is blood and blood products, which can give rise to transfusion induced not only lung but also renal failure. TRALI, you know very well. So patients should be, the next step after taking a good history will be investigation. A multidisciplinary approach is needed: obstetrician, internist, nephrologist, rheumatologist, and transfusion medicine. All of us should get together. Always rule out the thrombolytic hemolytic anemia, that especially hemolytic uremic syndrome and TTP, for which specific treatment is now available. I'll allude to it later. Can I have the next one? Investigation, please. Can I have the next one? Investigation. A full blood examination for hemoglobin and also evidence of histiocytes and acanthocytes, especially in HELLP syndrome, that is, and thrombotic thrombocytic purpura and hemolytic uremic syndrome. So this hemolysis is typical of these three conditions. And then you can see the thrombocytopenia. Creatinine and electrolytes is a must. LFT is a very important test. Then you have got LDH. LDH is a very important marker in pregnancy-associated hemolytic uremic syndrome, which is increased. Okay. And then ultrasound is important. And haptoglobin levels are also important in thrombotic thrombocytopenic purpura. Their zero haptoglobin levels are seen because of the hemolysis. And then we have got very important markers for lupus nephritis. Okay, so we'll go with that next. Next slide. Next slide. Proteinuria is important, especially in preeclampsia, HELLP, and lupus nephritis. So quantify the proteinuria in 24 hours. Coagulation profile. A renal ultrasound is very important to rule out the underlying chronic kidney disease where you see the cortical kidney damage and then the shrunken kidneys. So it's important. Then lupus nephritis, do an ANA, ENA, and double standard DNA, because lupus nephritis is very, very common nowadays. And complement levels, yes, very important, reduced in C3, C4 in lupus nephritis, and also in other hemolytic conditions. So complement levels, if you have got the facility, please do it. Then one more specific marker, I want all of you to understand, ADAMTS, which is less than 10% in thrombotic thrombocytopenic purpura. It is a specific marker, and it is related to the von Willebrand factor, and more than 10% in hemolytic uremic syndrome, HELLP and AFLP. So these investigations do help you to reach the diagnosis and manage the patient. Next one. Next one, please. Management is very important. The most important is the basic management is supportive measures to preserve the renal function. That is important. Specific treatment of the underlying condition and dialysis. So if you go to the first one, supportive measures, the most important is majority of these patients, especially our obstetric, they come in abruptio or they come in PPH or they come in preeclampsia. The volume replacement, especially if they are dealing with a pre-renal azotemia, is important to restore circulation and improve the placental perfusion, especially in hemorrhagic disorders like APH, PPH, abruption. So crystalloids are important, and albumin. You should never give a colloid like plasma expander are not indicated because it can initiate DIC. So 1 liter of crystalloid solution, especially ringer lactate, is better to combat shock and to increase the renal perfusion. Albumin, yes, you can give, and replace the blood and blood products. So give packed cells and give fresh frozen plasma in case you have got a coagulopathy, 150 ml per kg body weight. So very important for you to restore the circulation and renal function. And second important I want all of you to understand is prompt obstetric management in preeclampsia, eclampsia, HELLP and AFLP. So all of you know very clearly that the specific management of abruption or preeclampsia, eclampsia, HELLP and AFLP is delivery. So expedite the obstetric management, deliver the patient after you stabilize her, after the coagulopathy is stabilized. So once you deliver and the pathology is dealt with, then the patient will significantly improve. So prompt delivery is the most important thing. Can I have the next one? And the dialysis, third one. Now I just wanted to allude to a few this thing. HELLP with AKI. 36 to 50% of all preeclampsia land up with HELLP. Acute tubular necrosis is common, recovery is complete. Thrombotic microangiopathy, glomerular endotheliosis, nephrosclerosis have been noted histologically in HELLP syndrome. Acute cortical necrosis is the most feared complication because if the patient does not respond to our treatment, then they will not recover after 4 to 6 weeks. So these patients, dialysis is life-saving, and most of them, even though they may have prolonged dialysis, most of them recover 20 to 30% even after acute cortical necrosis. So HELLP syndrome is one very important where you can deliver the patient and prevent the acute kidney injury. Next one. Pregnancy-associated hemolytic uremic syndrome and thrombotic thrombocytic. These are two important conditions where you see the dysregulation of the complement system, especially in AHUS. It is seen in the postpartum. It can also be seen in preeclampsia, PPH, abruption, and sepsis. Now, a monoclonal antibody called eculizumab is useful, and plasma exchange is useful. Here you have got specifically LDH raised and ADAMTS high and low complement levels. So this is a very much treatable condition, especially in the postpartum condition if you diagnose it with the help of a nephrologist and a rheumatologist, and the patient can be saved. Next one. Thrombotic thrombocytopenic purpura is specifically a deficiency of AD-AMTS 13. The levels are less than 10%, occurs in pregnancy. Here, there is a relapse in the next pregnancy, can cause recurrent preeclampsia. Thrombocytopenia is more common and renal injury is milder. So the patient has a better prognosis in TTP. Plasma exchange is preferred, and you can, if the patient has a recurrent preeclampsia due to TTP, you can give her prophylactic aspirin. Yeah, next one. Can I see the slide better? Hello? Yeah. Renal replacement therapy or dialysis. What are the indications for dialysis? Very, very important for us to understand that if your patient is not responding to the routine conservative treatment, you have to hand it over to the nephrologist. When there is a volume overload, when there is a refractory hyperkalemia, when there is a metabolic acidosis, when there is uremia, when the creat levels are 3.5 to 5 mg, when the glomerular filtration rate is dropping below 20 ml, that is important. Peritoneal or hemodialysis can be life-saving. So dialysis now is a very simple modality. You can use the nephrologist for that, and peritoneal dialysis or hemodialysis depending on the choice of the nephrologist. So if you see the obstetric conditions again, you have got hyperemesis, you have got abruptio placenta, you have got PPH, you have got HELLP syndrome, you have got severe preeclampsia, eclampsia, sepsis. So many conditions, TTP, where you can take the help of our nephrologist and rheumatologist, especially also SLE. So hemodialysis, these are the conditions where you have to give hemodialysis or peritoneal dialysis, which will be life-saving. Next one. Long-term follow-up of these patients is very important. Follow-up from 6 to 12 weeks by relevant investigations. 6 to 10% may require dialysis even after 6 months. So assess the proteinuria and renal function periodically. There is increased risk of preeclampsia and adverse fetal outcome in subsequent pregnancies. So prophylactically, you can keep them on aspirin or even heparin also, doesn't matter. AKI in pregnancy is also a risk factor for future renal and cardiovascular disease and also end-stage renal disease. So it is a marker, in other words, for future complications. A meta-analysis of patients shows that 2.5% of the patients with pregnancy-associated kidney injury progressed to end-stage renal disease and needed dialysis. So this is a small percentage, and 74% of the patients recovered in a meta-analysis. So what is important for us to understand that if we have a multidisciplinary approach, we can improve the maternal and the fetal outcome. Next one. Take-home points to summarize my topic. AKI in pregnancy is very much preventable. So identify the high-risk cases in the antenatal period. Identify whether you are dealing with an obstetric complication or are you dealing with a pre-existing renal disease or a medical disorder or a connective tissue disorder like SLE, and do the appropriate management. Patients should be with underlying renal disease should be closely monitored. Manage sepsis, intrauterine fetal death, APH, PPH, preeclampsia, HELLP, and AFLP with established protocols. Very, very important. So you have an established protocols, at the same time individualize your case and then manage these conditions to prevent AKI. Optimal management of these conditions depends on the timing of the obstetric management. That is important. I always feel proud that we are an obstetrician. So the obstetric management is important. Timing of the obstetric management and appropriate interventions with the nephrology team and the multidisciplinary team. All cases with multidisciplinary approach in the ICUs only, not to be managed singly, as my previous speakers have already spoken. Next slide. I think I end my presentation. I thank, the organizers for giving me this opportunity and sharing my experiences. Thank you so much.
Thank you, Dr. Achal Vivekananda, sir, for that elaborative talk. I would like to thank the chairpersons, Dr. Usha and Dr. Shushma ma'am, for chairing the session, and also thank the coordinator, Dr. Dwani Rolekar, for her role in this. Moving on to the final session for today, which is cardio obstetrics. I now invite the coordinators for that session, Dr. Parth Shah and Dr. Havik Khatri, to please take over.
Hello, Dr. I would like to thank all the faculties, and it is very much informative sessions are going on. Thank you, Dr. MC Patel sir and Alpesh sir, to organize such a nice event. Hello, Dr. Bhavik. So, as we are quite late and it's the last hour of our last session of our event, we are going to start the session. I would like to invite Dr. Kirti Madam. Can I have Vasu? Can I have a slide of all the chairperson?
Yeah, please go ahead and introduce the chairperson. Yeah, Dr. Parth.
So I would like to invite all the three chairperson of our session. Dr. Prakash Bhatt sir. Sir is very senior gynecologist, and I can see here sir has already Uvara madam. Madam is practicing OBGY gynecologist, and she is secretary of Bihar OBGY Society. Dr. Abbas Singh madam from Delhi.
Next slide, please.
Very senior gynecologist from Delhi.
Yeah, I'm not able to open my video, but I think I'm audible.
Yes, ma'am, you're audible, ma'am. We will have Dr. Parth introduce you. So please go ahead, sir.
Yes. So I would like to invite all the chairpersons to chair the session, and they can introduce the next speaker.
Yeah, so I would request one of the chairpersons to please introduce the first speaker for today, Dr. Manjupuri ma'am, who will be talking on heart harmony, managing valvular disorders.
She's already there.
Yeah, please introduce the speaker, ma'am. One of the chairpersons could please do the honors.
Any of the chairperson available here?
Yes, sir, please go ahead, sir. Yes, sir, Dr. Prakash, please go ahead, sir.
It's a pleasure to introduce you, Madam Manjupuri. She is Director and Professor of Department of Obstetrics and Gynecology at the Lady Hardinge, the most prestigious institute. I remember when I was a student, one of our colleagues left for Lady Hardinge, and we all used to look at her with awe. That, yes, she is in Lady Hardinge. And Madam, you are the professor of that institute. Salute. Please go ahead with your presentation.
Thank you, Dr. Prakash. If I may share my screen, I'll start with my presentation. Is my screen visible?
Yes, ma'am, it's visible. Please make it full screen. Yes, ma'am, it's perfect.
So, my thanks to Dr. Patel and Dr. Alpesh Gandhi to have invited me for this marathon on high-risk obstetrics. So, this is the last session. So I'll be talking on managing valvular disorders in pregnancy. Now, we all know that 1 to 3% of all pregnancies have an underlying heart disease. And in developing countries, rheumatic heart disease continues to be a major cause of cardiac disease. Although we have a significant number of congenital heart disease also, which are now kind of, getting repaired and they become pregnant. In India, 69% of cardiac disease in pregnancy is due to RHD, and it's a range between 40 to 70% in different parts of India. Many cases are diagnosed for the first time in pregnancy, as pregnancy is usually the first contact of women with a healthcare provider. And physiological changes in pregnancy impose an additional burden on the heart. So all those who are asymptomatic might become symptomatic during pregnancy. Cardiac disease is also one of the leading indirect causes of maternal death worldwide, both in high, low, and middle income countries. And with valvular heart disease, the risk of complications vary according to the type and severity of underlying disease. We all know that stenotic lesions are less well tolerated in pregnancy, and especially the left stenotic lesions are not well tolerated in pregnancy. So what is the spectrum of valvular diseases? The most common etiology is found to be rheumatic. This is from a study from Patna, which I'm quoting. And mitral valve is involved in majority, 70% it is mitral valve, followed by aortic valve. And then, of course, tricuspid valve can be involved. Then mitral stenosis is the commonest lesion. We all know that a lot of changes take place during pregnancy.
the physiological changes, there is increase in heart rate, there is increase in plasma volume, the cardiac output increases, then the systemic vascular resistance decreases. Pregnancy per se is a hypercoagulable state, and the changes further get aggravated, the hemodynamic changes during labor and delivery. Because during labor, the patient is kind of exerting. So there is further increase in heart rate, stroke volume, cardiac output. And then in the third stage, there is, a back pressure. When the uterus contracts, the blood is pushed back into the circulation. So that is auto transfusion kind of thing happens. And the patient, the heart is unable, a diseased heart is unable to take up that load, and the patient can go into failure. And then also in the early postpartum period, the cardiac output again is more, that in the pre-labor condition. And it leads on to increased preload. And then the systemic vascular resistance now comes back to its normal. Initially it was decreased, so then it comes back to normal. So there's increase in afterload as well. And we must remember that the hypercoagulable state does not revert back immediately as soon as the baby is born. It stays for about 2 to 3 months. So the outline of my talk today would be to, address the initial evaluation and interventions prior to pregnancy, then look at the risk stratification of these women. Of course, risk stratification will be followed by counseling of these mothers to be for the increased risk involved in carrying a pregnancy, both maternal and fetal risk. And then management points during pregnancy, that is antenatal, intrapartum, and postnatal periods. So first of all, the initial evaluation, what should be the timing? The best is to have preconception, but unfortunately, most of our patients would come to us only when they are symptomatic. And, we would normally diagnose them during pregnancy. And, it is important that we should be able to identify all our cases at the registration visit. So that means that can happen only if we do a cardiovascular examination of these patients. And because most of the times it is mitral stenosis. So if we do not look at the pulse for tachycardia and auscultate the heart, we might miss out on the mid-diastolic murmur. The purpose of this initial evaluation is to assess the risk of the mother and the fetus. And the components of initial evaluation would be a detailed history of the disease, the treatment the patient has received, any surgical intervention she's gone through, and any hospitalization or any complications she's had in the past. Then a detailed physical examination. And of course, we must do some baseline investigations like do a X-ray chest, ECG, echocardiography, which is a very, very useful investigation. It will tell us about the number of valves which are involved, the type of involvement. Is it stenosis? Is it regurgitation? Is it prolapse? And then severity of valve involvement. Is it critical? Is it mild, moderate, severe? Then it also tells us about the size of the heart chambers, the functioning of the ventricles, ejection fraction, and also the presence of pulmonary hypertension. So all these points have to be looked up on echocardiography. It is followed by an assessment of functional status, that is also known as exercise test. We want to know how much, which class, NYHA class does the patient fall in. And of course, a review of the medications, especially those who have got valve replacement and those who are on anticoagulants. We need to review the medications and take a joint decision as to what would be the accepted anticoagulant regimen during pregnancy. So this is the New York Heart Association cardiac functional classification. So we all know class 1 is no limitation of physical activity. The patient is absolutely asymptomatic. The class 2 is there's slight limitation with ordinary activity. And when we say limitation, it is, symptoms. Fatigue, dyspnea, or angina are the symptoms which the patient can have with ordinary activity. Then marked limitation is when the symptoms come with less than ordinary activity, and class 4 would be symptoms at rest, and any physical activity would increase those symptoms. So looking at the interventions prior to pregnancy, we have balloon valvotomy, we have valve repair, and then we have valve replacement, which can be a bioprosthetic valve or a mechanical valve. So that is why a preconceptional counseling is very important, because any patient with a known RHD, we should get a cardiac evaluation, because the disease is progressive. So it is possible that the patient in a previous pregnancy may not have had that kind of a problem, but the condition might have worsened this time. So she should be evaluated by a cardiologist and also by an obstetrician. So patients needing valve intervention prior to pregnancy should receive a pre-pregnancy counseling by the cardiologist with expertise in managing patients with valvular heart disease during pregnancy. The reason being that in case the patient, one would like to go in for things like balloon valvotomy or a valve replacement with a bioprosthetic valve, so that the patient is not on anticoagulants while she becomes pregnant. But at the same time, we need to tell them that the life of the bioprosthetic valves is going to be lesser. So she might need another replacement. So that means that counseling has to go on, so that informed decision is taken by the patient. And valve repair is always preferred to valve replacement wherever possible prior to pregnancy, because if she's on anticoagulants, the risk to the mother and the baby is markedly increased. And women with moderate valvular disease and those who have undergone reparative surgery contemplating pregnancy should be counseled not to delay pregnancy, because as the time passes, after undergoing a repair or having a valve replacement, especially the bioprosthetic, the life of the valves also degenerate. So they should not unnecessarily delay the pregnancy. So that is also very important. Now, risk stratification is very important. So it is based on the history and investigations. And this would include general maternal cardiac risk factors. Then there could be risk factors which are, lesion specific, and also risk based on the coexisting comorbidities in the patient. Now, when we look at the general maternal cardiac risk factors, so these 5 factors are there, which predict a cardiac event during pregnancy. So more the number of factors you have, more are the chances that the patient is likely to have a cardiac event in the form of heart failure or a thromboembolic stroke or, TIA. So all these things are more common in the presence of these factors. So NYHA class 3 and 4, the risk is very high. History of any previous events like heart failure, transient ischemic attack, stroke, or arrhythmias, presence of cyanosis, then left heart obstruction, especially if the mitral valve is less than 2 square millimeter and aortic valve is less than 1.5 square millimeter, and or the peak left ventricle outflow gradient is 30 millimeter of mercury. So this actually more the gradient, more is the obstruction. So that is how we would take it. Of course, the ejection fraction, which we look at, if it is less than 40%, these are all high risk factors with the risk of cardiac event some more. Then lesion-specific factors would include the presence of mechanical valve, presence of pulmonary hypertension, so these are the things which will further complicate the prognosis. There are various scores which are given, CARPREG-2, Zahara, modified WHO classification, and lately Devi score. So these are the scores of these modified WHO classification is a well-validated method which can be used. So this classification system has, these 5 categories. So one is WHO1 category, which has mitral valve prolapse and then mild pulmonary stenosis. Here, there is no detectable risk of maternal mortality, and there is no or mild risk of morbidity. So this is pretty safe. In modified WHO2 category, we have mild MS and mild mitral regurgitation and aortic stenosis, and repaired TOF with moderate pulmonary stenosis or pulmonary regurgitation. So here also the risk is small of maternal mortality, but the morbidity, you have a moderate risk. Then in category 2 and 3, we have mild mitral stenosis, moderate aortic stenosis, and then bicuspid aortic valve with ascending aorta diameter of less than 45 millimeter. Here the risk is intermediate of maternal mortality and moderate to severe risk of morbidity. And when we move to category class 3, So this is when there is moderate mitral stenosis and there is severe asymptomatic aortic stenosis, asymptomatic but severe aortic stenosis, and then bicuspid aortic valve with ascending aortic diameter of 45 to 50 millimeter. So there's a significant increased risk of maternal mortality and severe morbidity. And in category 4, we have severe MS and severe symptomatic. In 3, we had asymptomatic aortic stenosis. Here we have symptomatic aortic stenosis, pulmonary arterial hypertension, ejection fraction of less than 30%, and bicuspid aortic valve with ascending aorta diameter of more than 50 millimeter. And all those who are in NYHA 3 or 4 category. So here there is extremely high risk of maternal mortality or severe morbidity. So the pregnancy is contraindicated in these patients. And in those in 3 and 2, they can undergo a reparative process before they, go in for a pregnancy. Looking at the maternal and fetal complications, in maternal complications, we've already listed that it could be heart failure, arrhythmias, thromboembolic complications, subacute bacterial endocarditis, then PPH, especially in those who have anticoagulants, and of course, maternal mortality can result. In fetal complications, there is a higher incidence of preterm births, small for gestational age babies. There could be embryopathy and intracranial hemorrhage in those who are on warfarin. That is what needs to be looked up. Congenital heart defects could be seen in those mothers who have congenital heart disease themselves. And then, of course, stillbirth can result. The next part is the counseling. So after we've done after the patient is classified as per modified WHO classification into whichever risk category, then the couple has to be counseled. They have to be explained about the risk involved, need for regular follow-up and monitoring with a multidisciplinary team. Also, they are counseled regarding change in medications, say ARBs and ACE inhibitors. In case they are on that, they have to be stopped or switched over to safer drugs. And warfarin also, depending upon what dosage she's on, if she's more than 5 milligram per day, then she will need to be switched over to low molecular weight heparin. So these alterations have to be done. And then for this, the patient has to be admitted, switch over of anticoagulants. Then she is to be referred for any preconception intervention after the risk assessment. And then appropriate contraceptive advice should be given if optimization is required. So if we refer her for preconception intervention, then we might as well give her a appropriate contraceptive advice. And I will touch upon the contraception in the postnatal part. Now, looking at the antenatal care, the aim is to keep the mother well compensated throughout the pregnancy. So what do we do for that? So the care is provided by a multidisciplinary team, early identification and prompt treatment of factors that predispose to heart failure. Because, especially in left-sided obstructive lesions, the patients do not tolerate tachycardia well. So things like anemia, infections, hypertension, arrhythmias, hyperthyroidism should be detected early and treated also aggressively. And then early identification and treatment of heart failure. So every time the patient, when we assess her, we must ask about symptoms of breathlessness, record her pulse, find out if she's got tachycardia, does she have tachypnea? So all those things, whether the JVP is raised, all those things have to be looked up. Then also auscultation of the chest for any creps, basal creps. Then careful monitoring for fetal growth, because we know that these patients do have a risk of small for gestational age. So we might have to do a fetal growth monitoring with the help of measuring the symphysiofundal height and doing serial ultrasounds. And also screening for congenital heart disease in the fetus, in case the mother is also suffering from congenital heart disease, by doing a fetal echo around 22 weeks. And all the patients who become pregnant with NYHA class 3 or class 4, we must offer them termination of pregnancy. But in case they want to continue or they are advanced, in that case, they have to be kept in the hospital. Whereas type class 1 and 2 can be managed on outpatient basis. A word about anticoagulation during pregnancy. So it has to be a shared decision, warfarin versus low molecular weight. We have the British, Hematological Society, which have come up with recent, guidelines. So according to that, discuss anticoagulation options, including risk and benefits to the mother and fetus, and need for strict compliance. The main important thing here is, poor compliance, which leads on to thromboembolism. And we all know that warfarin crosses the placenta, whereas low molecular weight and unfractionated heparin does not cross the placenta. So although it is said that anticoagulation during pregnancy with warfarin of less than or equal to 5 milligram daily, even in the first trimester, is okay, but then we are not too sure as far as the evidence goes whether it is going to be harmful or not. But of course, the recommendations say it can be given, and in case it is more than 5 milligram, in that case, the patient has to be switched over to low molecular weight, and the switchover has to be done in the hospital and done very carefully. We must start with higher doses of low molecular weight and then taper it, so that the patient does not have that in that window of switchover. The patient does not have is not predisposed to thromboembolism. So warfarin is superior to low molecular weight in preventing mitral valve thrombosis, in mechanical valve thrombosis in pregnancy, and recommended as optimal therapy for improving maternal outcomes. But the patient has to be told about that it crosses the warfarin, the placenta. So, we are not very sure about its effect. Then addition of low dose aspirin is something which should be done for all these patients. 75 milligram with low molecular weight is indicated in the absence of any contraindication. So this is a new thing. So, we must add, and those who are predisposed to preeclampsia, you can increase it to 150 milligram at 12 weeks. Now, the critical periods for decompensation are early pregnancy, and then between 28 to 32 weeks when maximum cardiac output is reached, then during labor and delivery, and then the immediate postpartum period for the first 48 to 72 hours when there is autotransfusion. So intrapartum care, the place where the patient has to be delivered has to be well-equipped and a well-manned center. You must have specialists there. The mode of delivery is spontaneous onset of labor with vaginal delivery is preferred in most cases, but of course you can induce them with Cervigel and even with misoprostol. Cesarean section is considered only in women with severe heart failure, that is NYHA class 3 or 4, high-risk aortic disease, severe pulmonary hypertension, and in women who are fully coagulated. So I'm saying they've been on warfarin in the last, the warfarin should be stopped for 2 weeks to allow them for a vaginal delivery. So stopped or switched over to a low molecular weight. You can't stop it, you switch them over to low molecular weight. But if warfarin has not been stopped for the last 2 weeks, in that case, she has to go for cesarean because the baby can have intracranial hemorrhage. The woman is encouraged to labor in propped up position or in left lateral position. She should be asked to be ambulatory. Careful monitoring of signs and symptoms of cardiac decompensation. We must monitor the pulse, the respiratory rate, saturation, the chest auscultation. Good pain management, epidural, and the second stage should be cut short with ventouse or forceps. We must restrict IV fluids and avoid methergin and prostaglandin F2 alpha. And of course, careful monitoring post-delivery is what is important. Now, in women with anticoagulants, we must discontinue warfarin at 36 weeks or 2 weeks prior to the scheduled delivery and switch them over to low molecular weight heparin or unfractionated heparin for rest of the pregnancy. Anticoagulation should be held on the day prior to the anticipated delivery. Aspirin is stopped at least 3 days prior to the scheduled delivery to prevent PPH. Unfractionated heparin can be restarted 6 hours after vaginal delivery or 12 hours after cesarean section in uncomplicated deliveries without a risk of PPH. And they are switched over to warfarin after 3 to 5 days after childbirth. Now, antibiotic prophylaxis, there's been a change. Routine antibiotic prophylaxis for most vaginal deliveries is not indicated unless there's a 3rd-degree perineal tear or something. Routine antibiotic prophylaxis before cesarean section is indicated as in any other woman. We must give up prophylactis within 30 to 60 minutes of incision. In high-risk women, before dental, oral, or upper respiratory tract procedures, it is indicated, not for the urinary ones like we used to give in the previous ones. But it is important that we maintain proper aseptic precautions, and unnecessary PVs should be avoided, and we must be very, very sure about our asepsis. So high-risk women, some people like to give, prophylaxis to these patients more liberally as compared to, even for vaginal delivery, they would consider. So this is a history of previous endocarditis, those who have prosthetic valves, those who have unrepaired cyanotic congenital heart disease, those who have repaired heart disease with residual shunt or regurgitation at the site of prosthetic patch or shunt. So these, it may be given, but generally it is not required. So the routine antibiotic prophylaxis which we give for cesareans, like it could be 2 gram ampicillin or cefazolin, 1 gram, or ceftriaxone 1 gram IV, single dose, 30 to 60 minutes before the procedure is recommended. In the postnatal care, careful monitoring, ambulation, hydration, and thromboprophylaxis, if required, even, without the, sorry, just a second. This is my last slide. Yeah. So even without the, if it is not indicated for the heart disease, otherwise also you must look up and then give it if it is required. And contraceptive advice and proper spacing. Here spacing is to tell them not to delay. If they want another baby, they should not delay it for a very long time, especially in those who have valve replacement. And even those who have disease otherwise, because the disease is progressive. So this is what is the recommendation as far as the Ministry of Health and Family Welfare 2022 guidelines are concerned. We have sent Chromin Saheli, which is category 1 for both complicated and uncomplicated valvular heart disease. And if you see for uncomplicated, everything is okay. IUCD, combined hormonal contraceptives, progesterone-only contraceptives, everything, implants, everything is okay. But for complicated ones, the combined hormonal contraceptives, COCs, are not indicated. They are contraindicated. IUCDs and implants can be given, and Chromin is category 1. So I think that is what. So we must try and give them LARCs, because we have to give them a reliable method. We don't want them to become pregnant unnecessarily. So my key messages are that valvular heart disease is an important cause of maternal mortality in low and middle income countries. Profound cardiovascular changes take place in pregnancy, which are well tolerated by a healthy heart, but can significantly compromise a woman with heart disease. And I've already told you those 4, times which we have to be very careful: early pregnancy, 7th, 8th month, in labor, immediately after delivery, and postpartum period. A careful CVS examination must be done for all pregnant women at registration visit to identify asymptomatic women with heart disease. Those with pre-existing valvular heart disease must be thoroughly evaluated preconceptionally by a multidisciplinary team for risk stratification, need for any interventions for optimization, review of drugs, and counseling regarding maternal and fetal risk, and need for regular and frequent antenatal visits. Remember that left-sided obstructed lesions like mitral valve lesions or aortic valve lesions are less tolerated than regurgitant and right-sided valvular lesions. But if the right-sided lesions are severe, then they would also have an adverse effect on the mortality and morbidity. Now, prosthetic valves pose unique challenges for the cardio-obstetric provider. Knowledge of anticoagulation options and risk of valve degeneration and complications are important. Labor, delivery, and early postpartum period are especially high-risk periods for these women with valvular heart disease, and careful multidisciplinary delivery planning and close postpartum follow-up are advised. Effective contraception must be provided to prevent unwanted pregnancy, and use of LARCs, postpartum IUCD, implants, etc. Are encouraged. And of course, we have our own Chromin, which can be given to them safely. And IUCD, whenever is inserted in these patients, you can give them an antibiotic cover. So thank you so much for patient hearing.
Thank you, ma'am. Thank you for that very effusive and informative talk. I request the chairpersons to please share a few concluding remarks about this topic. Dr. Prakash Bhatt sir or Dr. Abha Singh ma'am, would you like to?
Yeah, thank you, Dr. Manju. You've given a very elaborate talk, and you have touched all the points, starting from when to start seeing the patient, when to give this anticoagulation, the anticoagulation, the patient, when she conceives, she should not be on warfarin because there are more risk of warfarin embryopathy. So you have to put the patient on low molecular weight heparin, or then you can give a warfarin later on. So that is a very good message. Another thing is patients with Eisenmenger syndrome or with aortic wall problems, they are the ones who should undergo cesarean section, because chances of rupture of this aortic aneurysm are there. Otherwise, patients with heart disease should be allowed a vaginal delivery, and with careful monitoring and a multidisciplinary approach along with a cardiologist is required in these patients also. So thank you, and thank you, Dr. MC Patel, for inviting me, and Dr. Dr. Alpesh Gandhi for this beautiful webinar, the whole day webinar, really a conference.
Yeah, thank you so much, Dr. Manjupuri, ma'am. It's great meeting you, ma'am, on this platform after a long time. I think last we met was in AICOG. So thank you once again, ma'am. Moving on to the next, moving on to the next talk, which is Strength in Circumstance, Understanding Peripartum Cardiopathy. We have Dr. Krishna Kumari, ma'am, with us. I request Dr. Prakash Bhatt, sir, to please introduce ma'am.
Well, Madam Krishna Kumari.
It's okay, sir. Don't bother. Just, I think it's a pleasure meeting all of you all in AICOG.
Then I will
introduce myself as the scientific chair of AICOG 2024.
Everybody knows you.
Pleasure meeting all of
you. Yeah, you don't require an introduction, ma'am. You're familiar to all of us. It's nice to have you here today, ma'am.
So, very good evening to all of you. And at the outset, I would like to thank and congratulate Dr. MC Patel and the whole team. And thank you, Sujeshri, for this wonderful webinar today. I think it's covering all the topics of obstetric medicine. Can I share my screen? And I wish him all the best for the upcoming elections. Good luck, Dr. MC Patel. So, am I visible, audible?
Yes, ma'am. It's full screen and you're audible too, ma'am.
Just give 1 second. Oh, where did this key? Right. Okay. Now I hope I'm visible and audible.
Yes, ma'am.
My topic is on peripartum cardiomyopathy, and most important things I would like to impress upon the audience today is that to identify this problem, you need to have a high index of suspicion, and it's very important that you evaluate any heart any symptoms which suggestive of heart disease. And of course, the management is completely a team approach. And we should know the limitations of the management as well as our personal limitations when we are managing any symptoms. We do come across certain scenarios where we tend to miss out on the most important symptoms. So being aware of it this was a simple 20-year-old primey with 40 plus weeks of gestation who was admitted for induction of labor, has been treated for anemia and hyperthyroidism in pregnancy, and landed up in an emergency section due to fetal distress after induction of labor. So that was a very routine scenario which all of us come across in our day-to-day practice. On the first post-op day, suddenly the patient complained of acute chest pain and severe shortness of breath of NYHA classification, almost 3 to 4. And oxygen saturation was found to be 85% at room air. Her pulse rate was 102 per minute. Blood pressure was 110/80. And lungs on auscultation showed bilateral basal Krebs. So in the meantime, by the time we called the physician first, we just started with an ECG and which showed poor progression of V1 to V3 leads. And then they asked for a cardiologist opinion and who has done a 2D echo, which showed a dilated left atrium, left ventricle, moderate left ventricular dysfunction. Ejection fraction was 35%. There was moderate mitral regurgitation, mild tricuspid regurgitation, global left ventricular hypokinesia, and valeric ventricular pressure elevated to 40 millimeters of mercury. So the diagnosis was peripartum cardiomyopathy with pulmonary hypertension. So for any patient who is coming, suddenly we find them in such a case in the post-op ward or in the postnatal period, where the features are suggestive of acute cardiac decompensation. The immediate emphasis before you even look for a cardiologist and their coming, you should be prepared with the management of acute cardiac failure. So that is put a patient in the high dependency unit in a propped up position, give her supplemental oxygen, restrict her fluid intake, monitor the input output, administration of loop diuretics if there is no hypotension, for symptomatic relief. And most of these patients will recover with this conservative approach. But then the cardiologist will come, will evaluate, and suppose this patient requires inotropic support or are refractory to your regular measures, then shift the patient to the intensive cardiac unit. So what is this peripartum cardiomyopathy? I know that it is mostly a diagnosis of exclusion. It is a myocardial disorder of unknown cause associated with marked impairment of the left ventricular systolic function and development of heart failure, usually happening at the end of pregnancy, to be more precisely defined as the last 1 month of pregnancy and 5 months following delivery, although patients have been found a little earlier and a little late than that. And there is no pre-existing heart disease and there is no other identifiable cause of peripartum heart failure. So these then only call it as peripartum cardiomyopathy. So approximately 60% of the cases of cardiogenic shock during pregnancy or in early postpartum period can be attributed to peripartum cardiomyopathy. And 60 to 90% of these happen after delivery, most commonly in the first week after delivery. So in most of these 50%, the cardiac function will recover, but still the morbidity and mortality are high, and some patients may even need a left ventricular assist device or even cardiac transplantation. That is why awareness of this condition and management is very, very important. The most important pathogenesis was identified to be due to the hemodynamic changes, where there is a change when there is an increase in the preload. But then when they have seen the hemodynamic changes that are happening, like changes in the volume, cardiac stroke volume, the cardiac output and the cardiac mass, these happen much before the delivery, that is during pregnancy, and actually slowly come back to normal in the postpartum period. So there is a temporary discordance in what is happening as far as the physiological changes of pregnancy versus the etiology or the pathogenesis of PPCM. So the next reason what was found out was to be probably the toxic hormonal environment, which are by the hormones secreted by the pituitary and placenta, and they are synergizing with the intrinsic cardiac factors. And then some women who are susceptible will land up with these PPCM. And in the mouse model, it is supposedly the prolactin, which is now then cleaved to a breakdown product, which affects the cardiac vasculature. And this vasculature, in turn, they are triggering the ventricular systolic dysfunction. There are different reasons, by cardiac ischemia, by paracrine signaling, or the release of microRNAs and in the exosomes from the endothelial cells, which are affecting the cardiomyocytes, leading to their apoptosis. Also, we have many other secretions coming from the placenta. The syncytial trophoblasts produce glycoprotein hormones, growth hormones, MMPs, steroids, neuropeptides, senescence-associated secretory proteins, and like in preeclampsia, the soluble, the SFLT1, has also shown to trigger cardiovascular rarefication, leading to peripartum cardiomyopathy in mice. Other peptide hormones from the senescing placenta, including activin A, also contribute to cardiomyocyte dysfunction. So also the progesterone, which is increased late in pregnancy, suppresses the burning of carbohydrates by the heart, promotes cardiac hypertrophy, and have a direct negative inotropic effect. So all of these hormones are sensitizing the heart to further insults. So, but when so many women are getting affected by all these hormones, it's only some who are susceptible. This has been, they have tried to explain this through different sensitizing ways, but most of the time it remains unanswered. They suspect a strong genetic predisposition. 2/3 of these women are having a genetic variant in TTN, which is the gene that encodes the large sarcomeric protein that is a titin. Then others, it can be autoimmunity, microchimerism, or a pro-inflammatory state where there are increased cytokines like the TNF-alpha and interleukin-6. Myocarditis affected by some viruses as well as selenium deficiency. Although that's not very common in our country, it has all been thought of. So the biggest disadvantage is most of the time the symptoms are mirroring those of a pregnancy itself. So what are the symptoms which are more suggestive of heart failure? That is the paroxysmal nocturnal dyspnea, pedal edema, orthopnea, and dyspnea on exertion, dry cough, palpitation, increase in abdominal girth, lightheadedness, chest pain. Then when you're looking at the physical examination, there might be raised jugular-venous pressures, displaced apical pulse, third heart sounds more widely heard, MR murmurs, pulmonary rales. These are all suggestive of probable associated some cardiac disease. So whenever the symptoms are mild and the vital signs are normal, like heart rate less than 90, blood pressure systolic within 120 to 139, respiratory rate falls within 12 to 15, and oxygen saturation is more than 97%. With the physical examination findings being normal, you can be reassured. Not only the patient, you also need to be reassured. But when there is more moderate symptoms with including OSA, dyspnea, atypical chest pain, and repeated episodes of palpitation, fatigue, which is more severe, and the vital signs show an increase in heart rate from 90 above 90 to less than 120, or a systolic blood pressure somewhere between 140 to 159, respiratory rate between 16 to 25, oxygen saturation between 95 to 97%. But still the physical examination is not very suggestive. You can evaluate the patient in a non-emergent basis. But then if the patient is having a previous history of CVD or having severe symptoms or having vital signs where the heart rate is more than 120, systolic more than 160, respiratory rate more than 25, oxygen saturation less than 95%. And the physical examination shows JVP visible more than 2 centimeters above the clavicle with a loud systolic murmur, diastolic murmur, S4, wheezing, crackles, effusion, or marked pedal edema. Then it is time for an emergent evaluation and starting your treatment. So why are we worried? Because of both the maternal and to a lesser extent the fetal complications. Maternal complications can be thromboembolism, arrhythmias, progressive heart failure. You tend to misdiagnose it as preeclampsia, and the highly associated morbidity and long-term effects. Fetal complications are mostly because of hypoxia. How do we evaluate these patients? Initially, the evaluation consists of routine blood work where we look at excluding anemia, any electrolyte abnormalities, thyroid or renal or liver dysfunctions are first excluded. Then we also look for the anti-proben BNP. Although this is not well defined, the levels are not well defined in pregnancy. Anything less than 125, it is considered to be having a good predictive. So preferably it should be, of course, various values have been given 100, 125, but less than 125, it has a good negative predictive value. Then you look at the X-ray of the chest, which can show cardiomegaly and or pulmonary edema. So it may not be directly pointing towards PPCM, but you know that there can be heart failure. Again, ECG is non-specific. There can be sinus tachycardia, can be supraventricular tachycardia, occasionally ventricular tachycardias, STX segment and T-wave abnormalities, dilatation of the chambers, and also all these have been reported. But more specifically, QRS prolongation of more than 120 milliseconds was found to be associated with increased mortality when there was PPCM. So when we are looking, the diagnostic test is a 2D echo with a dilated left atrium, left ventricle, moderate left ventricular dysfunction, moderate mitral regurgitation, mild tricuspid regurgitation, global left ventricular hyperkinesia, elevated right ventricular pressure. So they come with a typical criteria, that is left ventricular ejection fraction below 45%, left ventricular fractional shortening below 28%, and a left ventricular diastolic dimension greater than 5.5 centimeters or greater than 2.7 centimeters per square meter. So the main study is echocardiogram. So it's not only it's the left ventricular ejection fraction, which is the key to rule out PPCM, and you have or other causes of heart failure. So, but other than that, you can also diagnose a left ventricular thrombus or atrial thrombus by looking at it. It is which are associated with dilation of the ventricles and atria. And if necessary, a cardiac MRI, cardiac catheterization in selected patients, and very, very rarely and usually not done for, usually done for myocarditis is an endomyocardial biopsy. So you have a whole list of differential diagnosis, which is identified by history, as well as the markers are usually by history or ECG or by your echocardiography. But most important of the multiple differential diagnosis, which are cannot be excluded by history, and is the most important is the hypertensive heart failure. Hypertensive heart failure is basically a diastolic dysfunction, unlike PPCM, which is a systolic dysfunction. So hypertensive preeclampsia can cause both hypertensive heart failure, or it also can cause PPCM. PPCM can be caused in patients with preeclampsia and also in patients where there is no preeclampsia. So I think these are some delicate points which we have to keep in our armamentarium. And like I said, it is a 2D echo, which is very typical in PPCM, that this is a diastolic disease, and it has a preserved left ventricular systolic function in heart failure, unlike PPCM. That is the way to diagnose it. And coming to PPCM, so it's the same as like any case of heart failure with left ventricular systolic dysfunction. Based on clinical status, the left ventricular ejection fraction, arrhythmias, recovery trajectory, pregnancy status, and whether the woman is breastfeeding or not. Based on these, you take a decision. And general goals are heart failure, goal-directed medical therapy with symptom relief, decrease the pulmonary congestion, and optimize the preload and afterload, hemodynamic support with inotropes and vasopressors if required. And if it is diagnosed intrapartum, you should optimize the patient before you plan her delivery, and if possible, then of course a multidisciplinary team which can plan labor, delivery, and postpartum care, and institute chronic therapies which improve the long-term outcomes. And decision making about contraception is very important, and education about future pregnancy risks again is very, very important. So beta blockers are contraindicated during breastfeeding because this is excreted in the breast milk. The carvedilol is a combined beta blocker with an additional alpha blockade effect that decreases the afterload. So useful in PPCM. So ventricular arrhythmias are again common with these patients. Sometimes a defibrillator may be indicated. So then in such cases, a temporary variable defibrillator is better because there is a reversal of the cardiac contractility can be recovered at a later stage, quite early. Hydralazine we can be used safely in pregnancy. NTG also can be used, which has the advantage of managing the afterload. In very ill patients, you can use inotropes like dobutamine, dopamine, and digoxin. When the inotropic and chronotropic effect both are necessary, especially when there is uncontrolled atrial fibrillation. There are newer drugs which are being used for heart failure with a reduced ejection fraction like sacubitril, valsartan, and sodium glucose cotransporter 2 inhibitors, but these have not been studied in pregnancies associated with peripartum cardiomyopathy. In acute cases, other than arrhythmia management, anticoagulation therapy, mechanical support, and therapies such as bromocriptine are being used. Anticoagulation therapy is controversial. So most of the time, because in left ventricular thrombus and thromboembolic events can occur in any behavior between 5 to 20% of these cases. So whenever there is a patient having acute intracardiac thrombus or evidence of systemic embolism, or she's having atrial fibrillation, or if she is on concomitant bromocriptine where there is an increased risk of thrombus formation, always better to use anticoagulation therapy, although there are different schools of thought on usage of this particular medicine. So also bromocriptine or antiprolactin therapy is again a controversial area, which is still being discussed with the European Society favoring and American Society not agreeing with the usage of bromocriptine routinely. So 2.5 milligrams once daily for at least 1 week in uncomplicated cases. And those where the LVF is less than 25% or the patient is in shock, you can give 2.5 milligrams twice daily for 2 weeks and then 2.5 milligrams once daily for 6 weeks. But just remember that this is a weak recommendation. Sometimes the patients are very unstable. First, most important is to stabilize the patient, especially if she is not yet delivered, and only deliver after she has been stabilized. And also, if there are any maternal cardiovascular indications, you have to deliver her. And patients with advanced heart failure, they need who are in the need of inotropic therapy or MCS or the mechanical devices, you may have to go ahead with the planned cesarean delivery with central neuraxial anesthesia. There is no role of cesarean section just for the sake of PPCM, but go with the obstetric indications. Only in unstable patients it is indicated when the patient is very ill. So the drugs which are contraindicated in pregnancy, the ACE inhibitors, the angiotensin 2 receptor blockers, angiotensin receptor neprilysin inhibitors, the sodium glucose luminal cotransporter 2 inhibitors, and mineralocorticoid receptor antagonists. Whereas those that can be used in the antenatal period are the diuretics, beta blockers. Diuretics, of course, we have a limitation, especially in preeclampsia patients. Beta blockers, hydralazine, nitrates, digoxin, and inotropes can be used in the antenatal period. So we all know that there can be a poor prognosis. The good prognosis factors are the small left ventricular diastolic dimension less than 5.5, LVF greater than 30 to 35%, and fractioning of shortening which is greater than 20%, the absence of troponin elevation, the absence of left ventricular thrombus, and ethnicity. Of course, we fall somewhere in between the blacks and the Caucasians, as far as ethnicity is concerned. The poor prognosis factors are QRS greater than 120 milliseconds, delayed diagnosis, the high NYHA class, multiparity, African descent, and a reduced right ventricular function, where you measure using only the fractional area change on echo or volumes on cardiac MRI. The next important thing that we have to remember is how to withdraw the medication. So the reasonable approach would be to wait for 1 year after the ECG changes, echo changes suggest recovery. And you don't withdraw all the medications at one time. You withdraw one medication at a time. Of course, it is with the cardiologist, but then one medication is withdrawn at a time. And in the meantime, you monitor the patient very closely. And you also have to look at the long-term clinical and echocardiographic monitoring of these patients. Sequelae, other than the high chances of recurrence that can happen in the next pregnancy, especially where there is a left ventricular ejection fraction is less, then the chances of the patient being affected in the next pregnancy is very high. Other than that, patients can also have cardiogenic shock where they need inotropes, temporary short and intermediate term mechanical circulatory supports like intra-aortic balloon counter pulsations, ECMO, and LVSS devices. Arrhythmias can happen, ventricular arrhythmias and cardiac arrest. And in one of the largest studies studied, it was 18.7% of these 9,841 hospitalizations, 18.7% had an arrhythmia. Ventricular tachycardia happened in 4.2% and cardiac arrest in 2.2%. Atrial fibrillation was seen in somewhere between 3 to 12%. And also, not only this, half of the women with peripartum cardiomyopathy may meet criteria for mental disorders such as depression or post-traumatic stress disorder. Death due to PPCM can also happen because of ventricular arrhythmias, progressive pump failure, sudden death, or thromboembolic events. So the prognostic factors being worse NYHA classification, LVF less than 25, Black, indigent status, multiparity, age greater than 30 to 35 years. And these women can also be associated with brain injury. So when the women had these major adverse events, it has been found that 1/3 of the patients had residual brain damage from a cerebrovascular accident or a cardiopulmonary arrest. Genetics, although there is no history suggestive of a familial history, still genetic counseling and testing should be considered because it can be also the first presentation of rare diseases like Duchenne's or Danon disease. And whenever you identify a pathogenic variant, you have to have a cascade testing of all the family members. The future directions, like I was telling you in the treatment, the two areas which need to be evaluated, still under evaluation, are the usage of bromocriptine and the randomized evaluation of bromocriptine in myocardial recovery therapy for PPCM, that is the REBIRTH trial, is going on, and it will be completed in 2026, where we'll have a more clearer idea about the role of bromocriptine. And the next most important point is when and how to withdraw medications once systolic function has recovered. These two are the areas where the intense work is going on. And of course, more specifically, the usage of drugs in pregnancy has to be further refined. So to conclude, the peripartum cardiomyopathy, first important thing is we have to see whether the patient is pregnant or is she breastfeeding. Then the next most important thing is she stable or unstable? If the patient is pregnant and stable, you can put her on beta blockers, loop diuretics, thiazide diuretics, vasodilators, and nitrates as per the, and with the activation of the whole multidisciplinary team, including most importantly the cardiologists, and of course go with the fetal viability with close surveillance and delivery planning. When the patient is unstable, again you have to leave it to the for the support hemodynamics and manage at a center with advanced heart failure support. So also if the patient is breastfeeding, there is again many people who are not in favor of breastfeeding because of the prolactin, which is supposed to increase the risk of PPCM. So if the patient wants to breastfeed, then you have to, and she's stable, then you have to again be sure of the medication you are using. Otherwise, you leave it to the cardiologist to go as per the guidelines directed medical therapy with the usage of even newer and other more effective drugs. Thank you all very much for the opportunity. And I think with this, we have ended a marathon session. It was the last batsman to bat.
True, ma'am, true. So we've come to the fag end of today's session, which has been a very informative session, and I'm sure all the delegates who logged in have benefited from it. So thank you, Dr. Krishna Kumari, ma'am, for that elaborative talk on peripartum cardiomyopathy. I request
Yes, this talk. Yes, I wanted to give that comment.
Please, Dr. Abha Singh, ma'am, please go ahead, ma'am. You can add to it.
Most welcome, Dr. Abha. It would be a pleasure hearing from you.
Yeah, I said you've given a very nice talk, and the etiology which we never knew, you have given lot of this thing hypothesis that it can be because of this, because of that. Earlier, we never used to see cardiomyopathy in our student days. Now we are seeing so many cardiomyopathies, and sometimes it is antenatal, sometimes postpartum. So this is a disease which has come into being, and it is all over the place in the antenatal period as well as in the postpartum period. So you have to be very careful. And you rightly said that auscultation should be done before that. And these patients with say preeclampsia, they are more prone to have all these problems. And this echocardiography, 2D echocardiography should be done to detect it. And if this thing is less, then the ejection fraction, left ventricular ejection fraction is less, then we should think more of this thing cardiomyopathy. And treatment, again, I've always emphasized, we have to have multidisciplinary approach. The cardiologists have to be involved from the very beginning, because we may not be able to diagnose and give the best treatment on our own. Even if we know the treatment, it is the best in the patient's this thing that we should have the cardiologist on our side.
And in emergencies, activate the code blue. Don't forget.
Yeah, if code blue
that is
is
really
available.
life-saving. Yeah, really life-saving.
Dr. Prakash, would you like to add anything, sir? Sir, unmute yourself, sir, please. Sir, please unmute yourself. Dr. Prakash, sir, please unmute yourself.
Okay.
Hello.
Yeah.
Yes, sir.
I just want to mention that we have Dr. Sushma Chawla and Dr. Usha, ma'am. They've stayed on throughout the session. So thank you, ma'am, for that, involvement. You've been there from the beginning to the end. Dr. Prakash, sir, we can hear you now. Would you like to add something, sir?
I just want to tell one thing, that these are the patients who sooner or later are going to need a heart transplant. A majority of them. So they have to be ready for that. I must have got by now at least 3 or 4 patients who are waiting for heart transplant, waiting for a appropriate heart to be available. And they have been delivered. And I thank Dr. Krishna Kumari for telling that these are the patients who need preferably delivered vaginally rather than cesarean section.
Thank you.
Thank you very much, Dr. Krishna
Thank you.
Kumari.
I thank the chairperson, and I thank the speakers, Dr. Manjupuri ma'am and Dr. Krishna Kumari ma'am, for that wonderful session, which was the last session for today. I request Dr. MC Patel, sir, to add a few remarks as we've come to the end of the session. Sir, unmute yourself, sir.
Sir, all the best. Dr. Patel, all the best.
Thank you, ma'am. Thank you on behalf of sir. I think sir's traveling.
अभी तो थे एक सेकंड पहले.
Yeah, worried. Sir?
I think sir will be just joining us for a few words
please, sir.
As soon as he gets connectivity.
So please say a few words, sir. Dr. MC Patel, sir.
Hello.
Yes, sir, you're audible.
We can
Please
hear
go
you,
ahead,
sir.
sir.
We can hear you.
Yes. Hello. Yes, sir.
Yes, we can see you.
We can hear you, sir.
We can see you also.
So please say a few words, sir.
So I thank all the faculties who have joined this mammoth WebCon. Guest of honor, Dr. Jaideep Malhotra and Dr. Jyoti Bindal madam, they have spared their time to bless the webinar, and all the faculty chairpersons, all the speakers, coordinators, and convener. I thank from bottom of my heart for all the supports and help extended to me in this webinar. I also extend thanks to Dr. Alpesh Gandhi also, who was scientific chair for this webcon. And I also thank all the delegates who have joined this webinar. And just, I think, shared by Dr. Charu also, more than 5,000 delegates have joined this webcon. It is success of all your supports, help, and cooperation. Thank you very much.
Thank you, sir. Thank you so much, sir.
Thank you, and
We
all the
wish you
best in your future endeavors.
All the best.
All the best, MC Patel sir.
Thank you, sir. Thank you so much. I will just say a formal vote of thanks because we are very really, so very, it was a big honor and a privilege to be a part of this conference. Huge success, I'm sure, with 5,000 delegates across the country and not just country. I noticed that it was even from USA, UK, and Greece people have logged on. So that is a big achievement, sir. And under your dynamic leadership and Dr. Alpesh Gandhi's very well-planned academic sessions, I'm sure we have all benefited a lot on a very wide array of topics, and the choice of speakers has been so good. All our esteemed faculty has shared so much good inputs and the newer latest developments also. We are very grateful to each one of them. Our guests of honor spared their precious time. Dr. Jaydeep Malhotra madam joined all the way, and Dr. Jyoti Bandal ma'am to give their blessings. Oration taken by Dr. Sanjay Gupta was an eye-opener on the latest developments in microbiomes and how we can probably think of preventing the pre-eclampsia in the long run. And I'm most grateful again. I will not take everyone's time now, since we have already gone quite late beyond the planned time. But our speakers have been absolutely excellent. Thank you so much from my heart. I'm also most thankful to our hardworking team of coordinators who have managed very smoothly all the sessions, in spite of some people getting busy, as doctors usually do. Gynecologists have to run for cesareans in between. But I am sure the sessions went off pretty smoothly. And even my co-conveners have been very helpful to join in whenever time permitted them, and the sessions have gone on smoothly. I'm grateful to our technical team from Corona also. Mr. Vasu, Mr. Rahul have been there throughout the whole day and taking care of the technical aspects. Thank you so much. Most helpful. And at a short notice, this whole conference was planned. So I think it has worked out to be very successful for every one of us. And I would like to end with heartiest best wishes to our Dr. MC Patel, sir. I believe he's a very inclusive leader. He carries along everyone with him, whether senior or junior, and makes everyone feel involved. And I think our ultimate goal is to serve the women of our country, for which we are all working hard. Our best wishes, sir, for the upcoming election. And thank you so much to everyone. Thank you for joining. I would like to end now. Okay.
Thank you, Charu ma'am, for giving us this opportunity and helping us in executing this whole program smoothly, seamlessly, without any interruption, and with a great support and great coordination. And undoubtedly, MC Patel sir and Alpesh sir has created a very good event. The topic itself is so excited, and the topic itself has given a enthu for so many delegates to join for this program, today's program. And the esteemed faculty made the program enlightening with their expertise and knowledge. And from Team Corona, we are so grateful for giving us this opportunity to organize this kind of full-day national web conference. And definitely it is a game changer approach from the typical 1 hour webinar kind of this thing. It is a focused event, and but the doctors, those who want to learn and enrich their knowledge, so without joining for even a big event, but this kind of national web conference or platform is helping them with a great knowledge. Thank you so much, MC Patel sir.
And
thank you once again, sir.
My deep sense of gratitude to Corona people and Vasu in particular for helping me as far as this academic support is concerned and technical support is concerned. Thank you, Vasu.
We are always with you, sir. Always with you.
Alpesh bhai is also there.
Okay.
Alpesh sir.
Thank you, sir. Thank you.
So thank you all.
Thank you so much, sir. Thank you.
Wishing you a safe journey, sir, and all the best, sir.
Thank you.
Thank you.
Thank you.
Thank
Good
you.
night, sir. Good night.